तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः 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 शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जगत् दीपज्योतिर्परब्रह्म दीपज्योतिर्जगत् मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुराव्यम् ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुराव्यम् देहि पुत्रांश पतिं स्वच्छामि मे सदा रवेरस्तं समाधिं यावत् सूर्योदयः रवेरस्तं समाधिं यावत् सूर्योदयः यस्य कृष्णे गृहे दीपः तस्य नास्ति दरिद्रता.
Can I request Professor Siddharth Ghosh to say a few words, and then Professor Bihari, please.
Good morning, everybody. On behalf of 7th Walter Reed Andy Neurosurgical Society, I welcome you all. This is the 7th, actually it's the 9th year we were doing this educational program. But 2 years because of the COVID, we couldn't do it. So this is the 7th session. We particularly concentrate on the educational aspect of the young neurosurgeons and also the final year and 4th year students. This year, our selection of date was a little, I think it was not correct because we were not aware that the DNB exam is coming on 15th of May. So a lot of final year students couldn't come. Actually, they were very much interested because they come on every year that they couldn't come. So I'm sure that's why I think our number of participants from the students' point of view will be less. Nevertheless, since we have been doing it every year and this year, because of some other logistic reason, we couldn't do it in the month of Jan. Normally we do it in January. So we had to do it in April. And we chose this part of the country because this is the, eastern and northeastern part of India was, we have never done it. We tried in Kaziranga during in 2019, but because of this CA and NRC, that time it was going on in Assam, so we had to withdraw it. So that is the reason this year we thought because of the climatic condition also this time it would be little cooler in Shillong, we selected this place. And also I'm sure a lot of us have not visited this part of the country. Even myself being from Calcutta, I've never come to this part of the country. So this is a good, I thought the people can have the educational program as well as in the evening they can spend some time going around the city, if whatever there, something the local people might help you to see what are the things to be seen. I have arranged the educational program in such a way that it covers most of important topics, and we have nevertheless all the stalwarts in the country who are the best, not only in the country but also in the world. They are renowned in worldwide for their work. So I am sure the students and even we will get benefited by their talk. So this year, most of the faculties we have invited have agreed, but at the last moment, 4 or 5 of them, because of their personal reason, couldn't come. So we had to ultimately do it as an hybrid thing. All of them have agreed to come online and give it. Professor B.K. Misra is gotten suddenly an urgent meeting, WFNS meeting in Prague. So he had to go. So it came only, he just came to know suddenly. He called me and said because it was some emergency meeting apparently. So like that, a few of them, Dr. Dharakanath, did not get leave because the institution didn't give him leave because this is the holiday season. So like that, few of the faculties could not come, but they have agreed that they will be online, and we have sent them the link. And I'm sure nowadays, because of this, Zoom facilities, it is as good as having the personal presence. So I'm sure all of you will be greatly benefited by this conference which we organize, and I'm sure we'll get more of the students. We also have arranged this like every year, the microsurgical workshop, the microvascular anastomosis, which we are doing, and Professor Andre from Spain, he comes from every year. He came last year, he has taken the burden to come all the way here to teach the students. And last time, every student was so much benefited with his training that he gave. And this year also we have an unique thing which Professor Manjul Tripathi actually gave. We had discussed with him, and he gave this idea of hosting this, having the stereotaxy workshop. Along with that, using the, gamma knife, which I am sure will be the first in the country. People, even the neurosurgeons who are not well versed with the techniques of the gamma knife, and there will be a workshop, and it will also be telecasted from Australia. And Dr. Manjul has taken a lot of trouble, and along with that we have Dr. Shankar from Chennai. He also is purely involved in stereotactic radiosurgery using cyber knife. So we'll have both the gamma knife and cyber knife facilities, and the people, all the doctors, delegates who have not been exposed to this cyber knife and gamma knife, they can definitely be benefited by having this training. So we have started that simultaneously. We have both will go parallelly. So that we have selected the batches, whoever is interested in whichever workshop they can join in. With that, we'll start our session. I'll ask Professor Sanjay Bihari to come and give a few talks. Thank you.
Good morning. It's a privilege and honor for me to be here. First of all, I'd like to tell you why Walter Dandy. The focus of why the society's name was Walter Dandy, and it's basically because this particular neurosurgeon concentrated on the techniques of surgery and how you could make the ergonomics of the operation theater better for the patients. That's the first thing. The second thing is this idea was conceptualized by Professor Salim Abdul Rauf, And it's, I think, now all over the world where lots of youngsters come and listen to the experienced people in the field regarding the operative techniques. That's the second point. The third point is that this has actually become a revolution, because when we started this about 9 years ago, we didn't expect this to kind of become so popular. And there were lots of people who said, well, this will not work. There's so many other societies going. But the unique concept of having um, only video lectures talking about operative techniques is something which has become very popular. And there are two people I'd like to really thank. It's almost like a thankless job, but on behalf of all of us in India, I'd like to thank Professor Siddharth Ghosh, uh, who actually has organized such a wonderful event, and single-handedly, he's a private practitioner, very busy private practitioner, and for him to organize everything without a lot of help, I think is a real important contribution to the Indian education. And I think we need to give him a big round of applause. The second very silent person who has been a focus of education in the entire country, and not many people know about him, is Dr. Anil Pandey. And I mean, from publishing textbooks to organizing an operative workshop, which has gone on for nearly 27 years, even before all AIMS and SGPGI and PGI workshops were being held, I think is Dr. Anil Pandey. And I think we also need to give him a big round of applause for what he's done. There are 3 points I'd like to mention here. The first of them is these operative workshops, which are very innovative, one on the revascularization and on stereotactic radiosurgery. I mean, this is an endeavor to make you understand that there is a huge difference in neurosurgery now. It's no longer confined to, doing a macho operative work and all that. There are several techniques which have come up. And there are several fields in which each one of you can specialize. So my request to all of you is that each one of you, apart from whatever you have learned in your training, every year should also focus on things which you have never learned in your training. Develop these techniques, take them forwards, and then teach them to your youngsters. The important thing is there is an equilibrium which is established. First of all, we are at the lower end of the energy. We learn from others. We learn from the energy of others. Then an equilibrium is reached where both of us, the teacher and the taught, are at the same equilibrium. And then the taught becomes the teacher and the teacher becomes the taught. So you must understand the circle of life and this equilibrium. And based on that, you need to really focus on whatever you have done. So I wish this conference a lot of success, and I thank all of you from coming from your busy schedules, and your participation here is what makes this a huge success. Thank you very much.
Since we still have a few minutes, Manjul, please, 2 minutes of your idea for me.
Good morning, sir, and good morning, everyone, in this serene city and on a beautiful morning. I sincerely thank Professor Pandey and Professor Ghosh for giving me this opportunity. As Bihari sir just told, it's now a parallel world. Radiosurgery, we are having the first stereotactic radiosurgery workshop today. And this is a unique one in a way because we have arranged an online training right now in which the master planners are with you on different indications, which we treat with the stereotactic radiosurgery with gamma knife. And you can come with your laptops. We'll give you an access, and the planners, myself, and the Electa team would be there to guide you how to make a plan and what's the usual workflow with the stereotactic radiosurgery procedure. This is the first of its kind which we are planning. We have planned for this time, so kindly utilize this opportunity, learn with it, and I would be very happy to assist you wherever you find any difficulty or you have any question with that. And it's running from 9:30 till 5 p.m. till the whole conference, and it's a 2 hours workshop. So whatever the time slot you find yourself suitable, please come, and I'll be very happy to assist you there. Thank you so much.
So we will request the first speaker, I hope they have loaded their things so that we start immaculately at 9 sharp so that the sessions go on. Request to all the participants, young neurosurgeons and neurosurgeons in training, please try to make use of this, because I don't know whether you understand, this is probably the only conference in the world where the faculty itself is about 45, 50. So the effort which goes to bring this many neurosurgeons of repute, we thank each one of them for having the time to come, is to make sure that each one of you get exposed to the surgical hands of different institutions. It's a very, very important thing, and probably this has to be really done because we learn from our mentors, but we must learn from other people also. So saying that, I think if everything is ready, so we would request you all to be there. Please make use of both the workshop. If you have not registered, register that so that, and you will have enough time with the microvascular anastomosis. And Dr. Gayavani is a genius, so please learn from him. Thank you.
No, Professor Salim, who is the founder of this Walter E. Dandy's Neurosurgical Society, he couldn't come this year because he has a simultaneous assignment in Kazakhstan. He's giving a keynote address to some Nobel laureate they've arranged, and he's right now he just now called me. He was supposed to be online to give the inaugural talk, but because of the weak signal, he's not getting it. So I think he would come sometime and we'll put him online that time. Professor Goel just now called me that he's still, I think the flight got delayed and he'll be a little late. He's just leaving Guwahati. So I'm sure he would not be able to be there for the first talk, and we'll organize him for the later on. So we'll start our sessions now. Thank you.
Joshita is a biomechanical engineer, and she's pursuing her PhD in neuroscience. She's interning with us at VHS. So she and Dr. Pretty will be doing the work, because we realized that getting, an event person to do it was not fitting in with the academic traditions. So we have got two professionals, and they will take us through this program.
Thank you, sir. We are now opening with our first session of the day on glioma, which will be moderated by Professor Sandip Chatterjee. And before we begin, a kind reminder to all the speakers to adhere to the time slots. And now I invite Professor Abhida Shah and Professor Sukhdeep Java to take us through the 3D surgical anatomy of motor cortex. Kindly wear your 3D goggles, which are placed on your seats.
Small correction. Professor Behari will be the moderator for the session.
So I welcome all the faculty and delegates to this wonderful opportunity and this unique conference in a beautiful location. First time here in the Northeast. I think all of you will enjoy this academic feast. While we are setting with the 3D, all of you who don't have 3D classes, just ask from the person, because this is a 3D presentation. You will enjoy the depth of anatomy, all the pictures, all this dissection is done personally by us, and you should enjoy. And all the anatomy topics we have put before the concerned section, Like now we are talking about glioma, so she will tell about the glioma anatomy, then cavernous sinus. So you will know the first the anatomy, then the surgical techniques, and then of course we have a discussion on the topic.
So let's start with the first topic of the day. And we are starting with intraaxial brain surgery. And this structure that you see here, can we shut off all the lights? So this magnificent structure that you see here is the human brain, and it holds so many mysteries. And let's start unraveling. We've not understood quite a lot of the human brain still, and we'll try to unravel some mysteries now with this presentation. So you can see this, the human brain resting on the skull base, the anterior and the middle cranial fossa. And the first topic today is we are going to discuss the motor strip and the insular cortex and insular lobe. So if you see, the human brain is actually divided into the human brain is divided into actually 7 lobes. So this one here is the central sulcus. This one is the precentral sulcus. So the lobe in front of the precentral sulcus is the frontal lobe. The lobe behind the postcentral sulcus is the parietal lobe. This one here, this ellipsoid in between is the central lobe. Then here you have the temporal lobe. Then there is an imaginary line going from the preoccipital notch to the parieto-occipital sulcus. So behind that is the occipital lobe. Inside, hidden here, is the insular lobe. And on the medial surface, you have the limbic lobe. So now looking at this from superiorly, you see this one here is the central sulcus. This one behind here, this is the precentral gyrus. And this is the superior, middle, and inferior frontal gyri as they meet the precentral gyrus. So if you look at this from the lateral aspect, this is without the pia and the arachnoid, and all the vessels have been removed. So this one here is the superior frontal gyrus. This one here is the middle frontal gyrus. This one here is the inferior frontal gyrus, which has various parts, which I will show you. And this one here, the right in the center, this ellipsoid is the central lobe. So this is the precentral sulcus. This is the postcentral sulcus. And this one in between is the central sulcus. Now you see this precentral sulcus is interrupted where the superior, middle, and inferior frontal gyri consistently meet with the precentral gyrus. Now the central lobe, this precentral gyrus has actually 2 convexities. So you see this superior convexities and inferior. Sometimes it is divided into 3 convexities, superior, middle, and inferior. But this one that you see here, this region, you see this omega-shaped region, this is consistently the hand motor activation area. And also another landmark to identify is where the superior frontal sulcus joins the precentral gyrus. So this area is the hand motor activation area, and corresponding to it posteriorly in the postcentral gyrus is also the sensory area for the hand. So this is the hand area in both the pre and postcentral gyri. Now the pre and postcentral gyri actually meet inferiorly above the Sylvian fissure and also medially in the just above the calcarine sulcus. Cingulate sulcus. So this part here, where they cross over and go on the opposite, on the medial surface, is the superior landing point. And this point here, where the subcentral gyrus is formed, is the inferior landing point. So where the pre and the postcentral gyri meet, this gyrus is called as the subcentral gyrus. And if you see here, this subcentral gyrus consistently sits here on the plenum part of the temporal lobe, and it actually sits on the Heschel's gyrus. So this is the subcentral gyrus that is sitting there. This is the inferior orlandic point. Now the inferior frontal gyrus, as I said, has 3 parts. This is the pars orbitalis, the pars triangularis. You see how this triangular formed area is there. It is pulled up above the Sylvian fissure, and you get this dilatation in the Sylvian fissure. That is the anterior Sylvian point. And this is your access into the insular lobe. So if you look in the depth here, there is the insular lobe. This one is the pars opercularis, and it joins consistently with the precentral gyrus with this connection that is also very consistent in most of the hemispheres. This is the Sylvian fissure, this is the superior temporal gyrus, and then the other parietal lobe and supramarginal gyrus. So now this is the anatomy with the vessels. So here again, you can see the central lobe. This is the central sulcus. And here again, you see how consistently it is meeting here and sits in the subcentral, on the Heschel's gyrus. Now, besides these 2 connections, there is a connection here in the depth. that is the middle knee of Broca or the pli, the passage of Broca, that connects the pre and post central gyrus in the depth. And sometimes this knee comes up, this gyrus actually comes up to the surface, and that time the central sulcus may seem to be interrupted. Now look at this view. So this you can see how beautifully this is the central central lobe, and here you see how it is sitting on this gyrus. So this gyrus is the Herschel's gyrus. Now you see the relation of the precentral gyrus. It's just a little bit behind the coronal suture. The coronal suture will come here at the level of the foramen of Monro. So when you're operating, your precentral gyrus is behind the central lobe, and it is related to the ventricle in this aspect. So the central lobe is related to the body of the lateral ventricle in the depth. And here, of course, it sits here on the temporal lobe. This is again its relation of the motor cortex to the coronal suture. So you see the coronal suture here. This one here is the central lobe. This is the precentral sulcus is just a little bit behind the coronal suture, and then the central lobe lies behind that. So now this is again looking at the ellipsoid from a lateral aspect. Here you see how it is going. Now we will go into the depth. This is all we have to know about the central lobe. And we will start dissecting the fibers in this region and going towards the insular lobe. So this is the first layer of fibers that have to be dissected. So you remove the cortical gray matter on the surface, and you remove the cortical gray matter in the depths, in the sulci. And when you remove these, you see these fibers. These are the short arcuate fibers. Now again, we have classified these short arcuate fibers into various groups, and it's now about to be published. So when we will discuss about that later. So once you open this region, so the insular is hidden by this opercula. Opercula means curtain. So it is hidden by this fronto-orbital operculum, the frontal operculum, the parietal operculum, and the temporal operculum. These parts are made up by the fronto-orbital cortex in the anterior part. Then here you have the inferior frontal gyrus and the subcentral gyrus forming the frontal operculum. The parietal operculum is formed by the supramarginal gyrus, and the temporal operculum is formed by this superior temporal gyrus and its planum polar and planum temporal regions. Now you look at this structure. This is the beautiful 3D picture of the insula. And this whole structure here, this insular lobe surrounding by the limiting sulci. The sulci around the insula is called as the circular sulcus of insula. This area is also known as the island of Riehl. Then you have it's divided into three parts: the anterior limiting sulcus, the superior limiting sulcus, and the inferior limiting sulcus. Now this region here, where the insula, this pyramid-shaped region turns, this is the Lyman insulae. This is also the point where the MC turns and becomes M2. Now this point here that you see where all the short gyri come, this is the insular apex. Now the insula is divided into anterior short and posterior long gyri by the central sulcus of the insula. And you see this central sulcus actually runs in the same direction as the central sulcus in the hemisphere. So this is the central sulcus. Now these are the anterior, middle, and posterior short gyri. Now you see two gyri here. This is the transverse gyrus and the accessory gyrus. This transverse gyrus goes all the way below at the base of the brain and connects to the posterior middle orbital gyrus or the posterior orbital lobule. And that is how the insula connects with the basal frontal brain. So all these regions are actually primitive areas. These are the regions that developed first. They have archicortex, paleocortex, and mesocortex. So that is how this connection is there with the olfactory area and how this temporal region connects with the frontal region. Then these are the accessory gyrus lies here in between the short and the transverse gyrus, and this is the anterior and posterior long gyri. Now coming further, what is important while doing insular lobe surgery, insular glioma surgery, are these white fibers. So along with the cortex, the important white fibers in this region have to be understood. So here you see this is the region of the central lobe. So when you start dissecting from laterally, on this you see these U fibers that are connecting adjacent gyri. Then you see two fiber bundles that are running from anterior to posterior. The one that is superior is the SLF2. Just beneath it is the SLF3. And the one fiber bundle that circulates, forms a circle all around the insula is the arcuate fasciculus. These are the insular gyri. The cortex of the insular gyrus has been removed. And you see there are fiber bundles connecting the deeper part of the insula to the surface. And these are the claustrocortical fibers. So again, you see this image. 3D image here. You see this claustrocortical fibers as they are coming up. Some part of the opercula is still remaining here. This is the beginning of the arcuate fasciculus. Now that insular region has been removed, the insular cortex has been removed, and you see the arcuate fasciculus more nicely. This one here in the below is the inferior longitudinal fasciculus. Once you lift this, you will get the middle longitudinal fasciculus in this region. Now, the first layer that you come across when you remove the insular cortex is the extreme capsule. Beneath that, you will have this gray matter. It's not very consistently seen, but you can see some gray here, and that is the claustrum. Now you see the arcuate fasciculus nicely as it is turning and terminating here in the region of the superior and middle temporal gyri. This one's up here. So this one here is the SLF2. This one here is the SLF3. These are all parts of the speech pathway. This is just an oblique view so that you can get an orientation. Also, another thing is these are fibers of the corona radiata as they're coming up and joining superiorly. And if you see these fibers remain all lateral to these fibers of the corona radiata, they will not go on the medial aspect. So this is another hemisphere, and looking from the other side, just a quick revision. So this is the extreme capsule, this is the arcuate and the SLF. I will go quickly. Now here, once you remove the extreme capsule and claustrum, you start seeing these fibers that are going superiorly and two fiber bundles that come inferiorly. So this superior part is the dorsal external capsule, and this inferior one is the ventral external capsule. So this one is made up of two fibers, the IFOF, which runs from the frontal and goes all the way to the temporal, and the uncinate, which runs from the frontal pole to the temporal region. And this one here is the dorsal external capsule, which will go up beneath the arcuate here and go all the way up and join the fibers of the internal capsule to form the corona radiata. In this region, there is a fiber bundle that connects this inferior frontal gyrus to the superior frontal gyrus, important for the supplementary motor area syndrome, and that is the frontal Ashland tract. So now you can see this image in a better 3D perspective. So you see this IFOF, and this is the uncinate fasciculus. This is the dorsal external capsule. Now just another beautiful image. So you see, this is how the operculum is, how these fibers are actually connecting to each other. This is the SLF, this is the arcuate, this is the insular cortex, which I have not yet removed. These are U fibers. So this is the complete first step of dissection when you come from the lateral perspective. Now the insular gray has been removed, and here you see the extreme capsule and some fibers coming up. This is the claustrocortical fibers. Here you see the middle longitudinal fasciculus as it is going up, and here below is the inferior longitudinal fasciculus. Now this is just an image to show you the 3D perspective. So this is the arcuate. This one is the IFOF. This one is the uncinate. This is the ILF. And now here some external capsule is being removed to show the putamen. Now, if you see there are fibers that are going up here, these are fibers of the corona radiata. And this is the region of the frontal Ashland tract. So now I've lifted the arcuate fasciculus, and you see this whole bundle of layer here is the sagittal stratum. So it is made up of fibers of the IFOF, fibers of the anterior commissure as it will come, fibers of the optic radiation, and then beneath that the tapetum. And above that you have the MLF and the arcuate fasciculus. And this one here is the uncinate and the ILF. Now, when we remove the external capsule and the putamen, you start seeing fibers in this region, and these are fibers of the internal capsule. This is again some part of the arcuate that is preserved. Once we lift it, you will see the sagittal stratum. Now, this is the whole bundle of internal capsule fibers. This fiber bundle that you see here is the anterior commissure as it comes from the frontal and joins the IFOF here posteriorly to form part of the sagittal stratum. Now, how these internal capsule fibers come, they come from the surface here and go all the way down into the cerebral peduncle and then go into the pons as this forming the corticospinal tract and coming here in the region of the medulla. So from the surface, the external internal capsule form the corona radiata, go up to the surface, then come down to the insula where they form the internal capsule and then come all the way down into the medulla. So here you see, this is the internal capsule, the anterior limb, genu, posterior limb, sublentiform and retrolentiform part. Then comes down here in the cerebral peduncle, then in the pons, and then in the medulla. So this is the whole motor cortex coming all the way down to the medulla and connected. Here is a closer view showing the fibers of the internal capsule as they are coming down from the cortex. Again, here, this is the optic tract has been cut, and you can see the fibers coming down more beautifully. Now, just quickly, some vascular part of the insula, which is again another important. So in the insular glioma surgery, two things are important. You cannot damage the white fibers. You cannot damage any of these vessels. So this is where the MCA is turning and entering into the insular lobe. And here you see the turning. This region where it turns is the region of the Lyman insulae. And the M2, these are the branches of the M2 on the insular surface. Then they again turn here at the level of the limiting sulci. And then again they turn here on the surface to become the cortical branches or the M4. And these are the deep supply of all this basal, the central core of the brain. And you see how these lenticular striate arteries supply this basal, the central core of the brain, and how important it is to avoid damage here. So in this region of the Lyman insulae is where the lenticular striate arteries come. And if you damage here, you will damage the vascular supply of this region. So giving a perspective from the lateral aspect of the insula. So here, this is the frontal, temporal. Now you see how the insula is related to the ventricle. So there is a recess here when you go from the superior and at the junction of the superior and anterior limiting sulci that will straight lead you into the frontal horn anterior to the caudate. And this posterior part of the insula actually straight leads to the atrium. And here you see the temporal horn with the hippocampus and the choroid plexus. And this is the choroid fissure in between the fornix and the thalamus going all the way in a C-shaped manner. Now you'll see it more beautifully. This is the choroid fissure coming like this, running between the thalamus and the fornices. And this is the region inside here is the third ventricle, which we will see in another lecture. So this is the region of the insular. So if you come trans-sylvian, so there is a risk of injury to the IFOF and the uncinate as they lie in this region. Sometimes the approach comes here and you can reach the amygdala and the hippocampus through here, but we prefer going through the middle temporal gyrus and remaining below this roof of temporal horn to avoid injury to the IFOF and the optic radiations. So this is just an image to show you the 3D perspective and all the fibers coming down. So this is the combination of both thalamic radiations along with the internal capsule fibers. From the medial aspect, these are the thalamic radiations. So you have the anterior, superior, posterior, and inferior thalamic radiations. When you come from the medial aspect, this is what you will see first. When you come from the lateral aspect, you will see fibers of the internal capsule. And of course, they're all intermingled with each other. And this is just a tractographic replication of the white fibers of the brain. And you see how in the center is the commissural fibers. Then you have these fibers of the internal capsule going down all the way into the cerebral peduncle. And then all these fibers that lie lateral on the lateral surface of the hemisphere. This is how it looks on tractographic images. So here you see the IFOF coming all the way posteriorly with the optic radiations. This is the visual cortex. You will have the uncinate like this. This is the arcuate. These are some fibers of the internal capsule. And this is the optic radiations as they begin here and go all the way to the occipital lobe. So here, this whole component is that of the sagittal stratum with the MLF and the ILF. And the yellow one is the IFOF as it is coming from the frontal to the temporal. Again, another image. This is the arcuate. This is the IFOF. And here posteriorly will be the optic radiations. So again, just to give a 3D impression. Thank you very much.
Now we'll have a next talk on the surgical anatomy of insular glioma by Professor Sukhdeep Java. Over to you, sir. So we'll move on to our next talk on the role of IONM and 3D ultrasound in motor cortex by Professor Aliasagar Moedi. I welcome you, sir.
Good morning, everyone. And the outset, I'd like to thank Professor Ghosh, Professor Pandey, and everybody involved in this organization for having me here. It's as much a learning experience for me as it is sharing some, some of my thoughts and some of my experiences with all of you, young and old, everybody here. Right. So I'm going to be talking about surgical strategy for resection of motor gliomas, perirolandic gliomas. So I'm not going to restrict myself just to motor or M1, but my talk is in two parts. And I'm going to try and cover aspects of mapping and resection under GA as well as awake. Now, I think for all of us here, gliomas is a very integral part of our neurosurgical practice. And for you young residents or young neurosurgeons, I think it's important to realize that gliomas is as much a cerebral, and the pun is intended, a cerebral topic for us and not a very mechanical thing that you do by just piecemeal debulking. It's also important to understand certain principles of and the rationale behind glioma surgery, and I'm going to spend a few minutes on that before going to the surgical technique. So I think gliomas are omnipresent. There are high grades, low grades. They come in all shapes and sizes. And by definition, they are diffuse. However, they can radiologically appear circumscribed, though not all of them. And even when they do appear radiologically circumscribed, I think it is very important to realize that pathologically they are not circumscribed, which means that there is tumor microscopically extending beyond visible, radiologically as well as visible to your eyes, the margin. And there are many pathways of spread, the most common being along white matter tracts. However, because of their virtue, by virtue of their spread along these microscopic margins, they are prone for local failure. And surgery is one of the important modalities besides other adjuvant therapies that are required to control them. However, the extent of resection remains probably the most important modifiable prognostic or risk factor in gliomas, which is what you can change. There are some other prognostic factors which you can't do anything about, but this is the one as a neurosurgeon you can modify. And that's what we will talk about. Abida mentioned about the mysterious brain, and I would say if the brain is a mystery, the gliomas are an enigma in this mystery. What we know about gliomas is that they arise in the white matter. They're usually subcortical, though they can come to the surface. They always respect bile margins and they grow along white fiber matter tracts. These are important points in your decision making, in your algorithm for how you will approach these tumors. However, we still don't know everything about gliomas. What we don't know is that is the function subserved by these tracts preserved or disrupted? Is this disruption partial? Is it compensated? Is it compensatable? And because of this intricate relationship of the tumor with these white matter tracts, crisscrossing in and out around it, which are not visible to the naked eye, it's very important to be able to have some more assistance or aids or adjuncts in making your surgery safe at the same time radical. Therefore, function becomes very important. What we are trying to do in glioma surgery is this balancing act between radical resection and function preservation. And therefore, it's a multimodal strategy, multi-pronged attack. You have to select the right case. You know, some of the gliomas are very diffuse. Gliomatosis, that's a term which is now kind of removed from the WHO classification, but it's an entity still. Those are not cases which you can surgically resect. Then you have to have the right technique and the appropriate adjunct. And we'll see with one or two cases how that can be done. And no two gliomas are the same. So you have to have in your armamentarium these various techniques and adjuncts, but you should also know how and where to apply these. As it said that no one size fits all. At the bottom, at the bedrock of glioma surgery is the microsurgical technique. I don't think any kind of adjunct, any kind of technology can replace that. And that is very, very important to understand. It's not a very complicated or a glamorous technique, but still it's a technique which has to be systematically implemented. And for this, background knowledge of anatomy, subcortical, as well as cortical is important, and that's what we've already seen. This technique essentially differs from piecemeal technique in being more of a circumferential technique. Different terminologies have been applied. People call it peri-resection, peri-lesional resection. We call it subpinal block resection or circumferential sulcus guided resection or Omas resection. All of them essentially involve going around the tumor, finding the margins, and resecting the tumor. In the subpile technique, what we would do is to find the gyrus which is involved by the tumor, localize it, do a gyrectomy going all the way to the margin of the pia, preserving the pia because it will preserve vascularity to the surrounding brain, which could be eloquent. And then at the base of the sulcus, at the depth, where there is no anatomical delineation, the tumor is in the white matter, you use complementary techniques with image guidance or functional mapping. Pure image guidance or pure technique is not going to help you always, because you have subcortical tumor, which may not be evident on the surface. You can't see where to enter. You have tumor margins, which are imperceptible, especially in the deep infiltrating zone. And there is a risk of inadvertent damage. And this is where some kind of localizing techniques come into use. There are many of them. Intraoperative ultrasound is a multifaceted tool. It's easy, convenient, requires a little bit of training, but can be used very effectively in glioma surgery. And when combined with, say, navigation, it gives you a complementary tool during intraaxial tumor surgery. And then for high-grade tumors, you have the option of fluorescence, which has been shown to be allowing you to extend resections beyond visible contrast-enhancing margins. However, just tumor delineation also is not enough. As I've already said, you need to have function preservation. And for doing that, you have techniques of mapping and monitoring, both under awake and under asleep. The technique of mapping is basically punctiform, spatially distributed, and even temporally interrupted. That means you do it, then you resect, you do it and resect. However, monitoring is something you can do continuously, and both of these are very important during eloquent cortex tumor surgery. And what is the evidence for this? I think the evidence is very, very solid. It shows that for tumors, intraaxial tumors, when mapping has been used, there is reduction in late neurological deficits. You might get immediate high incidence of deficits which are reversible, and that is actually one of the advantages of mapping. Also, there is a high chance or a higher chance of getting an extended resection even in more eloquent tumors. And therefore, intraoperative monitoring and mapping and verification of function is very crucial. And this is basically what we talk about functional neuro-oncological surgery. You could have differing philosophies for high and low-grade tumors. However, this is primarily because high-grade tumors require early adjuvant therapy, and their threshold for recovery is very, very low. So therefore, you should avoid complicated and high morbidity surgeries in high-grade gliomas. Now, the techniques for mapping in perirholandic gliomas under anesthesia are either indirect with phase reversal. This is not a technique that we use very often. And the more commonly used one is the direct mapping, which is generally under asleep, a monopolar high-frequency train of 5 paradigm, though bipolar sometimes can be used. How do you use this? What you record is MEPs or motor evoked potentials. And this is also can be used for both cortical and subcortical mapping. And this is important because the tracts and the subcortical fibers are equally important. And doing this mapping subcortically in a continuous fashion is very important, using a suction monopolar with periodically reducing current strengths, indicating more proximity to corticospinal tracts is the way to do it. How do you put all of this into practice? This is a case of a perirholandic largish tumor, just abutting the post-central gyrus and pushing the precentral gyrus anteriorly. You can see the functional MRI showing the hand area very close to it and the corticospinal tumor tracts played. In this short video, I will try and cover up all these techniques. So essentially, this is an oblong subpile resection technique. As soon as you expose, in this particular case, you won't need a localizing tool because you can see the tumor, but it still helps to have one to see the delineation. That is what we normally would do in all cases. And then you localize the motor strip. You can see the corticospinal tracts. You can record the MEP, and you put up strip there to do the continuous MEP monitoring, and then start the subpile resection. This technique involves coagulation of the pia, isolating the tumor-bearing gyrus, and then carefully, the coagulation is on the pia on the tumor side. Avoid coagulation on the normal brain side. And then using a combination of suction, distraction, or even ultrasonic aspiration, you can go ahead and do a subpile dissection all around. As you can see, if you use the right technique and the right plane, you will be able to remove the tumor from its boundary from the normal. And this is eloquent brain. This is where the leg area is in this particular case. You can also appreciate the subpile spread of the tumor and remove all of it without leaving fragments behind. Then you go ahead and you do this all around circumferentially. Right now I'm using the suction technique to do the subpile, and you can see remove every bit of tissue from the gyrus till you see the pia. This has to be done all around till you reach the depth of the tumor. And there you will encounter white matter. You often get a plane, but the plane can be deceptive. Use of image guidance or other mapping techniques will help. This is continuing the subpile circumferential dissection, and you can see how the tumor separates subpilely from the adjacent normal tumor, a normal brain, sorry. In the interest of time, I'm just going to skip a little bit. Once you have isolated the gyrus completely, you have the depth, white matter, and this is the suction monopolar where we've started stimulating. And in the depth, you start stimulating at higher currents. And as you get responses, you keep reducing the current to increase your radical resection. This is done all around, especially close to the subcortical fibers in the posterior part of the incision, the resection in this case. And finally, you have a circumferential resection, almost oblong. Sometimes it may always not be possible. And you remove the entire tumor without causing any neurological deficit. Interestingly, in this case, the MEP, the amplitudes improved as we went through surgery, indicating that the neurological deficit preoperatively was reversible. I'll skip the next case, just show you this one quick overview. This was another case. It was almost in the motor area. And you can see when you open the brain that you can see the surface being a little bit discolored. However, where would this be the tumor itself and where is the M1? It's very difficult to say that. And unless you map, you're not able to get your answers. So of course, ultrasound helps you show where the tumor is. Mapping tells you where it is, and then you can go ahead and resect the entire tumor. I'll skip that video. To summarize, I think motor eloquent tumors are very, very complex and require a multi-pronged approach. Probably saying that just doing a biopsy and leaving it is not the right thing because we know extent of resection is important, however, not at the cost of morbidity. And intraoperatively assessing tumor extent as well as function is very critical in getting the optimal outcome for these patients. Thank you very much. And with that, I'd just like to invite all the young neurosurgeons here for this very intensive 2-day workshop course on intraoperative monitoring that we are planning later half of this year. And everyone is more than welcome to come and join us for that. We have very good faculty and hopefully good learning during that workshop. Thank you very much.
Thank you, sir. Before we move on to the next talk, a small announcement. 10 delegates' name who has been notified in the WhatsApp group. Kindly proceed to the first floor for the first stereotactic radiosurgery, neuroradiosurgery workshop. The 10 delegates who have been mentioned in the WhatsApp group. Okay. So now I kindly invite Professor Ravi Mohan Rao to deliver his talk on the surgical approach to focal cortical dysplasia in language area. Okay.
For the time being, can I invite Professor Kuntal Kanti Das to take us through microsurgical excision of insular glioma?
Very good morning, everyone. First and foremost, I'm thankful to Professor Ghosh and Dr. Pandey for inviting me. This is kind of homecoming to me because I was born and raised in the adjoining state of Assam. Thank you so much. So I'm going to talk to you about microsurgical excision of insular glioma. And my task has been nearly almost done by the previous speakers. So I'm going to take you through some of the things that I've learned over the last few years. Now I begin with this slide. Why? There is a reason. You know, whenever you talk about insular gliomas, the first thing that comes to our mind is the propensity to cause complications. So we need to deal with the elephant in the house right away. So yes, insular gliomas do have complication. Like for example, I can show you two of my cases. The first one is left-sided insular glioma resected well. But as you see, post-operatively, the patient has a coronary radiata infarct and the patient had hemiplegia. So the problem was with the lenticular arteries. In the second case, in the lower panel, you see there was a right sizable insular glioma with more predominant posterior extension, and it was abutting the posterior limb of ventral capsule. The tumor was resected well, but in the pursuit of resection, probably I also ended up removing the posterior limb of ventral capsule. So these are precisely the two ways by which you can cause complication. One by direct resection of the important neurological structures, particularly the subcortical structures. And secondly, indirectly, you're not even knowing it, by causing injury or spasm to the lenticular striate arteries. So you need to be mindful of these complications because even now, in this era of neuromonitoring and gadgets, we still see complication to the tune of 10%. So it is very important for us to know that insula is hidden inside the brain. So we need to expose the insula either by opening the sylvian fissure or by resecting the overlying cortex. If you see this diagram, this has been taken from a study on a large series of insular gliomas. They have seen that as you move along the sylvian fissure posteriorly, you see the percentage of eloquence increases. So what does it tell you? It tells you that if you have to resect the operculum, and if you don't have monitoring, probably if you follow this line, the line which goes obliquely along the anterior sylvian point, you can probably safely resect the operculum anterior to it. If you have to resect the operculum behind it, you have to be really careful and you have to use the adjuncts. In my practice, I can remove this operculum pretty easily, even if I don't have any adjuncts. The subcortical anatomy has been dealt with very well. The important thing is the dorsal and the ventral language pathways. Now, these pathways, as you see, are located at the base of periinsular sulci. So as a surgeon, it is very important for us to find the periinsular sulci. If you look at the periinsular sulci, if you go to the depth of them, you find that all the important structures come deeper to that. So three structures that you need to be mindful of are the SLF arcuate fasciculus, that is the dorsal stream, the ventral stream, which has been very well depicted by Dr. Avida, and the corticospinal tract in the descending pathway. But let me tell you that all these important structures will come at the depth, not on the surface. So you have to be really careful about the depth in insular glioma surgery. Then we also have to deal with the middle cerebral artery. The middle cerebral artery, M2 divisions, as you know, they course on the insula. And you have to deal with them as you go in between them in a trans-sylvian approach. But probably the most important thing, small, which yet still packs a punch, is the lenticular striate arteries. As you see, the lenticular striate arteries, they perfuse the basal ganglia and the internal capsule, and they do not participate in the blood supply of the tumor as such. The tumor in the insula is actually supplied by the short insular perforators, which you see are arising from the N2 divisions. So you can probably take down the small insular perforators, which probably I can show you in the video, but it cannot take down the lenticular striate artery perforators. And the bad thing is, these perforators are running in the parenchyma. So unlike a skull-based surgery or an aneurysm surgery, you cannot actually see them. You have to anticipate their location. So as I said, the perilous zone, in my understanding, is the medial portion. And by respecting this transbasisalcal plane, whenever possible, will guarantee you a safe resection in any given patient. These are some of the considerations. Whether to go for awake or GA, the literature says not much of a difference, but it can map and monitor the patient more extensively if the patient is awake. But in my own experience, I'll probably do majority of them under GA because of several reasons. But awake is also a good choice if you have the facilities. Trans-sylvian or transcortical. Trans-sylvian, as you see the orange marker, it gives you direct access to the tumor, but you have to retract the operculum. So the amount of exposure you get is limited, and you have to work through the middle cerebral artery. So chances of ischemic complications are higher. So if the tumor has already gone beyond the insula, probably you can go ahead with transcortical approaches, which will give you wide exposure. You can work below the MCA, so the complication potential from ischemia goes down. And most importantly, many of these patients will have intractable seizure because of opercular invasion. So by removing the operculum at the same time, you can probably have a better seizure control. In my mind, as I have published, we go by the extension of the tumor rather than a set kind of frame of mind in selecting these approaches. I'll show you two quick videos. This was a right-sided insular glioma. As you see, the tumor has gone beyond the insula and is also involving the right frontal operculum. This patient was operated in a supine position with the head tilted to the left side. The incision is a standard one. As you can see, a transcranial MEP leads are in place. We generally like to do these patients in triple monitoring, motor monitoring, that is transcortical MEP, cortical stimulation, and subcortical stimulation. This is the policy that we have developed. Here, right, terminal craniotomy has been done. This is the frontal lobe on the right, on this side, and the temporal lobe. Can I have the pointer? So we begin with this craniotomy. So we have made this policy of doing one ultrasound in the beginning. As you can see, we have the hyperechoic tumor. At the inferior portion, you can see the ventricles. As the frontal operculum was invaded by the tumor, we started our resection from here. As rightly shown by Professor Moyadi in the previous talk, you have to remain subpial. So all you have to do is you catch hold of the pia with the forceps and keep using your suction to suck out the tumor. So once the infiltrated operculum is removed, you can actually visualize the insula at its depth. Can I have the pointer, please? So the infiltrated operculum is being resected. And it is important that you pursue the perisulcal planes, the sulci. Because if you pursue the sulci, you are likely to remove the tumor completely. Here we are pursuing the antereperinsular sulcus. Now, as you see, after removing the opercular invaded part, we put in the ultrasound again. And as you can see the surgical cavity, you can see the ventricle, and you can see that posteriorly there is still some amount of tumor remaining behind. Right. So now we are resecting the remaining portion of the tumor posteriorly. These are the Sylvian veins. So now we are making another opening on the temporal operculum. The idea is to attack the tumor from both fronts. Now, as you see, once you've removed the temporal operculum, you have another view to the tumor from behind. So we have a view on the front, a view from behind. We can see the M2 divisions. So as you see these M2 divisions, they will be sitting right on the tumor, and you have to find small windows between these MCA vessels to remove this tumor, yet at the same time not damage these arteries. Intermittently, you have to use papaverine. So I realized that the tumor probably can be better removed from the front, from the frontal side. The brain is pliable, and you do not really need a lot of retraction. You can use your instruments to retract the brain and access these deeper portions of the tumor. So as you see, I'm doing some subcortical mapping. What Dr. Moyadi showed, that by varying the strength of current, you can actually find the distance to the important targets. This is very important thing. You can see I am creating a window below the MCA from the temporal side, and I'm joining both the cavities. So this is the beauty of transcortical approach. You can actually work beneath the MCA. You see, these are the perforating branches. So you do not directly handle the artery, you go below the artery. You have a wide exposure. And this is what I want to show you is that at the base of the resection, you have to appreciate the change in color and some venous bleed. This venous bleed usually precedes lenticular striate artery. So you have to stop right at this stage and do not go deeper to this. Because if you go deeper to this artery may be injured inside the brain. So I generally stop at around 5 to 10 milliamps of current. So the resection is almost complete, but it is never complete unless you verify. So you will see, we're verifying with ultrasound again. And I'm poking with my suction here. So as you see, some amount of residual tumor is there and I'm still poking with my suction. So this gives me some kind of navigation here. So I go in and resect this small bit of residue which is left behind. Ultrasonic aspirator is a very important tool here. And I verify again with ultrasound that the small amount of residue that is here is acceptable to me because I know the internal capsule is lying just beneath it. So this is the final resection cavity. So utilization of these gadgets will enhance the extent of resection that you can get. So these are the post-operative scans. You can see the tumor is out. And you also have to do diffusion-weighted images post-operatively. Many times the infarcts would be seen on imaging, but the patient may not have any deficit. So I'll show you last video of a trans-Sylvian approach. Similar patient right-sided tumor, but here the tumor is confined inside the insula. So this is possibly a case where you can go trans-Sylvian. You do not have to resect the operculum. Sorry. So this was a 35-year-old female with seizures with right-sided insular glioma, which was confined to the insula, not invading into the operculum. So this is one case where I'll probably go trans-Sylvian. The position is again same standard. Right terminal incision is made and all the leads are put in place. We use a combination of ultrasound and triple monitoring that I've just told you. Too much of head rotation will cause difficulty if you want to go trans-Sylvian. So here we see some amount of tumor in the Sylvian fissure. So this exophytic growth actually helps you go into the Sylvian fissure. Like it is a standard with any trans-Sylvian approach, first you see the important structures. For example, here you are seeing the optic nerve, the internal carotid artery, and the MCA. So the beauty of this approach is you can see the MCA in the Sylvian fissure. You can see the M1 segment and possibly some of the perforators extrapially. You cannot see them inside the brain, but extrapially possibly you can. So we'll open the pia over here. We'll put in the ultrasound again. This is our practice. Do ultrasound at the beginning, do in between and do at the end. And the tumor is very much suckable. As you see, it is coming very easily into the suction. It is important to remain supine. As you see, I'm lifting the pia with my foreship and I'm utilizing my left hand and the suction to deliver the tumor into the cavity. Ultrasonic aspirator is very, very important, as I told you. And these are the peri-insular sulci. How do you know? The MCA, they will run in there. So pursuing the peri-insular sulcus is very important. And as I said, I'll be very careful in going deeper to this plane because all the important structures will lie deeper to that. This is the middle cerebral artery. So as I said, in trans-Sylvian approach, you have to actually handle the artery even if you don't like to do it. So it does increase the chances of postoperative ischemia. So intermittent application of piperine is helpful. So we are at the depth of the tumor now, surgical cavity. Apart from appreciating the change in color, we'd also probably do one ultrasound out here. So as I said, ultrasound does require some experience, but with some little bit of experience, you can do it. So we are using subcortical stimulation. So a combination of your surgical expertise, ultrasound, and subcortical monitoring. So you need to put in everything together to get these daunting tumors out. As I said, you have to pursue the tumor along all the peri-insular sulci. We can see the apex of the insula, what Dr. Abida showed. So we have to, just 1 minute. So again, we have to pursue the tumor from different corridors that we have. We have the middle cerebral artery here, the posterior peri-insular sulcus, insular apex. So we can see from the change in color that possibly there is not a lot of tumor invasion in this area. And this is exactly the area where the lenticular striate artery should be. So you have to exercise a lot of judgment out here. Radicality versus function preservation is entirely in the hand of the surgeon. So we see the extrapile M1 perforators, and I know that the perforators are running in here, and it is not appropriate to go and search for the perforators inside the brain. You just have to guess the location and just leave a bit of tumor over there. So ultrasound verifies the satisfactory extent of excision that we have, and at the end, we apply some amount of piperine over here. So postoperative scans show a good extent of resection. The patient made an uneventful recovery, and it is what I've started doing now is that if I have a good resection, I'll probably defer radiotherapy if it is a low-grade glioma. So these are the postoperative scans showing good extent of resection. So at the end, what are the 5 rules I can give you? The do's for a maximal dissection would be understand the normal and the pathological anatomy of a given patient. No two patients are same. Secondly, don't be fixated on a single approach, rather be flexible and use an approach based on a case. You may see a lot of experts all around the world, but you have to develop your own set of technology, technique based on the local environment that you have and keep on using that. And the two most important things that will help you in avoiding complication is not crossing the medial limits and then minimizing or not at all handling the MCA or its branches. Thank you.
Thank you, sir. Can we please call upon Professor Matthew Abraham to discuss microsurgical excision of thalamic glioma right now? Before that, a small announcement for those of you attending the workshop. The one on microvascular anastomosis, the participants, Dr. Het Shah, Dr. Puranjay Pratap Singh, Dr. Aaron Jose Fernandez, Dr. Ashish Thakur, Jesse Jeswant, Ishita Laha, Bilpula Shrikant, Ashwin Kumar Panda, J. Lalitbhai Madani, and Rishabh Malik. The workshop is happening just nearby, next door. And as for the workshop on stereotaxy radiosurgery workshop, Doctors Navajit Mani, S. Aditya Shivram, Akshay Patidar, M. Srivatas, Vikatoli Samuel Sorhi, Dr. Kamlesh Rangiri, Dr. Kabush Ravindranath, Apurva Prasad, and Dr. Ravi. The workshop is happening on the first floor.
Respected chairpersons and my dear friends. First of all, let me thank Professor Ghosh and Dr. Anil Pandey for organizing this meeting and inviting me and giving me this opportunity. Surgery for thalamic tumors. The most important thing to remember for a thalamic lesion is thalamus is not a single entity for a single approach. Each region of the thalamus has to be seen separately. And only those lesions that involve the pulvinar, the geniculate bodies, the medial and anterior and medial thalamus, and maybe perhaps the LD and LP are really operable. Those lesions which are involving this zone is not essentially operable. And the thalamus, as you all know, is a great integrative association center as well as a terminal point. It also stimulates the brain to maintain your sensorium. See, this region, you cannot breach this internal medullary lamina and the patient won't wake up. Plus the lateral aspect where you have the reticular nucleus also cannot be breached. So each approach has to be designed according to the location of the lesion within the thalamus. You cannot go perpendicular to the perforators of the PCA, and they are not good for a relook surgery. This is my personal series. If you can see, I have around 124 thalamic lesions. And this is the interesting aspect. Posterior thalamus dominates the picture. Medial thalamus around 28, inferior thalamus 18, while lateral thalamus only 6. Most of the lesions are actually, even on the thalamus, that come to a surgeon belong to the posterior aspect of the thalamus. I shall quickly go into the different approaches. This is for the approach for 72 cases I have done for the posterior for the pulvinar. So this is the inferior parietal lobule that is exposed, just like the Keen's point. It is an expansion of the EVD that you do. You steadily expose as the essential region. Approximately 1.5 to 2 centimeters would do. I'm just accelerating my video for want of time. So I've just now entered the tumor. Most of the tumors of the pulvinar are low grade. Unlike those in the lateral aspect of the thalamus, which are often high grade. So this is quite a suckable tumor. Only direct appearance and feel will guide you. Very little way of really knowing where the eloquent region starts. But there's a very clear demarcation between the tumor and the, as you can see, the composition of the appearance of the, this is white and very totally different from the feel of the tumor. So that is the end of the resection. You can see we have got a radical excision here. This is a 12-year-old girl, 8th standard student. Her only problem was loss of prosody of speech, particularly when she reads, as well as difficulty in writing. Subtle left-sided, subtle right-sided pyramidal signs. So this is again a pulvinar lesion, which we got a radical excision, and this is her post-op video. She sent me 8 weeks later. She could not read. She was a brilliant student, class topper. She found it difficult to read, could not write. Some prosody is lost, although it's not a non-eloquent side. The chain of words are not coming. She did not have any, she sent a very elaborate video. That is, she's writing. And her reading also returned. So this is a medial thalamic lesion. That is, it is lying inside the ventricle most of the time. So the midline, you can take a midline approach or you can take a Poppins approach. I'll just show the video of a midline approach that I have done. So this is the callosum that is exposed. I'm getting the, if you see, I'm getting the interpharyngeal plane. This is a sweet plane to go to the third ventricle. You can see this, the internal cerebral veins being separated. And the tumor is being decompressed. This approach is a very flexible approach. You can go to the anterior-most part of the third ventricle. You can remove anterior thalamic region. You can come posteriorly up to the, you can go into up to the pineal region. So this is the postoperative scan. You can see a radical removal. This is another lesion where you can see there's a large medial thalamic lesion which has been radically removed. These are post-op scans. These do not carry much deficits. Postoperatively, you will not find language. You will not find memory impaired. So this is an inferior thalamic lesion. So this is actually a lesion which is coming from the lateral geniculate body. Those which lie on the inferior aspect, they bury into the peduncle and reach the capsule, up to the internal capsule at the genu and in the posterior aspect. So this can be approached in two ways. You can go subcortically between the perforators of the ACA, or here I am doing a transchoroidal route. The choroidal artery gives a guideline. It guides you into the tumor along the optic tract. So this is a lesion. You can see the anterior choroidal artery here, which is dissected and separated, and you have the lesion is coming there. I'm decompressing this. These are also mostly pilocytic astrocytomas, although they look terrible on scans. It will look as if the capsule is involved. There will be hemiparesis, but they have a different blood supply from the capsule and can be eminently removed. A small anchosectomy may facilitate. Uncal removal will give you the space where you can stand. On one side, actually, you're having the attachment of the optic tract. That white region is the attachment of the optic tract into the tumor. So this is a post-op scan. This patient had come with a hemiplegia, and this is the post-op picture at 6 weeks. Pyramidal findings had actually disappeared totally. That is me standing in the background, talking on a phone. So this is another same type of lesion, much larger. You can see it looks as if the capsule is grossly involved. But here, initially we approached between the ACA perforators and decompressed it. And 8 months later, this is the picture after the first resection. This is actually only decompressed as the child was quite sick. And 8 months later, this is the thing. The whole tumor has come out and you can see the small spot lying on the capsule. It has a separate origin altogether and can be separated out in toto. This is a post-op video. This child at 9 years required leupride injection for precocious puberty. Precocious puberty is very frequently seen in thalamic lesions. No capsular deficits now. So the lateral thalamic lesion, this is actually a cavernoma. Just for the approach, I am showing this. This approach has been already published by Professor R.C. Mishra in Neurology, India. Lateral thalamic lesions are not great lesions from a surgeon's point of view. However, you can approach them to the posteriormost part of the insula. You have to open the sylvian really wide. It's a good practice session for a insular glioma. Interestingly, you have to practice on low-grade lesions first, not a high-grade lesion when you are approaching the insula. Oh, sorry. The insula has to be opened really wide. You have to see the angular artery and the posterior limit of the insula. So that you reach behind the posterior limb of the internal capsule. You go through the retrolendiform part of the capsule. It does not give a major deficit at that region. Most of the lateral thalamus otherwise is not operable. And they present early. They are high-grade lesions and they present with severe deficits. So this is the portion of the cavernoma that is coming out. It's not a glioma. So this is a post-op scan. This patient did well. He was an IT professional. So to summarize, anterior thalamic lesions may be approached through the anterior interhemispheric or transventricular approach, or maybe subfrontal. The medial lesions may be approached through a transcallosal route. The lateral thalamus may not be resectable most of the time, presenting very early, or a posterior insular approach when it is on the posterior aspect of the lateral side. And for the pulvinar or the posterior thalamus, you can go through the inferior parietal lobule if it is on the non-dominant side, and through the superior parietal lobule if it is on the dominant side. For a inferior lesion, that is those lesions that arise in the lateral geniculate body, you can go for a pterional subfrontal route, a transcortical, or if you can dissect the anterior choroidal safely, as a transchoroidal route. Thank you.
Thank you, sir. Can we please call upon Professor Aliasgar Mori for a talk on awake craniotomy for motor cortex glioma?
Have this on. So I'm going to continue from where I left off about the peri-Rolandic gliomas. I think we've had some beautiful talks on thalamic and insular gliomas. Now, this is where we left off in that talk about motor mapping with monopolar. That's what you usually do under general anesthesia, MEPs. Very reliable, very, very effective and objective assessment of intraoperative motor function. However, what we also must realize that motor function is not just about M1 or the corticospinal tracts. It's about modulating motor networks, and these are essentially premotor, supplementary motor cortical areas, which not only subserve motor coordination function, but also on the dominant side, speech initiation and coordination. And the corresponding subcortical connections include the frontoaslant tract, which we heard about, and the frontostriatal, which actually connects to the striatum. And these are, this is the connections which are important, and all of these contribute eventually to motor function. So when you talk about motor function, you don't mean power of 5x5 in some muscle groups, but you mean effective and coordinated motor activity. Besides these modulating functions, you also have the praxicons, that is the apraxias, which result because of disruptions of frontoparietal connections. These are not strictly motor functions, but if you talk of motor cognition, then this is an important aspect to remember when talking about motor outcomes in patients. And therefore, if you talk of higher motor functions, you have the executive function and the coordinated praxis function, both of which result in coordinated motor activity. So let's say this case, which was in the superior frontal gyrus in the supplementary motor area, and you can see that this just abutting the motor cortex, and we used motor mapping, and we removed the tumor, and it looks like it's pretty good. There is some cavity blood, but otherwise it looked okay, no infarct. And this was the patient on the first post-op day. Severe inability to move, no speech output, and even on follow-up, the patient had difficulty in doing coordinated motor activity. And this we all know is the supplementary motor area syndrome, originally described in 3 phases with immediate complete akinesia, often bilateral, with including speech initiation difficulties, and then gradual recovery. However, it should be noted that a lot of the patients have persistent fine motor or dexterity related issues. And over the years, our evolving understanding is that SMA and the syndrome resulting from its damage is essentially a surgical phenomenon. You won't see this in any other neurological disease very often. And we also understand that it's not just the SMA cortex, but it's also these connections which are important in preserving. So for example, this is another tumor, little largish. And if you see the tractography in this patient, if you see them, the corticospinal tract is definitely close to it, but the frontoaslant tract is hugging the tumor completely posteriorly. And the connecting fibers of the corpus callosum, which is actually an important component of the supplementary motor area network because it allows bimanual coordination, is also an important fiber which you need to be careful about and preserve. Now, how do you preserve these functions intraoperatively? For these, GA is not going to be enough. You have to do it awake. And when you do it awake, it's essentially bipolar. Bipolar with low frequency stimulation, what is classically described as Penfield stimulation. You can use monopolar in awake, but essentially it's bipolar mapping. So under bipolar awake conditions, how do you map motor function? You can map basic motor function, which is what you do with MEPs under GA also. And this is done by just stimulating in the motor cortex and obtaining an involuntary twitch of a muscle or a group of muscles, depending on which part of the homunculus you have stimulated. And remember that majority of the times you're operating on the convexity or the lateral surface, and you will almost always get responses from the upper limb and sometimes the face, almost never from the lower limb unless you stimulate medially. How do you then test motor cognition? That is, you want to look for coordinated activity. In this case, you ask the patient, and this is possible only when awake, to do a coordinated activity, continuous moving of the hand, and then you stimulate with bipolar, and this response is only possible with bipolar, not with monopolar. There is a disruption or decomposition of that movement, which tells you that these are areas which are responsible for coordinating the function of the primary motor area. Sometimes if your stimulus current stimulus is high, you may have a combination of responses, that is twitching, involuntary twitching, as well as decomposition of movement. And in these cases, you have to lower the current and you have to do a more focal stimulation. A step ahead is doing praxis testing. This is something that is theoretically possible. We don't do it routinely, but it can be done if you're operating in the deep frontal or parietal, where the frontoparietal fibers are important, and simple pegboard insertion test or using some kind of common implement or tool and asking the patient to show how it is being used and simulating at that time can be done. Now, this is an illustrative case. This was a left frontal tumor. And you can see at surgery, now this is patient has been done awake. At surgery, you can already see the extent of the tumor. You don't really need localization for this. And we start the stimulation by getting positive motor responses. We're using monopolar here. As I said, you can use it in awake, but you can also use bipolar. And then to get the negative motor responses, you start using bipolar stimulation. And this is just at the posterior border of the tumor. This is where the SMA would be. Sometimes you don't get any responses cortically, but you still have to establish a threshold using one of the other responses and then stimulate subcortically. And then interestingly, you have subcortical responses for other speech areas in that area. So remember that speech delay can be seen in the middle frontal gyrus, also terminations of the IFOF. Once you've identified function, then you do your subpile standard resection and carefully find the plane more posteriorly where you have the likelihood of the frontoaslant tract. You use a combination of layer by layer dissection with subcortical mapping. And subcortical mapping uses the same threshold you've got at cortical. And that is important. That's the reason you do cortical mapping, to get that stimulus threshold. And carefully remove tumor piecemeal, layer by layer, because this is important subcortical areas. Keep stimulating. And in this case, we got motor arrest of the right lower limb. That means the negative motor area for the lower limb, at which point of time you have to stop, even if it means leaving a small sliver of tissue there. Continue the resection, and you see it's a subpile, but an en bloc resection. Preserve the cortical bridging veins. Medially along the falx, you can do a complete subpile resection. And at the base, again, you stimulate subcortically because you are likely to get corpus callosal fibers, which besides other functions will also contribute to bimanual coordination. And at this time, you make the patient do a bimanual task, moving both hands simultaneously in alternating tasks. So eventually, you can get a near total resection. In this case, we did a near total because we left a small nubbin where we had the lower limb responses. And this can lead you to getting a radical resection without compromising neurological function. Now, there is a decision making when it comes to whether supplementary motor area syndrome is acceptable or no. If you do this case under awake, you can record the MEPs and you can get a gross total resection. You might argue that the patient may recover from a supplementary motor area, but this is a discussion that you have to have with the patient who is willing to tolerate a dexterity problem, which may be lifelong, or is willing to accept it. And based on that, the decision whether to resect negative motor regions can be taken. In addition, the other situation where awake mapping may be required in peri-Rolandic tumors is the speech output areas. Now, speech output areas, we all know, is not just the Broca's, but it's also the premotor cortex, the ventral premotor cortex, which is actually the final motor pathway for speech output. And this again can be tested only by bipolar stimulation. And it's actually the corresponding response to the motor supplementary motor area that you get. That means that the negative motor response when you ask the patient to do number counting is a speech arrest. And this tells you the location of the ventral premotor cortex, which sometimes may be in the ventral bank of the precentral gyrus. And this is only possible with awake. This is an example. Sure if this video runs.
This, 9, 10, 1, 2, 3, 4, 5, 6.
Dobara. So this is the classical speech arrest that you get when you do a bipolar stimulation with number counting. And it is again very important to have this algorithm in mind to differentiate primary motor from ventral premotor cortex induced anarthria. The distinguishing feature being absence of involuntary twitches, but still complete anarthria. And this is the ventral premotor cortex, which cannot be sacrificed under any circumstances. So if you have a tumor like this, which is involving a large area of the precentral gyrus and the ventral premotor cortex, you would obviously want to do this awake. This tumor was involving the subcentral gyrus and parts of the pre and post central gyrus. Of course, you have to rely on cortical plasticity to be able to remove this tumor, and therefore intraoperative mapping of function is important. In this case, as you can see, there was splaying of function. We got anarthria on the superior margin of the tumor, and actually lip and face twitches displaced more posteriorly. This allowed delineation of the tumor. Again, intraoperative imaging was useful because on the surface, very difficult to make out where the tumor is. And then with the mapping, you have your functional coordinates, and then you can go ahead and enter the tumor. Now, when you enter the tumor, you again do a subpial resection. This tumor was on the operculum and going again into the insula, where you have to be very careful of the vessels, remain subpial, and continue doing subcortical mapping intermittently, all the while monitoring the patient for motor function and speech, which is possible in the awake condition. Posteriorly, where we had cortical dysarthria and face motor twitches, it was subcortical mapping, looking for the subcortical fibers for dysarthria, and that becomes the functional limit at that particular region. Further, go ahead and complete your resection. Assess the extent of resection with ultrasound, in this case, navigated ultrasound, and finally get a complete resection. And this is what the findings we had in this particular case. And this was the eventual outcome. A thin, very thin layer near the insula in the deep subcortical matter was left, but we had almost a 95% resection in this case. So if I were to summarize again for peri-Rolandic gliomas, mapping is definitely important. It can be under GA, as I mentioned in my previous talk, but in certain situations like the SMA, most probably and preferably in the dominant SMA, but also in the inferior frontal gyrus, peri-Rolandic subcentral gyrus tumors, it is again probably preferable to do them awake so as to be able to test motor cognition and speech output function and be able to preserve them, because especially on the dominant side, these are non-compensatable. Thank you very much. And again, I'll just invite all of you all for this workshop and course in August later this year. Thank you.
Thank you, sir. Now can we call upon Professor Aliasgar Mordi, Professor Kuntal Kantidas, and Professor Matthew Abraham to please be seated in the first row, and the moderator of the session, Professor Sanjay Bihari, to take the seat on stage for the panel discussion and interactive Q&A.
Yeah. So first of all, I think a big round of applause for these masters of surgery. I mean, which make what used to be a simple, just a glioma surgery has become a fantastic work. So first question which I have for Dr. Abida, she's like over the years, she has perfected this art of anatomical dissection, which has really helped all of us. So I'd like to just ask you one question. In your anatomical dissections, we used to do this frontal lobectomy and we used to do this temporal lobectomy. Is it actually relevant now? I mean, or you would kind of, with your anatomical dissections, actually go on for something else?
Lobectomies are no longer relevant for glioma surgeries because as you have seen some videos, we are also using this en-masse resection technique based on the glioma origin and spread. So you know what, if you saw the first layer, these are short arcuate fibers that border the gyrus. So that's where I believe the tumor originates from. It'll involve that. It'll remain surgically localized to that. Diffusely, of course, pathologically it will spread. So you don't need to remove the whole lobe now. You can just go in and go around the tumor and remove it. If you're going for a supramarginal resection, you mark the boundaries by your mapping and then do the resection accordingly. The only rule of lobectomies is probably for disconnections of epilepsy, where you have specific landmarks and you perform the disconnection. And that's where you are disconnecting the lobes. You're not actually removing the lobes.
Yeah. So I just keep it open. Yeah, sure. Please go ahead. Yeah.
Can I,
Doctor. Yeah. Because if there is a difference of opinion, yeah, please go ahead. Yeah.
I would say that
You please get up because you can please the audience.
lobectomies are probably not completely out of favor in gliomas. So the difference being that in certain situations, temporal tumors, frontal tumors, you can still do a lobectomy. But what we now understand is that to extend the posterior resection, the posterior boundary of that lobectomy safely and still get maximum, probably these other techniques might help. And also that in certain situations where tumors are unresectable, gliomatosis, then you would still do a temporal lobectomy or a frontal lobectomy to give space because adjuvant treatment needs to be given. So yes, I would say that not completely gone off, but our approach or our perspective to lobectomies is a little different now. Yeah. So we would still do a lobectomy in certain cases, but in these situations.
So
now, considering the one more,
let me just I mean a little focused. I'm not that it's just a starting question. Now, if you were to do a lobectomy, frontal versus temporal, I'm not talking about epilepsy surgery. We'll come to that. But frontal and temporal lobectomy, what are the things that you would keep in mind?
For a frontal lobectomy, I would not go. I would resect, leave some cortex in front of the prefrontal sulcus also, because the SMA comes there. Your frontal eye fields come there. The pars opercularis, the pars triangularis comes there. So my boundary of resection for a frontal lobectomy would include the anterior part of the superior frontal gyrus and middle frontal gyrus, and a portion of the inferior frontal gyrus. The other things I would preserve for sure.
Yeah. And temporal?
Temporal, again, posterior superior temporal gyrus I will preserve. So the anterior part of superior temporal gyrus, inferior temporal gyrus, and middle temporal gyrus.
How will you decide the medial aspect of your lobectomy, temporal lobectomy?
Middle aspect, I can go up to the pia till the level of the uncus, hippocampus, parahippocampus is fine.
So you will spare that?
I will spare the fornix. I mean, I will spare the intraventricular part.
Talking about temporal. So normally, very practically, what we would do is go up to the temporal incisura and then stop there. So any points on that? Yeah.
I just wanted to add, I have a feeling that the standard lobectomies have evolved over several decades. They're still relevant. for the average neurosurgeon who is not that much used to deeper resections. This provides a standard which can be always enforced. There have been specially designs that patient comes out with practically no gross deficits or even neuropsychological deficits. We have done neuropsychological follow-up of patients who have undergone frontal lobectomies, both dominant and non-dominant as well as temporal. Very marginal deficits come. So it's been very intelligently devised resections for the average. Secondly, about this, the standard frontal lobectomy of 8 and 7 on the misses this SMA as well as any of the language areas. Only thing you have to form a C starting from the anterior part of the sylvian and coming 2 centimeters anterior to the coronal, 1 centimeter anterior to the coronal on the medial side. Second thing is regarding temporal lobectomy. Once you have removed most of the neocortex, the memory function actually deteriorates. The spared mesial temporal alone doesn't guarantee a preserved memory. There's significant fall. And if you have removed the head of the hippocampus and early part of the body, the whole deficit comes. So you can actually remain more radical and you can go posteriorly, almost to the junction of the cingulate.
Thank you. The second very quick question. There is the change of perception from an anatomical description of the brain to connectosome description of the brain. So now, considering your extensive experience, what would you advise about the shifting focus on the connectosome description of the brain?
So connectomics is coming a long way, and I think it will be the way to go because it shows you both the cortical and the subcortical structure. So it is basically the areas that are all connected. Understanding is that they will work together in sync. And if you can identify the network that is actually involved or the network that you have to preserve, the whole concept of your brain resections the tumor resections will change. You would try to preserve these connectomes.
In actual surgery, what is your perception? Would you really focus on the connectosomes or you would still focus on the anatomical areas right now?
So what I can say is that anatomy is necessary, but not always sufficient. And therefore, the connectome is important because classical example is our understanding of language. Broca's we always thought was eloquent area, and we thought that we can't remove it. If you go by pure anatomy, you would say inferior frontal gyrus, pars triangularis, pars opercularis, you can't remove. But we've seen that in patients who have tumors there can be reorganization of function in that anatomy. Therefore, anatomy is important, but you need to rely on some way of verification of function in real time, online. And therefore, I would say anatomy is important, but also that connectomes is a kind of extrapolation of function, but at least subcortical anatomy and how it is in real time intraoperatively is important to understand.
Thank you. In practical terms, what are those situations where you'll use the connectosomes rather than anatomical?
Absolute important point, actually. The concept of connectosome goes to a different level of understanding. The brain is not just with one single circuit. There is always a parallel. Evolution has given a parallel circuit to all of us. You see, I'll just now I had an experience of a patient who came with a catastrophic epilepsy where we had a posterior inferior parietal lobule what we call epileptogenic focus, that is a encephalitis. We resected that. The patient still had some degree of seizures. It came down by around 20%. So we went ahead, we removed the whole involved area and did a calosotomy. We still found that there were subclinical seizures on the opposite side, propagated even after calosotomy with the same speed. So there is something that is propagating a seizure with equal efficiency to the opposite side, probably from the thalamus. So the brain has been formed by multiple levels of control, but still, unfortunately, connectosome analysis is not yet available. The cost of it is now it's available with some few centers in Europe, prohibitively high. You can only get a subscription, and the subscription is 40 lakh per year. And you have to upload the details, and they will send you back the circuit. Along with AI information, which you can use on a image guidance. It's too prohibitively costly to use.
Thank you. The third point, all of you use some terminologies, and what is your concept of those terminologies? So one was you use supramarginal resection, Dr. Ali Asgar, and you used radical, just one second. You used supramarginal resection, then you used radical resection, then you used marginal free resection, then there is a safe margin, and there is a partial resection. So what exactly do you mean by each one of these terminologies?
I must say that a lot of these overlap. What we mean by radical resections.
So let me talk about each one of them. Supramarginal resection. What do you mean by
So when you say
supramarginal?
margin, you mean margin of the tumor, which is radiologically evident. In a high grade, it's generally the contrast, but our goalpost has shifted. Even in high grade, it is now the T2 flare. So whatever is radiologically the margin of the tumor is margin. If you are able to go beyond it, I would call it a radical or a supramarginal resection.
So what is that margin? Say, supposing what is your soft suckable tumor? What is that margin, 1 centimeter, 2 centimeter at the depth, at the surface that you would consider as your margin?
All radiological abnormality.
All.
And intraoperatively, I would look at ultrasound to correspondingly see whether it is there. And that would be all radiological abnormality within the confines of function.
Oh, Dr. Kuntal, would you agree with that, or would you have some?
Sir, we have to understand that the understanding on glioma surgery is evolving. So what people have realized, and what is true also, that most often the recurrence centimeter of initially radiologically seen tumor. So all the focus now is on getting this 2 centimeter or more area out. So there are different kinds of definitions. Whenever possible, you should resect the tumor supramaximally, indicating that you need to take out at least 50% of the flare hyperintensity in high-grade tumor and all of the flare hyperintensity in low-grade tumor. So much so that there are several groups who will keep on resecting and monitoring until they find a functional area which will stop them. So it is not 2 centimeter, it is not 1 centimeter. People have gone to the level of keeping on resecting, going on resecting until they find a functional area.
No, but
in this process,
know
they,
your experience. See, I'm not interested in what people think.
Yeah.
What I mean, for this young group of people, what is your practical, information that you would like to give?
See, first and foremost, you should all go in with the idea of taking the tumor out maximally. Corner the days of biopsy, unless there are specific indications. Go in with a set of mind that you need to take the tumor out completely. So what stops you there? The functional area that stops you there. And sometimes you accidentally leave some tumor. So I try to look at this way. There are two ways how a residual tumor is left behind. One, when you have no other choice but to leave when there is a function. And the second way is when you leave the tumor and you don't even know. And only a post-operative MRI scan will tell you that there is tumor and probably you could have removed. So therein comes the role of these adjuncts, particularly tumor visualizing adjuncts like ultrasound, which will work both in low grade and high grade, and this fluorescing particles that will work excellently well in contrast enhancing high grade tumors. So yes, in my practice, I go for maximal dissection, sometimes beyond the margin of the tumor whenever possible. But the real difficulty is to find out where the real margin is. So therein, sometimes all these things that we have been taught, that the glioma will have a different consistency than the brain, it will have different bleeding pattern, the brain will collapse or not. So all these things, they go haywire in the periphery. And this is exactly the area where the tumor recurs. So it is advisable for intra-axial tumor surgery to use these adjuncts, extend the resection as much as possible. Sir, it has been proven now, although most of the data is retrospective, that as the extent of resection goes, so does the survival. And as Dr. Moedi said, this is the only modifiable factor. The rest of the things, IDH mutation, location, size is not in your hand. As surgeon, the only thing that we can do is to provide a maximal dissection. At the same time, we have to realize that any additional deficit that we give reduces the survival. So it balances out whatever you have done. That is why this concept of maximal safe resection has come, meaning don't be defensive, go on resecting, but at the same time, don't be so reckless that you cause a deficit that neutralizes whatever gain you have achieved. So yes, sir, the final point would be go for aggressive resection, use whatever adjunct is available at your disposal. The point, I just want to come back to one of the points that you asked in the beginning, that is frontal lobectomy or lobectomies. Now, there is a concept coming up now that lobectomy is entirely not out of favor. For example, you have a frontal polar tumor or a temporal polar tumor. So doing a standard temporal or a frontal lobectomy that we have been taught is actually a supramarginal resection in this case. So still now we have to learn the art of frontal temporal lobectomy and maybe utilize it as a curative option of supramarginal dissection in polar tumors. Thank you.
Thank you. Is there a difference of opinion on that? Or yeah, sure. Sure, please. Yeah. No, you can just make a comment. I mean, this is a discussion.
So connectomics is not something very new. It's been existing for the past 4 or 5 decades. And it has been very maximally applied for stereoelectroencephalography. So I'll give an example. For instance, let us say patient presents with the frontal lobe seizures. We have now implanted more than 600 SEEG electrodes. And we are learning more and more every day. So for instance, if a patient presents with a frontal lobe epilepsy, typical nocturnal seizures, very short duration, bipedaling movements, usually gets up from the sleep, keeps on, pedaling his legs and goes on, and then immediately subsides, no aura. So it's a very typical frontal lobe epilepsy. So we always ensure that we cover the frontal area, the cingulate, and the occipital area. Why occipital area? Because 30% of the frontal lobe epilepsies actually arise from occipital and they pass along the superior fasciculus and come to the frontal lobe. Even in our cases, we have seen, patients presenting with typical frontal lobe epilepsy. We find again in the detailed history, they say that they are seeing some kind of a formed hallucination and immediately they have seizures. So similarly for language circuits. So when we are putting SEG electrodes for, let us say, resecting vocal cortical dysplasias in the primary language circuit, let us say we have to cover the Broca's area. So we anyway cover the Broca's area, we also cover the secondary language circuits. And we have found that in most of the cases, when you have a lesion or a focal cortical dysplasia on the primary language circuit, it's a secondary language circuit which becomes active. So you can very safely remove the lesion. So what I'm trying to say is that connectomics is not something, it's like an old wine which has been wrapped in a new bottle and it has been made, looks more polished.
Yeah, no, so basically what you're trying to say is that we need to now get it done for gliomas also. I mean, we need to actually study these areas
Absolutely.
for even glioma.
Absolutely.
Yeah, please.
So, just coming back to the previous discussion on, you asked objectively how to define this terminology.
Yes.
So for low-grade gliomas, all T2 flare abnormality should be considered as tumor. That is the target of resection. For high-grade gliomas, if you read the response assessment to neuro-oncology, RANO, the RANO criteria 2023, they have now defined supramaximal resection as complete removal of all contrast enhancing tumor and less than, not 50%, 5 cc of residual T2 flare abnormality. This is the target for supramaximal resection in high-grade gliomas, which means it's not just contrast enhancing, but even T2 flare, which is why all these adjuncts become important. And this criteria is based on a huge analysis with prognostic benefit. And then you have radical resection, which is complete removal of contrast enhancing and more than 5 cc of T2 flare abnormality. And then anything short of that is subtotal. I think it doesn't matter what you call it. Essentially, it is remove as much as is possible. And one just last comment.
Create controversies.
No controversy. So I just wanted to make this humble submission. I think as Indian neurosurgeons, we pride ourselves being the best in the world. I think be it skull base, be it vascular, be it anywhere. I think we should do the same for neuro-oncology. And I don't think we should use any other excuse saying that we don't have mapping, we don't have these adjuncts. We should make it available or make it, I won't say mandatory because that may be too controversial, but I think we should try and use all this to achieve the most optimal outcomes. That's all.
Dr. Manmohan, and then we go on to the next point. I mean, we need to, a brief one.
Yeah, exactly, very brief. The supramaxial resection we all talk about, but it is sometimes very difficult to achieve with that imaging because as we decompress the tumor, so everything your image guidance goes for a 6 because the brain shift is happening. So on table, resection becomes difficult, and the only way of approaching is the intraoperative neuromonitoring and the surgeon's experience. These two things are the standard ones. So I think we always try to achieve the supramaximal resection of the flare, but sometimes it is not that easy as we talk about.
So coming to the next point, which is a very simple and a very stupid question, which I ask, which is, I mean, yes, your post-operatively, your patient develops weakness, and there's some, you can say, oh, it will improve over a period of time, or you say it will not improve over a period of time. So what is your practical criteria for deciding, okay, this will improve over a period of time and it will not improve over a period of time? Yeah, please go ahead.
Very important question. The
Can you address the audience, please?
Yeah. I was initially doing a lot of away craniotomies, around 45 of them in a chain. Then I did the same lesion, around close to 80 lesions without away. I found there's hardly any difference. And I'm getting the same extent of dissection. So this is the point that Vihari sir was saying. That is, how do you know whether a deficit post-operative will improve or not? My feeling is those resections where you have maintained the blood supply, you have gone subpile, where you have not had a misadventure into the deep white matter. These deficits will improve if you are stuck to the tumor or within a few millimeters beyond the tumor. Those where you had a mishap, you have lost a blood vessel, or you have gone deep unknowingly into the white matter, then the picture is different. So there is always an impediment as you do an awake craniotomy of a transient deficit. Total weakness. Your whole team to assess the deficit is with you. You have to show some degree of respect to them. Initially, we had the neurologists who used to come inside the theater to make an assessment. So they used to feel disheartened that I have continued even after a deficit has come. But all these people have improved around 6 weeks from our section. This is the best thing. I think the answer from my point of view is preservation of blood vessels to the pial planes.
Yeah. But
will give the answer.
see, clinically, when we assess, sometimes there is hypotonia, right? Complete hypotonia. And of course, the patient improves. But when you are doing glioma surgery, the patient improves, but the fine movements don't improve. So any other comments on that?
So I think, again, and I'm coming back to that, is this actually speaks for doing functional mapping and monitoring intraoperatively. If you have done intraoperative functional mapping or monitoring, and you have got positive mapping findings, say you're doing a supplementary motor and you get those networks, and you stop short of them, almost invariably, these patients will have some transient deficit post-operatively. But because you have mapped them, you can rest assured that you can tell the patient these are going to be reversible and will improve. The same situation, if you had not mapped and the patient has the deficit, you are still uncertain. And that's where all the uncertainty comes in your mind, whether this patient will improve or not improve. And that is why mapping the right function, that's also important. And the second, as Dr. Matthew said, is ischemia. If you have a post-operative scan, always do a diffusion on that, and you see an infarct, it's unlikely that the deficit caused by that infarct is going to recover completely. So I think that is.
So I think the three take-home messages there are: first of all, if there is hypotonia and there may be some fine movement deficit. The second is if your mapping shows that there is still in fact functions, this person is likely to improve. And the third, I think, if tone is maintained, then this patient is likely to improve. And if there is an infarct which comes in, then of course this patient may not improve to the extent that you wanted to improve. Okay, the next important point is when you're talking about this mapping, Kuntal, you said subcortical mapping you do. What is this subcortical mapping that you're talking about? We understand cortical mapping. What is subcortical mapping?
Like I said, both things are important, the cortex as well as the white matter. Probably the white matters are more important. The reason is because of the phenomena of neuroplasticity, the function in a particular cortex may get relocated to some other area. But this can only happen when the white matter is intact, right? The bundles. That is why there is a lot of reliance now on the white matters, the connectomics. If you prospectively look at...
no, Dr. Kuntal, can you be short?
I need to be specific.
Because we need to cover more points here.
So in subcortical mapping, the idea is to find this white matter bundles. Because inside the brain, you cannot...
So how do you do it?
So there are different ways, but what most people do and what I do is use monopolar stimulation. So we have monopolar stimulation either as a standalone stimulator, or many times it will come with the suction itself. The idea why monopolar is used is the current in the monopolar, it spreads, right? So it will spread to a diffuse area, and there is a millimeter to milliampere linear relationship, meaning if you get a response at 10 milliampere, it means the tract of your interest is 10 millimeters away from you. So you can dynamically monitor that, keep on resecting it until you reach a point where you decide to call it a day. So why do you stop? So there are different criteria, but most people would agree that they would stop at around 3 to 5 milliamperes. Because if you go beyond that, and if you go on dissecting beyond that, the deficit that will come may not recover.
Thank you.
So monopolar and for this important white matter.
Dr. Ali, please be very brief so that we can cover some more
I
points.
think just to add that even bipolar can be used for subcortical mapping. It's just that monopolar is very effective and objective for motor tracks, but bipolar is essential in awake surgeries for doing subcortical stimulation of all the other functions. The same functions, the same way that you do cortically, can be done subcortically. The only difference being between mapping is that you're doing it intermittently. So always remember that when you map, it does not mean you will not have a deficit. You also have to monitor the patient. If the patient is under asleep, then you monitor with continuous MEPs. And if the patient is awake, then between mapping, when you're stimulating, make sure somebody is doing a task with the patient, either spontaneous speech or movements. That is the monitoring. So monitoring and mapping are both very important components of functional assessment.
Thank you. Coming on to central tumors, thalamic tumors, and most of them, there are many thalamic, like the ones that you showed, they're soft suckable. It's whatever approach you take, you can remove them. But most of the thalamic tumors are like, very tenacious, non-suckable. And the other important thing is there's the central tumors, which may also be non-enhancing. So therefore, giving the message that total excision is always possible may not be the right answer. The second question which I have is lateral thalamic tumors. There is an internal capsule when you come from the Sylvian fissure. So how do you avoid that?
I think in my talk, I said not all thalamic tumors are resectable.
So how
those
do
are
you
the
decide?
pulvinar.
So how do you decide?
Yeah, the pulvinar, lateral and medial geniculate bodies, medial aspect of the thalamus, anterior thalamus, and maybe LP and LD, the superolateral part, are resectable. Those on the lateral are unresectable. They come with severe deficits and they are usually small. Your approach itself will damage. I think the most important point when it comes to tackling a thalamic tumor is thalamus is not a single entity. Each location in the thalamus requires a different trajectory, and each has to be treated in its own merit. And if you create a deficit, you have lost everything. So you have to, if the consistency is an important point, once it's too firm, may not be possible.
Yeah, so please remember that if it's a very tenacious thalamic tumor or bilateral tumor, then there's no point in actually going in for a total excision. That may not happen. Yeah, yeah.
Sir, regarding your point of avoiding the internal capsule, now the recommendation is for every thalamic tumor, you have to do DTI and you have to find the location of internal capsule. So although by definition, thalamic tumor should lie medial to internal capsule, but it also happens that it remains lateral. So you have to avoid the internal capsule. If the capsule is lateral to the tumor, you avoid a transcortical route. You will go interhemispheric or maybe supracerebellar infratentorial. Likewise, you alter your approach based on the internal capsule. So capsule detection by DTI is very, very important in approach selection in thalamic tumors.
Thank you. Only one last question, which relates to awake craniotomy. We have not discussed this. What is your preference for awake craniotomy? There are several patterns of awake craniotomy. You can have sleep, sleep, awake, sleep, or pure awake. What is your take on it, and which one would you follow?
I think for tumors which are small and frontal or temporal polar, I would prefer doing a completely awake also. That means the patient is only kept sedated with no airway, and patient is, after the craniotomy, sedation is stopped and patient can become completely lucid very quickly. For large tumors, insular tumors, which require longer time, in them, I would prefer doing a sleep awake, which means you put the patient to sleep with an airway, which is usually a laryngeal mask airway. And once the patient craniotomy has been done and you're opening the dura to start the mapping, the LMA is removed and patient is fully awakened. It shortens the time that the patient needs to be kept awake. So this is usually the criteria, but it's again, depending on how you and your anesthesiologist are familiar and comfortable with doing it. But this is what I would do.
Thank you so much. So I think a big round of applause for all the speakers and the fantastic discussion. Thank you so much.
Dr. Ghosh and me feel that you have been the best moderator we've had for a long time. Thank you. We are all average neurosurgeons in the majority of neurosurgery. In one area, we are the experts. I would like the young people to check with the experts, and you also should participate. I think that should increase in Dandy. Do you understand that? So you should feel free. Whatever you want to ask, please ask. And you should participate in that if you feel that thing is there. Because lobectomies are not going to go away anyway. And we need to know them. Thank you.
Hello. Thank you, sir. And thank you all for making this a brilliant session. That concludes the topic on gliomas.
So moving forward, we have a next session on cavernous sinus moderated by Professor Kuntal Kantidas. I call upon Professor Abida Shah and Professor Sukhdeep Java to take us through the 3D surgical anatomy of cavernous sinus. Once again, a kind reminder to all the speakers to adhere to the allotted times.
Again, I thanks the organizing team for giving us this opportunity. So starting now, we are changing from now glioma to the other aspect of very important aspect of neurosurgery, that is the skull base. And skull base, we are starting with the cavernous sinus. So I'll be just showing the anatomy of cavernous sinus in the in this presentation in 3D. If you see here, so this is the skull base, and this is a mid-sagittal section. You can see all of the skull base. This is the anterior skull base. Then you have the sellar region. Then we have the posterior skull base. So we have the big nasal cavity, and it gives a wonderful access to almost all of the skull base in the midline. But then this is the midline. Then there is a lateral part of the skull base also. So if you see the skull base in its entirety, so here there's missing of the anterior skull base, but you see this is the majority of the skull base which is concerned with the cavernous sinus. We have the sella here. This is the sphenoid bone. This is the temporal bone, and the so if you see the cavernous sinus, it's a very interesting entity, very much interesting to neurosurgeons. Not that you know, from the functional point of view or another point of view, but cavernous sinus has been remains the enigmatic, and all lot of textbooks and lot of literature is written how to approach cavernous sinus, how to deal with pathologies of the cavernous sinus. So it holds a special position in our for our neurosurgery community. So just to see the its uniqueness, you see it extends from your anterior skull base to the middle skull base and even to the posterior skull base. So it is occupying almost all of the skull base here, you see, and it is, related to all these major skull base bones. We have the clivus here, we have the petrous part, then of course we have the sphenoid here. And the uniqueness also, it gives you a complexity as the internal carotid artery. It is entering your skull base from the extracranial surface and going to the intracranial. So it has to traverse through the first the petrous part of the temporal bone, then where it has this S-shaped turn here. Then it is forming a double S shape, this configuration in the cavernous sinus. So all this anatomy is very important. This is not just that this anatomy was formed in isolation. This was part of the, all the evolution, millions of years. So all this anatomy has a functional aspect also. So we have to understand this is a functional anatomy. We have talked about the anatomy of the fibers and all these. So all this has not been in isolation. So whatever anatomy is there, you have to ask why this anatomy is there, why these things are there. And when you will start asking why, you will understand it's much better. Then it will help in your practice also. And many the time we are asked why you study fibers, why you do this anatomy dissection, what is the use? Now we have so much of technology is there, AI is there, but you understand why this. So this is, of course, the frontal view of the, when now, as you see, we have a lot of endoscopic approaches and to the cavernous sinus sella. So if you see, this is a sphenoid cavity, large cavity at the base of the skull, giving access to both the cavernous sinus sella and all the petrous apex region. This is the foramen rotundum here. This is the Vedian canal. Just remember these structures. We will come to this again. So this is the superior orbital fissure here. And if you see it obliquely, you see this is a very large spongy bone, which we normally neglect while doing the anatomical approaches. But it is very important when you are doing endoscopic approaches. This is a large ethmoid bone. So it's a very large spongy bone, which is occupying almost all the front of the access to the sphenoid sinus. And if you see there is a bone here, just remember this part of the bone. This is an optic canal here and superior orbital fissure. And between both of them, there is a solid bone, which is optic strut. So optic strut is a very important landmark for endoscopic as well as microscopic approaches. So just remember optic canal, superior orbital fissure, then we have the V2 here, foramen rotundum. So this is the optic strut here. And if you see optic strut from the opposite, from the endocranial surface, this is the upper surface, we have the sella turcica here, and this is the optic strut. So we have just seen optic canal, and superior orbital fissure is seen better here. So this is the anterior clinoid. These are very important landmarks. So when you are operating, you should understand how they are oriented to your surgical approach. Anterior clinoid again is a very important part of this cavernous sinus approaches. So this is the top-up view. You see that this is here, two tuberculum sella, then the chiasmatic sulcus is there. And you see small bulge here, which can be sometimes quite prominent. That is your middle clinoid. And this is the posterior clinoid process. And if you see, there is this process, which is not very much, described in literature sometimes, but you just remember this process. There's the lingual process. So what is this lingual process? I'll show you. This is again the posterior view from behind. You see this is all the dorsum sella, posterior clinoid. And if you see, there's a process over here. Many people, there's also not very well defined, but this is a petrosal process. We have the ligament, petrosphenoid ligament, then we have Gruber's ligament. We'll come to all these structures. Just I'm showing you the this bony anatomy here. Chiasmatic sulcus between both the optic canals, superior orbital fissure, foramen rotundum. So coming, this is the top-up view of the cavernous sinus. If you see, this is not in 3D. We'll come to the 3D. Okay, this is the 3D picture. So we have a beautiful, this is the middle fossa here. This is the anterior skull base here. This is a sella here, and the ICA coming here. And you see, there's a beautiful oculomotor triangle. Many times by, textbook description, we don't understand until we see this beautifully here. So anterior clinoid is a very important structure. We have the interclinoid ligament between anterior and posterior clinoid. We have a petroclinoid ligament and the posterior petroclinoid. So between this, there is this gap. So that in gap center, you enter this oculomotor nerve. This is the oculomotor triangle. Just try to see beautifully. And it is on the top. And as it enters and it goes into the lateral wall of the cavernous sinus. So this is your oculomotor triangle. And you see thin nerve here is the trochlear nerve going along the tentorial edge. So if you see carefully anterior clinoid, there are a lot of ligaments attached here. Tentorium is attached. Then there is interclinoid ligament, anterior petroclinoidal ligament, and of course this falciform ligament, which is going from one side over the optic nerve here. So there are four ligaments attached to the anterior clinoid. This is again in a 2D, but you see beautifully how this oculomotor triangle has been opened up. Now you see some branches of the cavernous part of the carotid artery, which are going to the clivus here. And you started seeing some part of the abducent nerve here. And you see the ligament coming into the picture. So now you see beautifully in 3D, this is the bow-shaped ligament here, which is covering your this sixth nerve, which is the abducent nerve, and this is the petrosphenoid or the Gruber's ligament. So as it is entering the Dorello's canal, then going into the medial side of the lateral wall of the cavernous sinus, sixth nerve is a very interesting nerve. If you understand the anatomy here of the sixth nerve going into the Dorello's canal, then this is all the venous lake, big venous lake, posterior basilar venous plexus. So Dorello's canal, sixth nerve entering, sometime it bifurcates, then it again joins. So it's a long course, long oblique course of the sixth nerve. And you see, this also makes you understand how this is oriented to your cavernous sinus anatomy. So this is the top-up view. You see how this is the medial cavernous compartment, which is more appreciated when you are approaching through endoscopic approaches. Just showing the full dissection from the top. Now we'll see from the lateral side. So lateral side, when we see this, the dura, both the layers of the dura covering the cavernous sinus and covering part of the Meckel's cave also. And you see that the nerves entering here into the roof and this lateral wall of the cavernous sinus. So once you remove the outer layer, you see this thin layer, which is the other, this is again the lateral wall of the cavernous sinus, where all the nerves are embedded here of the lateral wall of cavernous sinus. Third nerve, fourth nerve, and this is your Meckel's cave here. And if you remove the arachnoid part of the arachnoid, which is investing with this posterior root of this trigeminal nerve, you see here it is the V1, this is the V2, and the V3. So technically, V1 is the only part of the this trigeminal nerve, which is in the lateral wall of the cavernous sinus. V2 and V3, they are outside. They are pericavernous venous plexus here. So stepwise, we remove the lateral wall. Now you can see the V1 here. This is the third nerve here, and this is the cavernous sinus here. So cavernous sinus is basically on, it is more, you can say, on the top on lateral, this medial aspect of the Meckel's cave here. So very interesting anatomy. Now we have removed the venous conjection and we have removed part of this clinoid segment here. This is again a very interesting anatomical concept. This is the proximal dural ring. This is the distal dural ring. Many times, young neurosurgeon and we also didn't understand until we started this dissection. So proximally, this is the ring, this is the distal ring, and between them, it is your clinoidal segment of the ICA. So just for the time's sake, I'll just quickly go through the approaches. This is the petrolingual ligament, which I showed you lingual process, and this is the petrous apex. So this is the petrolingual ligament. It's the starting of the cavernous segment of the ICA. So it is very important to remember this. So this is the petrolingual ligament. This is the sixth nerve here. So this is again another view of petrolingual. Before that, this is the petrous segment. Sometimes bones can be deficient. Fifth nerve has been, retracted here. So this is the whole of the view. So just to see the approach, you can take an incision as you want. This is the superficial temporal, then fascia, muscle, then bone, dura, then go extradural. This is a beautiful approach. You have to understand this approach. Of course, Dr. Goel will talk about it. I'll just show you briefly. This is the middle meningeal. Just remove it. Then you keep on peeling it, and you will see this how this all of the cavernous sinus with the Meckel's cave. You can see here. This is the extradural approach to the cavernous sinus. So this is a clinoidal segment again. This is a little bit of, to show the endoscopic anatomy. This is the superior hypophyseal artery. This is the cavernous sinus, just retract medially the ICA. This is a lateral wall of cavernous sinus from the medial side. First we saw from the lateral side. Now this is view from the medial side. So third nerve, oculomotor triangle. This is again overview of the whole dissection from endoscope. You can see the basilar artery here also. And you can see beautifully how sixth nerve is obliquely going, like it's a long nerve, long thin course for the sixth nerve. And this is the overall anatomy of the cavernous sinus of the middle cranial fossa. You can see infratemporal fossa, you can see V1, V2, and you can see the nerves going into the ophthalmic orbit here. With this, I finish my presentation. Thank you.
Thank you, sir. I now invite Professor Manmohan Singh to deliver his talk on surgical steps in the dissection of cavernous sinus lesion.
Morning, everybody. So I would like to thank Professor Ghosh and Dr. Anil Pandey to give me this opportunity to talk in this August occasion gathering. So thank you, Dr. Jawar, for your excellent presentation on the anatomy. I think you have made my day easy. So I'll talk about the surgical aspect on table. How do we do it? The approaches to the cavernous sinus, basilar tip, interpeduncular regions, retrocellular area, they are really surgically challenging. And unless we know about the anatomy of the cavernous sinus in and around, so we won't be able to do it. And we won't be able to do the justice so that our patient surgical outcome is likely to be suboptimal if we don't know the anatomy. Over the last 50 decades, various our forefathers, they have advocated different approaches to the cavernous sinus, like Dowling's approach. This is more anteriorly and medially, and just it addresses that anteromedial part of the cavernous sinus. This is the Cavasi's approach, which addresses the posterior and the petrous apex. But many times our lesions are such that we need a wider exposure. So there is no one single approach which can address it. So in our classical teaching, which I also particularly follow, that the wider the exposure, the better will be the result, because you know that where exactly the structures are, from where to enter, and for how to attack that area. So full dissection of the cavernous sinus is likely to be better, and it gives you wider exposure inside the cavernous sinus and in the intradural lesions also. So this is the most usual incision. This is the this is a question mark incision starting just in front of the tragus, and it starts at just below that zygomatic arch, and then it goes just above the pinna and follow that the superior temporal line. So after the skin incision, and there the muscle reflection is done so that the bony exposure is made. So after the craniotomies, so this is this frontal lobe, this is a temporal lobe, orbitozygomatic craniotomies. So I used to do in the beginning of my career, and most of the surgeons, they still prefer it that, but I don't think this is absolutely requirement for that your cavernous sinus dissection and inside that cavernous sinus or the intradural also. So I just limit myself to that zygomatic osteotomies, and I leave that zygoma attached to the muscle and reflect along with this temporalis muscle, and it gives a very decent exposure of the subtemporal areas as well as the cavernous sinus. So zygomatic, orbitozygomatic osteotomy for the cavernous sinus surgery is not an requirement. Another next step after this exposure is that the drilling of the temporal base, and so you just need to drill this whole of the temporal base so that you can see that whole of the temporal base in one single line. So you just have to drill this whole area, and after that you have to disconnect this temporal dura from the base by coagulating and cutting that middle meningeal artery, which is usually the limiting step. And once you are disconnecting it, that the whole of the temporal base is freed. The only thing which now remains attached is that just medial to that middle meningeal artery is that GSPN. You just have to dissect the GSPN of this temporal basal dura just to preserve it and to mobilize the whole of the temporal lobe of the cavernous sinus. So another that was the posterior aspect. From the anterior aspect, so this is the anterior cleanout process. This is that superior orbital fissure. This is a temporal lobe, frontal lobe, and this superior orbital fissure, you just need to drill by around 4 to 5 millimeter from here. From anterior, so medial to that lateral aspect, drill a little bit of superior orbital fissure just to aspirate that the periorbita. So usually you will find always a groove here which separates the temporal dura with that orbital periorbita, and this gives that line from which you have to start your dissection. And to begin that, you have to cut this or meningo-orbital dural fold and start from anterior to the anteromedial to that lateral aspect. Intradural dissection with the reflection of the dura propria is done, and exposure of that whole of the cavernous sinus is done. So this is the dissection. This is the posterior limit. This is anterior limit. And this is the V3, V2, and the V1. So this is the Gasserian ganglion. You can see the very beautifully this whole of these nerve fibers coming from the Gasserian ganglion, supplying this V2, V3, and V1 divisions. And this area is the middle meningeal artery, which is coagulated, and the whole of the temporal lobe is lifted up that cavernous sinus. Now this is a complete exposure, and this particular case was a tumor in the proximal part of the cavernous sinus. This you can see this whole bulb just under that V3 division. Nothing is, you cannot learn this cavernous sinus dissection unless you go to the lab and do the cadaver dissection. So here you can see this in the cadaver dissection. So this is the temporal side. This is the temporal base. You just have to drill this whole temporal base and make it flush. So after that, you just have to catch hold of that the middle meningeal artery So this is the middle meningeal artery, dissect it off. Just medial to that, this is the origin of the GSPN, just medial to that. And this is middle meningeal artery. And you have to, on table, you have to coagulate and cut. Here we am cutting the middle meningeal artery. And this is the GSPN, just medial to that. That is the V3 division. So this is GSPN, and which has been dissected off. Now the interdural dissection is going on. So you just have to cut the dura off that V3 division. You start. And this is the Petrus Cavernous rhomboid. And you dice with the blunt and the sharp dissection, you have to take that temporal lobe dura off that cavernous sinus lateral wall. And I particularly do not use knife in these situations, which to me looks a little, you can damage the structures underneath it. The scissor dissection is, for me, it is better. And you can retract, you can peel it off and cut at the same time with the scissor. Sometimes you may not require a dissector for that. So now you have to peel that whole temporal lobe dura off the cavernous sinus. And this is lateral wall. This is a V3. This is a V2. This is the V1 division area. So V2, this is a foramen of rotundum. This is a foramen of ovale. So now from the anterior side, so this is the meningo-orbital fold. This is the periorbita. In this cadaver dissection, we have done that front orbitozygomatic osteotomy for the demonstration. So you start from there. You will always find a groove here. So you just remain on this groove between the periorbita and the dura, and dissect it off. So this is the V1 division. This is the fourth nerve. Okay. So now this is the area of Petrus drilling. So in this case, this I am going to now avoid that. So that is not our topic right now. So just taking off the last bits of the dural fold from that Gaussian ganglion. This is the entry of the fifth nerve into that middle fossa. This is the fourth nerve. So now I have lifted the whole of that temporal lobe of that cavernous sinus. And the last part from the anterior side, this is anterior cleanout process. This is the whole of the anterior cleanout process. So here is the dissection. Now I can orient you. This is the temporal side. This is the frontal side. This is anterior cleanout process. Now this is that superior orbital fissure. I've done that this temporal frontotemporal craniotomy and zygomatic osteotomy. This is the temporal base. This is anterior cleanout process. Now I am drilling a little bit of the rim of superior orbital fissure. So superior orbital fissure is drilled off. This is in the area of the foramen of rotundum. The little bit of bone is also taken off from there. Now you see that you will always see this groove between this is the periorbita and this is the temporal side. This groove is there, and you have to start your dissection after division of the meningo-orbital fold. And a scissor is always a better tool for me. Now this area is V2 is coming here. This is the V2. And dissecting, interdural dissection is there, and coming towards that V3 division. So I just want to now tell you there that if you remain in this correct plane, so there will not be much of the bleeding. And usually there is the venous ooze is there from the small, perforations between the fibers of this fifth nerve. And they are not very difficult to control. And with the help of your flowable hemostat like a flow seal, or maybe with that tissue glue, you can, from those spaces, you can push your flow seal or the tissue glue into the cavernous sinus, and the bleeding stops immediately. And you don't have to coagulate and push. Never coagulate in this area, otherwise you are going to damage these nerve fibers. So this complete dissection is there. you can see that these small spaces you will see, and you just have to inject your glue into that, and the venous ooze stops immediately. Now you can see that whatever the size of the tumor is there, you are now better oriented. You know that where exactly your structures are. This is a V1, V2, V3. You will see, because there's a little bit of blood is there, you will see that fourth nerve also, and the just superior to that, you will see the third nerve also. So you have the whole nerves visible to you. Now you can choose your territory from where to enter into the cavernous sinus. So my usual entry point is that if you don't have, because many times the tumor is giving a big bulge into that cavernous sinus, so you will always find that this is a safe area to go in through it. But sometimes that may not be a scenario. So my area of interest is that between the fibers of the V1, I would avoid V3 and V2, and between the fibers, I will dissect. You may have to sacrifice one or two fibers, and then longitudinally, you have to enter into the cavernous sinus to attack that area of interest, or maybe the tumor, whatever there in the cavernous sinus. So you just have to never do your dissection in the cross section. You will cut whole the fibers. You have to go along the fibers. You may be damaging one or two fibers of the V1 division. Otherwise, nothing is at risk. So that way you have to carry on your surgery. So I will stop my talk here. So the take-home message for all the beginners is that it is safe and absolutely provides the wide exposure. Technically, it looks challenging, but it is not. But with the help of your mentoring and your cadaver dissection in the lab, this skill can easily be mastered. Thank you.
Thank you, sir. I now call upon Professor Ashish Suri to deliver his talk on surgery of cavernous sinus hemangioma.
Good morning. I'd like to thank the Walter Dandy team for the kind invitation, and thank you, Professor Ghosh and Pandey for a wonderful organization. And a lot of hard work we've been doing for the last several years. Thank you. And is it on screen? Problem? Well, cavernous sinus hemangiomas are practically the only true tumors of the cavernous sinus. The rest are all juxta tumors. They can come either from the chordomas from the bone, the meningiomas from the meninges. These are the only and very challenging tumors, very humbling tumors. You pray in the morning and you pray in the evening, and then you pray every day. So I'm been told to restrict myself to the surgery. So it's a standard supine position, head turned, a Tyrion temporal incision. Dr. Manmohan has beautifully described all the steps. Thank you. So a standard temporal craniotomy with a zygomatic osteotomy. You don't do a obvious zygomatic unless it's a very giant one. It always helps just to show the residents where the cuts of the zygomatic osteotomy are. Then drilling of the temporal base. These are small valleys and mountains at the temporal base. You must drill them all. And if it oozes, just take a dry diamond, an old dry diamond, and just that actually helps. A couple of millimeters helps there. Widen the foramen spinosum, but the foramen spinosum would be just under the 2 centimeters, just under the root of the zygoma. So if you reach that, that is the foramen spinosum, and that's the middle meningeal artery. Dilate that and divide that. Then work on the anterior clinoid process, cut the tentorial duplicature, also known as the orbitomeningeal band, dissect the anterior cavernous sinus, complete extradural dissection, and then you, this is the V2, this is the lateral of the orbit, so 3, 3rd and the 4th, 6th is here, and then it disappears inside. I love using the knife. Good thing about the knife is it's always 15 number of 11 number. Do not use more than 3 times. So 3 cuts, and you change the knife. We now have very good diamond knives, And when Manmohan was with the Atas, he procured those, and I think they work wonderfully, and they don't go bad. And this is the complete cavernous sinus that you can see. That's a V1, third, fourth, V2, V3, the GSPN, the calcium ganglion. This is the area where you need the exposure for the cavernous, the hemangioma of the cavernous sinus. And these are usually the access point. This is the exposure point. The access into the cavernous sinus is the Parkinson's triangle between the fourth and the V1. Usually this space becomes widened, as you'll see, or even between V1 and V2 sometimes. Then you open this and then you can dissect the tumor. And what you have to see is this is the course of the ICA. This is the intradural, and then it comes like this. It turns and then it becomes into the lacerum. So this is the course of the ICA. So this area, once you've opened the Parkinson's triangle, this area is free. You can decompress the tumor, but these are the areas close to the infralateral trunk, and actually it gets supplied from the meningohypophyseal trunk. That is where you have to go very careful. So it's a pure extradural approach. I can be excised. So I've already talked about the position. So reduce these are the small mountains that I was talking about. Always drill them, the temporal base. It always helps. Middle meningeal artery I was already shown. That's the tentorial duplicature. And the anterior wall of the cavernous sinus is peeled. As a combination of blunt and sharp dissection, around what 80-20. 80% is sharp, 90% and 30% is blunt. And the two layers of the cavernous sinus are peeled from each other. If you are in the plane, you'll never damage the fascicles. Then the cavernous sinus is entered. Here you can use CUSA. So this is the area where it is safe. And then you're close to the carotid. And dissecting it off from there. Sometimes just gets peeled off, and the carotid is, you can see the shadow of the carotid there. Why try not to use too much of a coagulation over the carotid, because the sympathetic plexus, also the sixth nerve is also there. And these are the last bits. You have to dissect them off from the inner surface of the V2, then the V3, and that is from the dura. That's the Meckel's cave. Use some Pippin sealants and because the bulk of the tumor, the middle meningeal foramen spinosum becomes hidden. That is the place where you can actually, you need a navigation there sometimes, but otherwise you can just landmark it from the root of the zygoma. Dilate it. Do not cut it directly, otherwise it retracts and starts bleeding. Take off all the, then again expose the V3, that is foramen ovale. That's the V2. Especially in these large tumors, it's difficult to see this junction, the junction of the membranous and the meningeal layer. Here you can actually then dissect. So it's a combination of sharp and blunt dissection. The simplest dissection is over V3. V2 is difficult. V1 is very difficult. And then here we are down. Separate the two layers. No need to take off the anterior clinar process in cavernous hemangiomas. You just need to take the base off, not the tip. And then, so you don't need a retractor also. You can just put some sutures, foro silk. And that's the V1 being separated up. The fourth nerve is above. And here, this portion of the tumor, you can use CUSA easily. The problem is this area. This is the area you should not use CUSA. You should dissect it. Lifting, we are lifting the V1 and the V2. And that's the ICA. And gently dissect it off. and then under the V3. Once the ICA is safe, then you can again decompress. QSA has to be under low power. What if you have a very large ones? These are the ones which are very vascular. And you can see them going to the cavernous sinus, cavernous and the sella. So if you see that, if you trace this tumor, it is actually going into the sella. Let's skip this extradural portion. Yeah, that's important. Lateral wall of the orbit. Protect the periorbita. Take off the lateral wall of the orbit. That's the bone over the V3 foramina vale. You must open up these foramina so that you can dissect. That's the base of the ACP. And that is the V2. So all these foramina have to be widened. You can, at least you must see the nerves going in. And that's we're opening the tentorial duplicature or the orbitopharyngeal band. Bring it down. That's the V3. This is the most important area, the V3 and the V2 junction where the meningeal layer. If you do not do that, that is where you can damage the fascicles of V2. And that is where the tumor is now on the surface. You can put some sutures there, or you can put a retractor, open it up, decompress. And the more you go close to the ICA, you become a bit slow. And then you leave the QSA, and that's the bleeder from the meningohypophyseal trunk. That takes time to take off the tumor, the last bit of tumor from meningohypophyseal trunk. Yeah, that's the ICA. The sixth nerve would be just behind that. We coagulated the meningohypophyseal trunk along with the tumor, but I think then we're dissecting it off and finding the branch. And that is the meningohypophyseal trunk. We had to put a Liger clip there. Initially, I coagulated, but then I thought it'll become a pseudoaneurysm or something. Just put a Liger clip. Checked on the navigation. That's the only where the navigation helps it. The cellular portion, that we are sure of the removal of the cellular portion. Then the hemostasis. Sometimes it becomes very fibrous. So this is where it is less vascular. The last one was more vascular. This becomes a bit less vascular, becomes very fibrous. Here you need to dissect it more. Otherwise, yeah, here you see that you're dissecting between the nerves and the tumor. The dissection is important here. I'll just run through this. And again, decompression, you can use QSA there. If you're away from the carotid, QSA is not a problem. And the nerves, undersurface, we're actually working under the undersurface of the nerves. That's the Doppler. So to conclude, cavernous sinus hemangiomas are challenging pathologies, highly vascular tumors. Aim is maximum, practically total resection with neurological function preservation. Surgery is the gold standard, extradural temporal microscope approach with navigation, Doppler, QSA, cell saver are the best. Gamma knife radiosurgery, we found in our institution to be a very good adjunct. And for small tumors, In case of subtheodral removal and recurrence, it just melts. That just melts with radiosurgery. So I've stopped advising surgery for any tumors with less than 3 centimeters. They just melt with them. Thank you.
Thank you, sir. I now request the speakers, Professor Manmohan Singh and Professor Ashish Suri, to take up their seats on the front row. While our moderator for the session, Professor Kuntal Kantidas, to take up the stage.
Thank you very much, the speakers. We really had an exhilarating session on cavernous sinus. And this gentleman have shown that cavernous sinus is no longer the no man's land. Thank you so much. So we have very limited time for discussion. And as pointed out by Dr. Anil, I think we'll be happy to have a few questions from the youngsters here. Please feel free and ask. Anything? I hope they have made everything clear. So, for their behalf, I'm going to throw a few questions at you. So, Dr. Jawar, very nice presentation. And I must say that you, Dr. Abida, are doing some exemplary work in the field of neuroanatomy, and they deserve a big round of applause from everyone.
Thank you. Thank you.
Especially in India, we are so much after surgeries, and not many of us are into anatomy and teaching. So, Dr. Jawar, you have shown beautiful anatomy in your slides, and Dr. Avida too. Yes. So, my thing is, it may not be possible for most of us here to have that kind of facility at our centers. So, what is your advice to the youngsters here? How they can train with such state-of-the-art facilities that you have?
I think now most of the institutes, they are very much interested in, having cadaver labs and to present these kind of facilities. So only option is to, find a place near you where you can go. And even if, all of you are in medical colleges, you collaborate your anatomy department. And then maybe also your forensic department when they are doing this. You can, of course, you have to, find the ways how you can make most of the day. The only thing is, you have to, as Sir also told, it is very important once you go into, this cadaver lab and understand this anatomy, and then you do have such kind of lesion, it becomes very easy. So I am not working in a very high volume, some central hospital. I am working in a private setup. And once a while, whenever we get these kind of tumors, so, but when I start doing it, all this anatomy that comes, I have done over the years, and it has evolved, it comes into your mind. Your mind becomes a, navigation tool. So you have to do more and more dissections, and you will find it very easy when you are doing this. You see, you will start seeing these fiber tracks also. You will know which structure is coming. So I will just suggest do as much as possible. Of course, this will help you in your career also.
Thank you. So the message is to have the right intent. If you're interested in the field, you have the intent, then the avenues are in front of you. So we have here some of the senior most and highly experienced pelvis surgeons with us. Some of them are in fact running such programs. So Dr. Suri, so what would be your take on this? Training our younger generation in this complicated exposures.
I think cadaver dissection is the most important. And anatomy, knowledge of anatomy. When we join neurosurgery, it's around about 9 years back. You actually have learned anatomy. The anatomy changes. The gross anatomy is different from the surgical anatomy. Well, I started cavernous sinus in the year 2000 when I went to Dr. Binko Dollins. I became a fan of his. I went there thrice through my holidays, through my own funds and all that, my savings. I used to go to him and to learn. And then I started that thing. So learning anatomy of the cavernous sinus, if you're doing any sculptures, cavernous sinus is very, very important, especially the peeling of the 2 layers of cavernous sinus, you have to do on the cadavers at least 50 times before you can really master those.
Thank you, sir. Thank you. Dr. Bihari, from whom, in fact, I have learned all these tricks. Sir, please.
I'll answer 3 questions which come to your mind, but you are afraid to ask. The first is when you do a pterional craniotomy and the patient comes to you, sir, I cannot open my mouth. What has happened? You just palpate here. Your incision has gone below the zygoma and the temporomandibular joint capsule has been opened. And when it heals, there is fibrosis. That's the first thing. So you should palpate when you are reaching the lower level and ensure that it doesn't come. And along with that, this part of the dissection, do it with forceps so that you try to save the superficial temporal artery. So that in case it is required at any given point of time, for example, with this fantastic dissection which Dr. Ashish showed, you have that, you can do an anastomos. So that's the first point. The second very important thing is, you say there is an asymmetry of the eye, the patient has developed ptosis. Now, that is because of the frontal branch of the facial nerve. Now, how do you preserve it? It's a very simple question, but I mean, I learned it very late. Now, the very important anatomical landmark is it passes from the stylomastoid foramen, that nerve, comes like this, just on the zygoma, superior surface of zygoma, it comes like this, and then goes to the eyelid. So if you draw a line from the tragus to the external angle of the eye, right? And any fascia, rather than going between the fascia, just expose the muscle below it. That nerve will not come. Do you get it? So again, I'll repeat, draw from the angle of the eye to the tragus, right? And take both layers of the fascia along with the flap below this line. That nerve will not come. That's the second point. The third point, which whenever you're doing the dissection, often there is a problem. And that problem is that they say, sir, I opened the cavernous sinus, but there was a lot of bleeding from the cavernous sinus. Okay, and then I had to stop surgery and then go Transylvian or something. The reason why this is happening is you don't realize that the actual petrous apex and where you are actually doing the dissection is at the root of the zygoma. It's not anterior. So what happens is if you go too anterior, which you are exposing in a pterional craniotomy and not focusing on the root of the zygoma, then you are too anterior, and from there the cavernous sinus will bleed. So therefore, the important thing is to palpate the root of the zygoma, keep it at the center of your craniotomy. Then why do you have to go anterior? You have to go anterior because when you cut the meningohypophyseal band, then the dissection of the temporal dura from the cavernous sinus dura becomes very simple. If you don't cut the orbital band, then the temporal lobe continuously keeps bulging when you're doing the anterior petrosectomy. So therefore, you must remember both these things. The focus of your dissection for anterior petrosectomy going to the cavasses quadrilateral is at the root of the zygoma. However, you go from front to back because you want to cut the meningo-orbital band. So these are three important points which I think is the key to getting to this point. Thank you.
Thank you, sir. They were in fact really very valid points. So coming to Manmohan, sir. So you have shown elegant dissection of the cavernous sinus, the peeling and all. But what we also saw was that you had to retract the temporal lobe quite a bit, even though it was extradural. And myself having done some of these cases, I realized sometimes when you open the dura, you find that the temporal lobe is partly contused. So my question to you is, what are the methods of brain relaxation you utilize in the extradural phase of such dissections?
Many times we feel that the CSF release by the just before the surgery after induction that lumbar drain is required. The flip side, it makes everything very lax. The temporal lobe is very lax. You can correct it very well. So many times the situation is that, but there is the oozing for the cavernous sinus is more. Because once the temporal lobe is little turgid and it is bulging out, so the bleeding from the cavernous sinus is less. The only thing is that you have to retract that temporal lobe with a very gently, and many times you don't have to retract with your retractors. So just put past the sutures, foro sutures, and keep on retracting with that. So that helps preserving that the contusions of that temporal lobe per se. And once that dura is over the temporal lobe and there is a CSF is also there, this always gives a buffer to that. So it is a little difficult to contuze the temporal lobe with that dura intact. So retraction with that retractors should be avoided as much as possible. Just pass sutures as you go down, keep on passing sutures foro and retract with those sutures, multiple sutures, and the chances of contusions is definitely less. As you reach the Gasserian ganglion area, already once you be there, the CSF all starts oozing from there, the small from the Meckel's cave. So that keeps on releasing CSF very gently. it keeps your hemostasis intact and it relaxes the temporal lobe also.
Thank you, sir. I think these are very, very valid points that you need to employ a lot of things. For example, positioning of the patient, pulling down the temporalis muscle as much as possible, suture retraction, whenever possible, releasing CSF from these different options. Thank you so much. Now, one question to both of you, Dr. Surya and Dr. Manmohan, is that you have shown elegant intracavernous procedures. So what if the artery gets injured? What kind of backup plan do you have in such situations? Because for the lesser experienced, it could be a hell of a thing.
Well, all these cases, anything you're doing in the cavernous sinus and you want to tamper over endoscopically or transcranially, must get a DSA preoperative. One, see if there's a cross flow. That gives you a pseudo confidence when you're going in the morning. And yeah, and especially it gives a salvage thing that suppose you injure, there's a cross. Second is always have a neck control. In these cases, I don't have a neck control because I'm opening the cavernous sinus. The Glasgow's triangle is there, and you can take the control there. But it's always better to keep it clean, draped, and mark your incision there. Third, keep the Doppler in place, keep your navigation in place, and keep your temporary clips in place. Normally, when you're doing endoscopic surgery, the chances of the avulsion of the meningohypophyseal or the infralateral trunk can be big, or there can be an injury to the ICA. When you're doing transcranial, there are very low chances that you'll actually injure the carotid. The maximum thing would be a branch or something like that, which you can easily pinpoint coagulation there.
Thank you, sir. Dr. Manmohan.
You don't actually nick into the carotid.
Understood, sir.
Once you follow that, all the principles that how you dissect and peel off the dura, so it is very difficult to injure carotid per se, because first you have to have a 3D anatomy of the carotids from your preoperative MRI images. You should always see that MRI that from in relation to the cavernous sinus tumors, where exactly is that ICA from the entry into the carotid canal to the lacerum, and how it drapes that particular tumor in which direction, whether it is inferiorly, maybe it is pushed medially, or many times the bony tumors, which are like the chondrosarcoma or the chordomas are there. So it may be pushed laterally also. So maybe it may be the first thing which you see before you enter that tumor itself. So the preoperative evaluation of T2 images and sometimes the contrast also to see where exactly is the relation of tumor to the carotid. So once you peel it off, then you have to replicate your 3D anatomy of the imaging to that intraoperative picture, that where you are likely to find that ICA. So if you are aware of these situations and your wider exposure is there, it is extremely difficult to damage IC. I never take neck control. So it is possible that you should keep that things ready, but most of the time you will not require it.
Thank you, sir. So the takeaway is you have to plan beforehand. You have to anticipate that a thing like this can happen. Perfect your skills, go to the labs, learn from masters. And if it happens, then you should have some armamentarium ready.
If you don't have neck control and ICA gets injured, then very simple, you just press the neck at the region of the ICA, the bleeding stops significantly. And then you take muscle, mash it up a little and place it then, and then put fibrin glue. So I think fibrin glue should be ready more than anything else. And then by just pressing the neck there, ICA bleeding stops significantly, and then put muscle.
You can do something around
yeah,
it,
that kind of releases thromboplastin, and that also acts like a thrombotic agent. And then with fibrin glue, you can actually get hemostasis at that point of time. Then immediately take the patient to angiogram, suit post-operatively to make sure that there's no pseudoaneurysm development.
Thank you. So the final question, in this era of function preservation, even cavernous sinus surgery cannot be left behind. So my question is, how often do you use intraop neuromonitoring triggered EMGs to find out the nerves of interest when you are going inside the cavernous sinus? If the facility is available with you, should you not use it?
IUNM can be used, but it is for the extraocular nerve. Sometimes the putting that electrodes to the individual muscles sometimes is a little challenging. So it is possible, but definitely challenging. But once you are dissecting the whole of the cavernous sinus lateral wall, so you'll always see V1, V2, V3, and fourth nerve is always visible in most of the tumors. Third nerve is the only thing which is many times it is splayed. It just looks like a arachnoid band. very, very thinned out in a larger tumor, especially the cavernous sinus mangiomas. Is a very grossly bulging cavernous sinus. You will see just under that anterior cleanout process, just lateral to the anterior cleanout process, you will see a very thinned out third nerve. So reason is that you have to have a high degree of suspicion that it is there. V1 is usually a guiding situation that this is the V1 fibers. You will always see that just superior to that V1, you will find that third nerve area. So never venture into that and be careful. Never try to cut any band which looks like a band. It may be a third nerve, especially once that cavernous sinus is bulging. So intraoperative monitoring may be helpful, but in those situations, you sometimes may not be able to see that from where exactly it is coming because the current will spread. It may not exactly localize which fiber is actually that third nerve. So the high degree of suspicion and your anatomical localization by your clinical knowledge is more important rather than your IONM.
So I'm afraid I have to close it now.
Just finish it. I think Dr. Manmohan has taken care of everything. And the V1, V2, V3, the nerves, they're actually seen there. You don't need to stimulate them and see. The problem is the third nerve. Well, you cannot really put IOM. I tried putting one in the laboratory preparation of Apioris. The patient didn't have a third nerve, but the patient had a ptosis because there was hematoma in the LPS. So after that, I made sure I'll never do a third nerve monitoring in future. So I think that answers. Thank you.
So thank you so much. Thank you all the speakers. We had a really very, very interesting session. I thank you and hand over to the organizers.
Thank you, sir. Let's have a break now. Refreshments are being provided throughout the entire day, just outside the hall. And let's resume at 11:50 for a unique session on recent advances in neuroimaging.
All right, with that, we'll resume our session with a brief talk on the recent advances in neuroimaging by Dr. Adityan. Before he begins, I believe Professor Siddharth Ghosh would like to say a few words.
Sorry for the delay. I think Dr. Salim is trying to get on to line for his talk. Yeah, he's come.
I'm good, thank you.
Professor Salim Abdulraf, are we audible? Sir, can you hear
Yes,
us?
thank you so much. Yes, thank you so much.
Professor, you can please go ahead with your talk right now. Thank you, sir.
Well, thank you very much. I'd like to thank Professor Ghosh for his hospitality again to host the Congress in India. To my colleagues, friends in India, this is one of the few times I could not make it there in person, and my personal apologies. You're like family to me, and this Congress, as has been hosted by Professor Ghosh for some years now, has been a great endeavor. So my personal apologies to you about not being there in person. I just had to fly to Kazakhstan this morning. They're hosting an event, a national event to honor Nobel Prize laureates, a group of Nobel Prize laureates in Kazakhstan, and they asked me to serve as a keynote speaker for this event to inspire a young generation in Central Asia to enter the sciences. So this was a special thing that I had to come to for this Nobel laureates recognition. I think it's nice for them to ask a neurosurgeon, one of us, to speak in here, because they see, as the rest of the world sees, that the 21st century will be known to be the century of the brain, with all the work that's going on now in brain interface with AI, and neurosurgeons will always be involved in all these endeavors. So I thank all my colleagues, you in that room, all my friends, and you accepting my apologies not to be there with you today. We look forward to clearly being there next year together. And I miss not being with you. And just I saw the program, what an impressive program with the impressive speakers you have. So I appreciate you accepting my absence this year. And I look forward to seeing you all soon in many different endeavors, but especially Dandy next year. So there'll be a Congress for Dandy in India next year, and there'll be the World Congress for the 10th World Congress for Dandy Society that actually the country of Kazakhstan wants to host a global Congress. And those of you who have not visited this part of Asia, it's a beautiful part. I hope all you will be there as well. So again, my recognition of Professor Ghosh and the organizers of all the hard work. And I look forward to seeing you all soon. Thank you so much.
Thank you, Professor Salim, for the words. It was so nice to see you online, and we really missed you there. This is Anil Pandey here, and
Hi, Neil.
looking forward to having you here next year. Thank you. Thank you
so
very much.
Thank you.
Thank you for joining us, Professor.
Thank you.
On that pleasant note, we'd like to resume with the session with a unique talk on the recent advances in neuroimaging by Dr. Adityan. For that, a few words by Professor Ghosh.
He's been with us in Apollo Proton Center and is an excellent neuroradiologist. And his interpretations on the MRI are so good that most of the time nowadays we diagnose the tumor what it is based on the MRI. And in the city now, in the city of Chennai, he being here for last 3 years, has been recognized as one of the best MRI neuroradiologist in the city. And I'm sure slowly I brought him specially here to give this talk. And incidentally, he got the best young scientist award in the ISNO conference this year. So let us give him a big hand. So here to Adityan, I'm sure all of you will learn a lot from his talk today. Thank you.
Thank you, Dr. Ghosh and Dr. Neil Pandey, sir, for giving this opportunity. Special thanks to Dr. Ghosh, who is my mentor and guide throughout my career after my studies. Okay, we'll talk about the advanced neuroimaging. There are many conventional imaging currently available. I'm not going to talk about MRS, DTA, and fMRI, and other advanced imaging that that we are using in our institute that still currently many centers not having. I think I will explain about these imagings. Coming to the MR perfusion imaging, there are 3 types of MR perfusion imaging currently. Currently, there are ASL, DSC perfusion, DC perfusion. This ASL is the non-contrast perfusion, whereas these are contrast-based perfusion. The ASL will give the absolute CBF value. The DSC perfusion will give about the CBV. This type of perfusion imaging can give information about the tumor grading, identify the molecular characteristics, and give the treatment response and predicting the prognosis. The DCA perfusion is also called the permeability imaging. Coming to this case of left frontal glioma, we did a DCE perfusion, that's T1 perfusion, DSC perfusion, as well as ASL in the same patient. You can get the information about how the perfusion, each of the different types of perfusion giving the information. This is a 30 years male patient with a seizure. You can see there is a glioma, the left frontal lobe in the eloquent cortex in the motor region. This is the ASL imaging. The ASL imaging showed the medial part of the tumor alone shows eye perfusion, indicating at least the grade 3 astrocytoma. This is plan is a pre-surgery MRI. This was planned for as post-surgery surgical planning. After that post-surgery, there was some residual lesion with the raised perfusion, and this is after post proton therapy. You can see the complete resolution of the perfusion. So there's significant good response. So by using the perfusion imaging, you can grade the tumor, you can tell the prognosis, plan the surgical planning, and response assessment you can make. And coming to the perfusion imaging, the ASL imaging can be used even within the lesions which are adjacent to the bones, whereas other types of perfusion, the image quality may not be good. You can't get the adequate information. This is a case of there are two different cases which recently come across. This optic mass lesion within the orbit. Both the lesions showed raised perfusion, indicating it has to be the optic nerve glioma. This is another tumor with along the optic nerve. This is a hypoperfused. This is a case of optic nerve glioma. By using the ASL perfusion, you can differentiate between meningioma, glioma, meningioma, schwannoma, even schwannoma from paraganglioma. This is another case of difficult location enhancing lesion within the middle ear cavity. The ASL perfusion showed very high perfusion. With this high perfusion, it has to be the glomus type of tumor. ASL perfusion also can be used to differentiate granuloma demyelination from the tumor. These are two cases referred. Both are referred as from outside center as a glioma, high-grade glioma. You can see the enhancing mass lesion in the midbrain and another mass lesion with a diffuse pontine glioma-like appearance with the central enhancement. Both the lesions showed hypoperfusion in ASL, and this type of enhancement with hypoperfusion, it has to be, we thought of granuloma, and the biopsy was done, and both the lesions are turned to be tuberculoma. And this is a post-response. The lesion has, after ATT, the lesion has reduced in size. This is another interesting case. It's a case of sinonasal endocarcinoma, which is treated by surgery and radiotherapy. After radiotherapy, the patient came after a few years with the right frontal lobe mass lesion. This is referred to us as a recurrent mass lesion with plan for surgery and proton therapy. This case, we did ASL perfusion imaging. That's completely hypoperfused tumor. This type of hypoperfused, it has to be the radiation necrosis. This is follow-up imaging after bevacizumab. The lesion completely disappeared. This is after 3 years follow-up. Even the tumor is not seen currently. By using the ASL perfusion imaging, you can differentiate the radiation necrosis from tumor progression. In our experience, it's much better than the contrast perfusion imaging. And even we applied this different types of perfusion imaging in meningioma. This is a grade 1 meningioma. This is a grade 2 meningioma. See the difference between the perfusion parameters of each of the imaging methods. And even you can use the ASL as a marker to assess which tumor may require preoperative embolization. And the advantage of ASL is that this is a case of right temporal high-grade glioma. This is a follow-up imaging after radiotherapy. There was a new mass lesion with a bleed. In this case of bleed tumors, the routine perfusion imaging may not be useful and will show some much artifacts. Only the ASL perfusion will give much information. This tumor showed that there is hyperperfusion within the tumor, and this was surgery was done. It is shown to be recurrence. Coming to the DC perfusion, the T1 perfusion is a new another advanced perfusion imaging method. This is permeability imaging method. There are multiple values we will be getting from this imaging method, like K trans VE. This importance of K trans. This will tell about the permeability of the contrast from the blood vessel to the extravascular extracellular space. By this imaging method, there's multiple researchers to analyze the different types of tumors, response, and gradings. Coming to the epilepsy imaging. This one of the 15 years male patient with seizures. This patient undergone multiple imaging outside, and it was told as normal. This undergone ASL perfusion imaging. You can see the definite hypoperfusion of the right temporal lobe compared to the left side. And during the ictal period, the ASL perfusion imaging will show the site of origin by hypoperfusion. Even the digital PET that was done for this case, it showed normal. And after analysis, there was with the narrow window flare images, you can see there was a flare cortical thickening in the right temporal lobe region, which is corresponding to the ASL perfusion imaging. And this is another case of left frontal oligodendral glioma. This is a post surgery and radiotherapy. The patient presented with seizure. You can see the ictal onset with hyperperfusion. This is after follow-up with after few days, the perfusion completely disappeared. The interictal period will be hypoperfusion. Many of the structurally negative epilepsy, the epilepsy ASL will be very much useful and will show the hypoperfusion at the site of origin. Whenever doing referring for epilepsy, always make sure they are doing the 3D flare, which is the mandatory sequence. Many of the centers are doing only axial and coronal flare. Only the 3D flare, you can see the cortical dysplasia well. This is a case of right insular cortical dysplasia with the transmantle sign. You can well appreciate this is a post-surgery scan. The lesion and the transmantle sign was completely removed. These are the mandatory sequence for epilepsy imaging. That is a 3D flare, 3D SPGR, and coronal T2. This has to be done whenever epilepsy imaging is done. And in our experience, the ASL imaging also has to be mandatory sequence for epilepsy imaging. Coming to stroke imaging, any advances? Whenever this left MCS stroke, the CT angio showed there is a complete occlusion. Usually, most centers will do the single phase CT angiography. This is we usually do multiphasic CT angiography. If you are doing only single phase, you will appreciate there is no vessels in the left MCA territory, and you may indicate there is a poor prognosis because of less collaterals. But in the second phase of CT, the left MCA vessels are completely filling, indicating it's actually there is a patient is having good collaterals, and patient will have good prognosis. And follow-up imaging, the patient has a good MRF scale at 90 days. And also stroke imaging, always do when you are doing MRI, just ASL imaging, just 3 to 5 minute sequence, which will give very much information. This is a case of a ACOM aneurysm, post-clipping, and follow-up after 10 days. The left MCA undergone vasospasm, there is infarct in the diffusion, and the ASL perfusion, there is a complete hypoperfusion of the left MCA territory, and showing significant mismatch. This patient undergone emergency balloon angioplasty, and the patient symptoms improved. This is a further advancement in the ASL imaging called multi-delay ASL that I'm not going to go detail. Coming to the importance of 3D sequences in neuroimaging. 3D compared to 2D sequences, 3D sequences may pick very small lesions, and for epilepsy sequences, the cortical dysplasia, heterotropias will be big, and the 2D sequence there will be many more artifacts which may not be seen in the 3D sequence, and complex anomalies can be better appreciated in the 3D sequence. Even the spine imaging, it's better to do the 3D T2 for assessing the disc and disc prolapse. We did the 3D imaging and we published in JNS, and in that we analyzed around 89 cases of patients of spinal vascular malformation. We proved that the 3D T2 is a more accurate and even compared almost equal to the DSA imaging. This is a case of cord edema. The patient came with cord edema, and in the routine 2D sequence, you are not able to see anything. The 3D T2, you are able to appreciate the flow voids, and the coronal reformment, you can see the vascular channels. It's almost same appearance as the DSA. And also when you are doing vessel post-contrast sequence, always make sure the radiologist is doing black blood contrast images. Black blood contrast images means the blood vessels will be black and the contrast will be suppressed. Whereas the routine post-contrast sequence, which most centers is using, you may not be differentiate between the vessels and the lesions, and you can't differentiate the leptomeningeal enhancement. Usually we will do the black blood imaging, so the small lesions and the even glioma tumors, meningitis are well appreciated. Coming to another new advanced imaging is called amide proton transfer imaging. This routinely we use in our center. This type of imaging will tell about the amide protein content of the tumor, and it is very helpful to know the preoperative grading, prediction of genetic mutation, and diagnosis of brain tumors and differentiation from the treatment changes. We recently published in the Nature Scientific Reports that the usefulness of pilocytic astrocytoma, amide proton transfer in differentiating pilocytic astrocytoma from other brain tumors. These are the two different brain tumors in the same site in the midbrain, in the pons. Same imaging appearance in the conventional imaging, but the amide proton transfer imaging, you can see the difference between these two type of tumors. This was proved to be pilocytic. This was proved to be diffuse midline glioma. And this is one of the another interesting case. Dr. Ghosh has referred. This is a case of a mother presented with angioblastoma. This surgery was done, and it was proved to be angioblastoma. After that, a few months, the child, 2 years old, of the mother came, and this also says mass lesion in the posterior fossa. Naturally, you may be thinking the genetic condition VHL syndrome with angioblastoma. This type of large tumor, you must do preoperative embolization. But we did APT, and we found out that it's a definite pilocytic carcinoma, not angioblastoma. This case undergone complete resection, and it is proved to be pilocytic carcinoma. We avoided the preoperative embolization in this case. Coming to another new imaging method like MRI acetylcholine challenge using the MRI ASL technique, which is a new technique we proposed. Usually, acetylcholine challenges is done for any vascular occlusion before bypass procedure. Usually, there are 3 types of response after acetylcholine challenge. There is a type 3 response in which there is a decreased blood perfusion in the baseline, and continued decreased perfusion after acetylcholine challenge is a type 3 response. Only these patients may require bypass. This is a case of right IC occlusion with a small infarct. The patient has recurrent TA. We did ASL based acetylcholine challenge. In India, only a tablet is there. So so MRI, there is no studies. We did first time with the tablet acetylcholine challenge test. This is a pre-acetylcholine challenge. This is a post-acetylcholine challenge. You can see the normal cerebral hemisphere shows increase in perfusion after post-acetylcholine challenge, whereas the right side, the temporo-occipital shows further decrease in perfusion. Only this case require bypass procedure. This patient undergone right ICA MCSTA bypass. This is another case of right MCA near complete occlusion. This patient also has symptoms, and you can see that the baseline perfusion was symmetric and normal. After acetylcholine, the perfusion has further increased, indicating the type 1 response. These patients may not require bypass procedures. We published also a series of cases with acetylcholine challenge MRI based. Coming to the AVM imaging, I'll explain some of the advances in the AVM imaging. This is a case of a case presented with the right cerebellar hemisphere bleed, and the TOF was done, which did not show any malformations. And this case we did ASL imaging, which we can show the blood bright signals. The ASL is one of the highly sensitive technique to pick up even very small microvascular malformation, which is almost equal sensitivity to DSA imaging. So we were told to do DSA, and the DSA confirmed it's a right cerebellar vascular malformation with the blood supplied by the right superior cerebellar artery. This as another case of left frontal AVM. You can see how the ASL imaging picks up the nidus, the draining vein, very well. Coming to the another advancement in the AVM imaging is the 4D angiography. The 4D angiography is a very highly sensitive technique, almost 100% sensitive, equal to DSA positive negative predictive value. Even you can do the vessel selective 4D angio, that is the single vessel can be imaged. This is one of the case of 4D angio we did. You can see this is a case of right caudate AVM. You can see the progressively the multiple frames you can get by the non-contrast. This without contrast we are getting the 4D angio. You can see that the right lenticular state of the MC artery is feeding the nidus, and even the after frames you can see the draining vein. Even you can get now currently this vessel selective. Only the single vessel can be tagged, which cannot be done in any other imaging method. You can see the single vessel, the right MCA alone, ICA alone tagged, the feeding artery, draining well are well seen. This type of imaging can be used for the complex vascular malformation. How is the flow, whether antegrade or retrograde flow? This is a case of AVM, which has treated. This pre-treatment scan, you can see the nidus draining vein. This is a post-treatment scan. The complete occlusion of the nidus and draining vein, you can appreciate. Currently, you may not need the DSA to confirm the diagnosis also. And you can use the 4D angio even for the Moyamoya disease. This is a case of left STA MCA bypass. You can see the left STA is supplying the MCA. The MCA is filling retrogradely. There's a paucity of vessels in the right side. You can, this type of complex anomalies, you can do the 4D non-contrast angio techniques. Coming to the vessel wall imaging, we also published the vessel wall imaging, and the vessels, even the MCA vessels, the small vessels. Actually, the wall of the vessel of MCA is 0.2 to 0.4 mm. Even this much tiny vessels also can be imaged now currently with the new technique, vessel wall imaging. By this vessel wall imaging, you can differentiate between the atherosclerosis, vasculitis, RCVS, and Moyamoya disease. Especially for neurosurgery, when an adult patient comes with right ICA narrowing, you have to differentiate between the Moyamoya disease and ICAN, because the treatment of choice is different. It's a case of Moyamoya disease. we did a vessel wall imaging. The usually vessel wall imaging, the Moyamed disease shows negative remodeling and a very thin concentric enhancement, whereas the atherosclerosis will shows concentric type of enhancement due to the fibrous cap and lipid core. And dissection flap also can be appreciated in dissection cases. Recently for aneurysm also, the vessel wall imaging can be appreciated, well used, especially for assessing the instability, surrogate marker for predicting the aneurysm instability. Whenever the incidentally detected aneurysm is done, you are able to see. And also when there are multiple aneurysm which with subarachnoid hemorrhage, which is the culprit aneurysm, can also be appreciated by the vessel wall imaging. Only those aneurysms will enhance. After post clipping and post stenting of the aneurysm, you will be doing the CT angio and MR angio, but most of the cases you will be seeing the artifacts in the aneurysm and the vessel wall you cannot be appreciated. This is a case of we did series of cases with post stenting and post clipping aneurysm. We did silent MRA, new technique. This is a routine TOF MRA and CT technique. You aren't able, so much artifacts will be there. You are not able to appreciate the residual aneurysm patent vessel. This but in the silent MRA you will be able to appreciate the aneurysm and the vessel, adjacent vessel very well. Almost similar information to the DSA. You are able to get the information by this new technique. MR neurography, till now you'll be sending for brachial plexus, lumbosacral plexus, even peripheral nerves neurography, but most of the previous techniques are cumbersome. You'll be getting the 2D sequences and the nerves may not be well appreciated. Now currently with advanced imaging, you may be able to appreciate each of the nerves very well. The brachial plexus, this is one of the case referred. We did neurography. The right brachial plexopathy is there. You may be appreciating the root, strengths, chords, divisions, almost similar to the routine anatomical book images. This is the same case with the brachial plexus neurography imaging. Coming to another one of the resting state fMRI, usually pre-surgical, pre-operative setting, you will be setting task-based fMRI. Task-based fMRI means the patient will be doing some task, finger tapping and leg movement. You will be getting the images. But many of the patients in a young child and non-cooperative patient, sedation patient, you can do resting state fMRI without any task. This is a case of left temporal glioma, 2 years old child. We did resting state fMRI. You are able to get the information about the hand area, language area, and the default mode DMN network. You can be able to appreciate. Coming to another one, the quick-term imaging. We recently used some of the, by using the quick-term craniotomy imaging, you can maybe appreciating the multiple different networks in the brain you are able to get. This is one of the case we did. It's a left frontotemporal glioma, it's high-grade glioma. Pre-operative, this is a post-operative MRI. You are able to get the different networks within the brain, language, salience, limbic, many networks. In this case, the limbic networks is very close to the, very close. This is a post-surgery MRI. The frontotemporal lobe is gross totally excised. This is the pre-operative network imaging. This is a post-operative network imaging. You can maybe appreciate the limbic network was affected by this tech surgery. Final talk about radiogenomics. By using the radiogenomics, you are able to now pre-operatively diagnose what type of mutation. This, for example, many of them may be knowing the T2 flare mismatch sign. This is a very highly predictive specific sign. If it is there, it is almost 100% specific. It's an IDH mutation. Why it is pre-operatively the radiogenomics is important? Because in many cases it's useful. For example, in the Lancet journal, it was published that pre-operative diagnosis of medulloblastoma grouping is very much useful because only in the group 4 there is a difference between the subtotal and total resection, whereas the other medulloblastomas like Wnt pathway, there may not be any difference between the subtotal and gross total excision. You may not do aggressive surgery. And summary, there are many conventional imaging, including MRS DTA, but there are many advanced imaging still available, which is not utilized. This will give very much additional information, and in our setting, it will be used, can be used in other institutes also. Thank you.
Thank you, Dr. Adityan, for the very insightful talk. With that, we'll jump into the next session on trigeminal schwannoma. Once again, I'd like to remind everyone to try to adhere to the allotted time in the spirit of keeping things within the allotted time. So I'd like to invite Professor Vernon Velho to elaborate on the surgery of CP angle epidermoid.
Thank you, Professor Ghosh and Professor Pandey for inviting me. It's a beautiful gathering, beautiful place. And I hope the students take the best of this. Well, my topic is slightly offbeat. It is on CP angle epidermoids, and just share our experience and certain technical aspects. Right. Well, coming to CP angle epidermoids, basically they are most beautiful tumors which were described by Walter Tandy, but sometimes it's beauty. Underlying the beauty might be some dangers there, and they are not that easy sometimes to tackle. They're basically dysontogenic lesions, and they appear bright white, and they are not very common. They form around 0.2 to 1.8%. And the CP angle area is the most commonest area. Now, with advances of imaging, we can, precisely diagnose them and also plan an approach for them. And it is the basic disseminated growth pattern which makes sometimes excision very tough. And it tends to creep down the CSF spaces, and you have to go on chasing them until you reach a dangerous area. So that is the problem with CP angle epidermoids. This is a slide for the residents. You have to know all the 30 causes, all the 30 different types of tumors which can occur at the CP angle lesions. And these fall within extra-axial lesions, and they are a low T1, which has to be differentiated from 3 types of cysts there, which I will tell you later. So it was first reported in 1683, then in 1854 it was labeled as an epidermoid, and there are various theories which are ectopic inclusions of epithelial cells, and the other one is the dysembryogenesis, which occurs due to secondary disruption of the neural tube in 3rd and 5th weeks of gestation. Now, coming to histology, it's classical. You have to have a keratinizing stratified squamous epithelium, which has to be seen as a pearly white wax tissue formed with concentric lamellar deposits of keratin as well as cholesterol. And the spread, again, as you see, it is takes the natural canals, it takes over the natural canals, and then tends to creep up those normal crevices. Signs and symptoms are subtle for a very long time. They may be just headache. The commonest thing is trigeminal neuralgia, facial paresis, and hemifacial spasms. And sometimes they can present with epilepsy as well as something called as molar meningitis, which at times is subtle or at times gets aggravated when you touch these epidermoid cysts. These are the classifications we have: Sammy's classification, the Thalamic classification, and then also the Rogello classification, which is an important classification for posterior fossa epidermoids. CD findings are important, and they're basically hypodense lesions, but sometimes you might get calcification and also some contrast enhancement, which are the problematic ones. If there is a contrast enhancement, then these are going to be problematic ones for you. The MRI findings are classical. We have the flare imaging, we have the diffusion weighted imaging, where there is a restricted diffusion, but some you can also, 35% can have a contrast enhancement. And these are the tumors which will give you trouble while operating. So differential diagnosis, as I told you, arachnoid cysts, cystic neoplasms, and dermoid cysts, which have to be differentiated before you tackle these tumors. And coming to the surgical excision, it's a safe excision. We still prefer the retrosigmoid approach. There are the other combined approaches depending upon where the tumor lies. But what is important and what residents should know, you got to counsel these patients before you operate, because these tumors are going to come back however much you operate, however much total excision you do. And we have to be keeping them prepared that these tumors are going to come back after 5 years, 10 years, depending on how much you remove. So these are the approaches: classical retrosigmoid approach, then we have the middle fossa approach, and then we can have the combined approaches. And these are the positions which are used. Lateral, we use the lateral semi-sitting position, which is a modification. Then you can have the sitting position also. So coming to this first case, this is a fairly small tumor. It's not that big, but it is anterior to the nerves. So one has to be having a proper position for this. So here we have already done the craniotomy, posterior fossa craniotomy, which should be fairly good for you to expose the epidermoid, release the CSF first, and then go for opening the dura completely. Do not try to open the dura when the cerebellum is coming at you. First, go down to the cisterna magna, and then you see this epidermoid. It will have a layer of arachnoid, then it will have a layer of a pseudocapsule, and then the true capsule will come in. So you have to work in between the vessels, find your area which has maximum tumor first, and then start debulking, decompressing gradually. You got to use sharp dissection in places close to the nerve or close to the vessel. And one can use scooping technique. You can use the tumor forceps, but everything has to be gentle.
so that we do not use retraction. We just use a silicone patty over the cerebellum so that there's no counter tension on the nerves and the vessels. And the difficult part is working under the vessels and under the nerves. So that's the place where one has to be careful. It's a gentle delivering of the tumor. You mobilize, deliver, and then you can work gently below the vessels also. The endoscope is very, very important. You got to check all crevices once you use the endoscope. However, it is slightly difficult because this is the post-op scan. Before we used to use mirrors, dental mirrors, but now the endoscope you can check everything, but always be careful of the vessels and nerves around when you are handling the endoscope. Some epidermoids are tough. They get stuck to vessels and you have to use sharp dissection. This was a tumor going down into the cisterna magna and going right up to the vertebral artery also. So it has to be a gentle manipulation, a gentle peeling off, and you can remove it layer-wise till you reach the brainstem. If you find it is too adherent, you can leave it, but you can gently dissect it, and the capsule tends to come out. It's dissected gradually, and then the endoscope can be put in to check. And here, incidentally, with the endoscope, we could see a small schwannoma in the internal acoustic meatus, which we would have missed otherwise if we had not used the endoscope. So here we are, that's the schwannoma here in the internal auditory meatus, which was incidental, and we could remove it endoscopically and just clearing off that internal. And that's the post-op, what it should look, a clean brainstem and a clean surface. And this is another patient like that, going anterior. I'll just show you sometimes putting the endoscope becomes difficult. When you're coming out with the endoscope, we can have some problems. So always be careful. Use a two-hand technique for the endoscope. So here we are going under the nerve. And work in between the crevices and try to get as much as chunk out rather than use the irrigation right at the end. Otherwise, we'll move, a lot of flakes will go into the CSF spaces, and that is one of the cause for the chemical meningitis. As far as possible, remove solid chunks of tumor. Do not use irrigation in the beginning. And here, while removing the endoscope, see what's happened. The vein gives way. So always be careful while handling the endoscope and putting it between the nerves. So we tried to control this with a hemo patch, which is a fibrin patch. We did not avoided too much coagulation here. And then one can do the rest of the peeling gently. So using sharp dissection. Gentle tug and sharp dissection for the capsule. These are slightly, when it's adherent, slightly the brainstem, but you can get a plane most of the time. If it is enhancing on contrast, one has to be a bit careful. So gradually, if you work on the tumor, one can get a plane over the brainstem also. Here, just if you are coagulating, very low bipolar. That's the chunk which is out. And then one can give the wash. This is the endoscopic view to see that everything is complete, and there are some flakes which can fall down due to gravity, which can be picked up with the endoscope. This is the post-op. She had a mild facial because of that endoscope which slipped, but then it improved on follow-up. So this was a patient which was referred to us as epidermoid. And we were confused because the patient came from out with the MRI. And if you see here, there is a hypodense, hypo-intense structure, and there is a hyper-intense structure and going into the middle fossa. So there were a lot of differential diagnoses. When we opened, it was a hyperostotic bone, which was in front. And we didn't know what it was.
So, and below that bone was a tumor over the trigeminal nerve. So it looked like a trigeminal schwannoma, which was going into the macula scape. So we protect the cerebellum with the silicone paddy before we drill this area. And then we could excise this schwannoma, which was in between, because it was referred to as an epidermoid, because it had a hypo-intense and a hyper-intense component, but it turned out to be a trigeminal schwannoma. So here we are splitting the nerve longitudinally to get to the tumor. We have to drill a bit of petrous apex. And then we could deliver the tumor from the macula cave gently. It's moving towards the macula cave now. That's the tumor coming out from the macula cave. Trigeminal schwannomas are comparatively less vascular. So that's the tumor coming out. From the macula cave. That's the post-op scan. So complications, one has to be ready for meningitis, cranial nerve injuries, and also stroke due to handling of the vessels. Recurrence is the problem, so you have to counsel these patients and keep doing serial scans probably every 1 year to see whether they are coming back. These are series which we have already published in the British Journal of Neurosurgery. And to conclude, epidermoids, although rare, they can cause, they are a common cause of trigeminal neuralgia. Retroscopic approach is one of the best approaches. The use of endoscope, it helps your completeness of excision, and regular follow-up of these patients is required to look out for recurrences. Thank you.
Thank you, sir. Now, can I invite Professor Rajneesh Kachra to speak on combined supra-infratentorial approach to trigeminal schwannomas? Thank you.
At the outset, I must thank Professor Ghosh and Dr. Pandey for including me in this program. And it's honor and pleasure to present this talk. My talk is on the combined supra and infratemporal approach for the trigeminal schwannoma. The trigeminal schwannoma, they are benign tumors, very slowly growing, well circumscribed, and a very, very rare tumors, actually less than 1%, even less than 0.5% of all the intracranial tumors. And amongst the schwannoma, if we see, it is about 1 to 8% of the intracranial schwannoma. But it is the second most common schwannoma after the vestibular schwannoma. Most common symptoms they present is with the fifth nerve symptoms, maybe numbness or paresthesia and trigeminal distribution. They also can present with the facial pain. If there is a complete or near complete anesthesia, it may sometime predict maybe malignant process, something going on which is destroying the fibers. The pain may be either mild or maybe lancenetic pain. It may be constant or intermittent pain. They can have headache, many patients. If there is a sudden headache, it shows maybe intratumoral bleed. Many patients can present with the diplopia due to involvement of the sixth nerve. They can have facial nerve dysfunction, either maybe because of the middle fossa component, or maybe a dumbbell tumor, which can cause compression on the 7th, 8th nerve complex. They can have optic nerve dysfunction. On examination, the majority of the patient will have facial hyposthesia and diminished corneal reflex. They can have weakness of muscles of mastication. You can have a masseter weakness or temporal fossa hollowing. There may be other cranial involvement like second nerve, third nerve, sixth nerve, as much as about 35 to 40% of the patient. They can have cerebral signs when tumor is very large. Various classification has been devised by these scientists. One of the earliest classification was Jefferson classification, depending on the predominant location of the tumor. If it is in a middle fossa, predominantly this is type A tumor, posterior fossa type B, and a dumbbell schwannoma is type C. And later on, Sami has added the type D when tumor is going extracranially. And there are various other classification, more or less similar type. More than 50% of the these tumors usually in the middle fossa, and about 30, even around 1/3 of the patients, they have posterior fossa tumor. And the combined dumbbell-shaped tumor is in about 20% of the patients. So the surgical consideration depends on the where the tumor is located, anterocavernous sinus, posterior cavernous sinus, in the Meckel's cave, or posterior fossa, or extracranial. Depending on that, you have to decide about the approaches. This is, I am just showing from the literature, Professor Goel, who is going to speak after me, and he has probably the largest series of operating on the trigeminal schwannomas. This is a paper by Professor Almefti, and the title is the removal of dumbbell-shaped tumors through the expanded Meckel's cave. And probably in the majority of patient, if it is a good corridor between the middle fossa and posterior fossa, the posterior fossa component can be removed, provided you have a very lax brain and there's good amount of space because of erosion of the petrous apex. And he devised this approach is extradural zygomatic. Usually these tumors we go with the extradural middle fossa approach. This is another paper. They have probably the A type, C type, and D type tumors can be targeted with the middle fossa approach, except for the B tumors, which are in the posterior fossa. Usually they are removed by the retrosigmoid approach. Sometimes in type C tumors, which is in the middle fossa and posterior fossa, we may require to use combined approach to remove the tumors in the both the locations. So this is, I will just show some of the examples of, this is the tumor, the young boy presented with the symptom of trigeminal dysfunction and diplopia. And this we had operated. This is a perioperative picture. You can see this is the V3, V2, and V1 division. And you can see the carotid artery. This is at the end. And this tumor had, this patient had a small residual at the Meckel's cave. We are following him up, but his diplopia is improved. There's another tumor, again extradural middle fossa approach, and this tumor is completely removed. And patient did not have any deficit related to the trigeminal nerve. Again, similarly, this tumor, large tumors, they can be removed very well with the extradural middle fossa approaches. Sometimes tumor is exclusively in the posterior fossa, and these tumors need a retrosigmoid approach to remove these tumors. And this is, these are all operated very long back when I was working with Sri Chitra. This was operated almost around 30 years. This is the time probably MRI was also not there. So this is again, the tumor is in the middle fossa, posterior fossa, and there is a small component in the middle, in the Meckel's cave. But we operated, and the patient was very much symptomatic in the sense he had a 7th nerve, he had 8th nerve symptoms, he had a severe gait ataxia. Probably the tumor is had a repeated subclinical bleeds. There was a lot of adhesions while removing this tumor, and it was quite adherent to the fifth nerve. And this is the postoperative CT scan, shows complete excision, though there's a maybe middle fossa component is still lying. We are following this with the serial imaging. So coming to the topic which has been given to me, the combined approach is usually very seldom required to remove these tumors. As I said, if there is a good corridor and brain is quite lax, you can access the posterior fossa component from the middle cranial fossa, and you can remove a posterior fossa component from the same approach. But many times, if tumor posterior fossa component is quite large and you cannot access the lowermost portion and brain is not relaxed, then you may have difficulties removing the tumor from the middle fossa. So this is one paper by James Liu. He has advocated this approach, combined petrosal approach for resection of the large trigeminal schwannoma. What it says is that the depth of the surgical target in the superomedial corner of the CP angle and the petrous apex makes sometimes it is difficult to remove these tumors. So he advised anterior petroscopy like this petrous apex removal and the posterior petroscopy retrolab approach to access these tumors, to remove these tumors completely. So this is about the posterior petrosal approach. We can pre-sigmoid and the middle fossa craniotomy is done to remove these tumors. This is the one example. We had operated this patient in 1996 when we were just started our career and learning these approaches, and we accessed this tumor by this combined approach. And though today probably the middle fossa approach is enough to remove the posterior fossa component, and this is the post-op MRI which shows the complete excision of the tumor. Another tumor which I had operated very recently, there is huge tumor in the middle fossa and the posterior fossa. Decided to do a combined approach, but then the previous we had difficulties in getting the very lax brain to access the posterior fossa component. So in this, I removed with the two separate craniotomies, the middle fossa component with the temporal craniotomy and the posterior fossa by retrosigmoid. I'll just show a small video of this. So this is the middle fossa, large tumor, and this tumor is coming out from this dural layer. This patient was greatly symptomatic. She had a 7th nerve, 8th nerve, great ataxia, 5th nerve, all the so this is the middle fossa component you can remove with this. Then we have did another craniotomy for the posterior fossa component, and this is the, and here the important is, I mean, you can release the CSF from the basal cistern here, cisterna magna, and you can make the brain very lax so that the tumor becomes, I mean, tumor removal becomes easy. So here, this is the 7th, 8th nerve complex, and the tumor is above that. So this is the two craniotomies we have removed, and this is the postoperative CT scan, this MRI. There is some residual tumor here. This was quite adherent to the brain, and it is going quite low. So from that approach, combined approach, it was, I feel it was difficult, and what we have done is, and we are just following with this MRI. This another tumor which we have removed by combined approach. Tumor was quite vascular, very vascular. Brain was quite tense, and we couldn't remove this tumor completely. This was also operated in 1997 when I was working at Sri Chitra. I don't have a postoperative MRI imaging. So these are the other examples. This is in the posterior fossa component is posterior fossa tumor can be removed with this cerebrosigmoid craniotomy. Another tumor mainly in the posterior middle cranial fossa, and this is postoperative MRI scan showing complete excision of tumor. So with this skull-based techniques, the surgical resection of the trigeminal schwannoma can be achieved with a very low morbidity and mortality. the total resection rate is very high, about 75 to 100% tumors you can remove. The recurrence rates are also quite high, up to 60% has been reported when these are involving the cavernous sinus. But with the use of skull-based approaches, the recurrence rate is about 10%. And the recurrent tumors can be managed with the reoperation or adjuvant treatment. So in summary, the total resection of trigeminal schwannoma is treatment of choice. Surgical approaches are directed to the intercranial location of the tumor. Extradural skull-based approaches increases the resection rates. Tumor extending to multiple fossas poses a surgical challenge, and endoscopic skull-based approaches can be used in selected cases. Radiosurgery can be used in recurrent ones, residual tumors, or inoperable cases with good success. Thank you very much.
Thank you so much for a nice talk. Next, as Professor Goyal has just arrived, he got delayed due to traffic. So what we will do is we will postpone the discussion to after his talk, and we'll go on directly to the pineal tumors now.
So moving forward to our next session on pineal tumors, moderated by Professor Manas Panigrahi. I now call upon Professor Abida Shah and Professor Sukhdeep Java to take us through the 3D microsurgical anatomy of posterior third ventricular region. Once again, a gentle reminder to all the speakers to adhere to the allotted time. Over to you, sir.
So back again, while this thing is getting set, now we are going to see the anatomy of the most intricate part of the brain, the center of the brain, the posterior third ventricular region. As you can see in this anatomical image. So this is the region whose anatomy we are going to study. Here you see, this is the region of the velum interpositum, and it is opening into the quadrigeminal cistern, and you see the great vein that is going here into the sinus. So let's look at this anatomy. So this is the medial surface of the brain. This is, of course, the corpus callosum, the fornix. This is the lateral ventricle. This is the interventricular foramen of Monro, just beneath the fornix here. And as it enters, this is the region of the third ventricle. So the third ventricle has the thalamus, the hypothalamic sulcus, and the hypothalamus. We are going to see this posterior part of the third ventricle now more closely. So now you look at this structure here. So this is the posterior third ventricular region. The roof of the third ventricle here is formed by the velum interpositum. You see this fiber tract that is going all the way from here, the septal area, right up to the pineal region. It actually goes to the habenular nuclei in this region, and that is the stria medullaris thalami. This is the pineal gland that you can see. Here you can see the dissection of the fornix as it is going into the mammillary body and the beginning of the mammillothalamic tract. This is the ependyma on the thalamus. Now here you can see this image. Here, this is the region of the velum interpositum. So this velum interpositum forms the roof of the third ventricle, and it is made up of a series of layers which constitute the tila choroida, the internal cerebral veins, the medial posterior choroidal arteries, and there are 2 layers of tila choroida. So sometimes this velum interpositum opens into this region with a cave, and it opens straight into the quadrigeminal cistern. Here, this is the superior and inferior colliculi, and let's go further. So now looking at the roof of the third ventricle, this is the view from the top. Here you can see this is the arachnoid of the velum interpositum and the tila choroida. These are the internal cerebral veins. These are the choroid plexuses as they are coming in from the foramen of Monro. Once you reflect the internal cerebral veins, here you see the medial posterior choroidal arteries and the second layer of the tila choroidea. Once you open this, you will enter into the third ventricle. So now this is the cavity of the third ventricle as you view from above. This structure that you see here is the massa intermedia as it is connecting both the thalami to each other. And this structure anteriorly is the anterior commissure, and this structure posteriorly is the pineal body. Now, when you look from inferior aspect, so this is the base of the brain. So here, this is the region of the aqueduct. And what happens when you make a cut section like this, you will still enter into the third ventricle. And this is how it looks when you cut it like this. So here you see three important structures. The first one there is the anterior commissure. That one there is the columns of fornix. That is the interventricular foramen of Monro. This is the massa intermedia, and this is the posterior commissure. So you see this is the anterior commissure and posterior commissure line as they form. They come in the same plane when you look at it from the inferior perspective. Now, how do we approach this region? We will go by the approach and then see the anatomy of this posterior third ventricular region. So you can either come from occipital transtentorial and approach this region, or you can come supracerebellar infratentorial and approach this posterior third ventricular region. So we are generally more comfortable with this supracerebellar infratentorial approach. There are some veins here, the cerebellar veins, and then you have some other veins that connect this to the tentorium, which normally have to be transected if you want to access the posterior third ventricular region. So when you look from top, when you're coming occipital transtentorial, this is the view you'll get. You'll get the splenium, you'll get the veins here, and you'll get the superior and the inferior collicula in this region. The tent here has been cut. And when you look from down, when you look from a supracerebellar infratentorial approach, this is how you will see it. So this is the region of the splenium. These are the veins as they're coming down. This is the region of the superior and inferior colliculi. This is the cerebellum that has been retracted downwards. So again, this is another view you can see from the supracerebellar infratentorial approach. So this is the precerebellar vein. This is the superior and inferior colliculi. These are branches of the superior cerebellar artery as they are going to supply the colliculi. These are the basal veins of Rosenthal. These are the internal cerebral veins, all connecting together to form the great vein of Galen. Once you remove this vascular anatomy, this is the region you will see. Here you will see the superior. So this is the splenium. Now I have depressed the cerebellum here and splayed the occipital lobe. This is the region of the superior medullary velum. This is the frenulum veli. This is the superior and inferior colliculi. And when you look here, you will see the pineal gland. So when you approach it from here, if you look upwards, this is the splenium, you will see the two fornices that are going here, and they are connected together with the hippocampal commissure. So this pineal body is the most important structure in this region. It has, when you look from the lateral aspect, on the superior leaf of the pineal body, you have the habenular commissure, and on the inferior leaf, you have the posterior commissure. So this one here is the frenulum veli, and just next to it laterally, you will see the fourth nerve that is coming out and encircling the cerebral peduncle. These are the superior and inferior colliculi. This is the thalamus, and this is the region of the medial and lateral geniculate body. So again, you now see this. So when you're exposing from the supracerebellar infratentorial approach, this is how it is. So this is the region of the posterior third ventricle. This is the massa intermedia. This is the view you normally get after you're resecting the tumor. This is the pineal body with its superior leaf having the habenular commissure and inferior leaf having the posterior commissure. This is the thalamus, and here the superior and inferior colliculi. This is generally how much you will see. You normally do not see this. You have to depress or suck through the vermis to see beyond this level. So what happens beyond this level? So you see this frenulum veli, and you see the fourth nerve as it is coming and going around the cerebral peduncle to the anterior aspect of the brainstem. So this is the only cranial nerve that arises on the dorsal aspect of the brainstem. This is the pineal body, and here you see the superior and inferior brachium as they are going into the medial and lateral geniculate body. So now you can see it very nicely, the posterior third ventricular region. This is the mammillary bodies. So the fornix and coming into the mammillary bodies in this region. So this is the superior colliculi. You see this auditory tract will go here and go into the middle geniculate body. That is the superior brachium. And this is the inferior brachium, and it will go to the lateral geniculate body. Here again, you can see the frenulum veli. Now this structure here is the superior cerebellar peduncle, and they are connected by a thin layer here. That is the superior medullary velum. And in this layer, just beneath, you will have the globose and emboliform nuclei in the cerebellum. This is, of course, the thalamus and the choroid plexus as it is running in the choroid fissure. So again, a view into the posterior third ventricle. So this is the region of the habenular commissure. And once you lift the pineal body, you will see the posterior commissure. So going further down, you open the superior cerebellar peduncle and the superior medullary velum, and you will straight enter into the region of the fourth ventricle. So in this part of the fourth ventricle, the ependyma has been preserved. In this part, the ependyma has been removed. We will discuss the fourth ventricle in the posterior fossa, but just quickly to show you the abducent nucleus forming the facial colliculus. These are fibers of the facial nerve as they're turning and coming out in the region between the pons and the medulla. And then this is the median sulcus. We will discuss this later. Here again, you can see the fourth cranial nerve as it is coming. Now the approach is the vascular anatomy that comes in the way when you're using the supracerebellar infratentorial approach is you're entering basically through the cerebellomesencephalic fissure. So this is the midbrain, this is the superior surface of the cerebellum, and this is the cerebellomesencephalic fissure, which you can see here. Now these are important branches of the superior cerebellar artery, the last part that goes on and goes on to supply the tectal plate or the superior and inferior colliculi. Some branches of the posterior cerebellar artery also go in this quadrigeminal area and supply this tectal plate region. So coming laterally, so we saw the midline supracerebellar approach. What happens when you come laterally? This is the lateral perspective, and you will depress the cerebellum and see all the cranial nerves in this region, the fifth cranial nerve, the seventh, eighth complex, and here the lower cranial nerves. Here on the top near the 10th, you see the fourth cranial nerve. Here you see the superior cerebellar artery that is entering, and you see the superior petrosal vein. When you depress the cerebellum, so this is the lateral perspective of the view where you see the colliculi, the fourth nerve, which you have to preserve, and you know it runs very close to the tentorial edge. And this is another region that is normally used to approach midbrain tumors, the lemniscal triangle, or we have also described a lateral cerebral peduncle approach, which goes to the temporopontine fibers, and you can enter the midbrain safely in this region. So this is the region of the lemniscal triangle. This is the superior and inferior colliculi. These are the geniculate bodies. This is the cerebral peduncle, and this is the fourth cranial nerve as it is turning and coming anteriorly. This is the third cranial nerve that is coming out from the region of the interpeduncular fossa. So when you depress and look in the cerebellomesencephalic fissure, here you see the basilar artery with its superior cerebellar artery that is branching here. It is dividing into two parts, and both these loops generally run very close to each other. Here you see the third nerve, here you see the fourth nerve, and this last part of the superior cerebellar artery goes on to supply the quadrigeminal plate. So again, a view from the lateral aspect where you see the superior cerebellar artery going on to supply the quadrigeminal plate. And that is the vascularity of the third ventricle as seen from the ventricular perspective. You see these choroidal branches that enter. So the middle posterior choroidal artery is a branch of the posterior cerebral artery, and it enters here into the roof of the fourth ventricle. And here you see this, the pineal body. So this superior leaf here is the habenular commissure, and this inferior leaf here is the posterior commissure. And that ends my presentation. Thank you very much.
For both the sessions, can I request Professor Sarat Chandra to be the moderator for the last one and this one too?
Thank you, ma'am. Now moving on to our next session. Before that, there's an announcement for the participants for the second session of the workshop on microvascular anastomosis. Dr. Poonam, Dr. Adrian, Dr. Dheeraj, Dr. Abhijit Acharya, Dr. Manimaran, Dr. Manamanan, Dr. Nitish Kumar, Dr. Ashish Kumar, and Dr. Satya Rangme are requested to go to the neighboring hall for the workshop. And then now our next talk, I invite Professor Sanjay Behari to deliver his talk on midline supracerebellar approach to pineal tumor. Over to you, sir.
For all the participants, every of these lectures will be online also. So when you are attending the workshop, you can definitely come back to these and listen to them. So don't get worried about that. Utilize both the workshops to your benefit. Thank you.
So I'd like to talk about not just one approach, but approaches to posterior third ventricular region. And so, as Dr. Abhita said, that if you look at what exactly is midline posterior, what is posterior third ventricle? It is from the posterior to massa intermedia of the thalamus to the mammillary body. Anything posterior to that is the posterior third ventricle. And what are the things that we look for? One is the enhancement characteristics, the invasiveness and hydrocephalus, whether the torcula is angulated, it is very low lying, and what is the tentorial angulation at this point? What is the relationship of the tumor to the deep venous system? Is it infiltrating or where it is? and where the lateral extension is very important, because unless you look at the lateral extension, it won't be no. Tonsillar herniation is another thing which is very important, and whether there is CSF dissemination. Now, coming to infratemporal supracerebellar approach, this 8-year-old child had this lesion here, right in the midline, not going to the opposite side. And when we are actually placing it, it's a slouch position so that it has to come as close to you as possible. Our 2-finger rule here, because the neck should not be too compressed. You must make sure that the shunt is not coming in the pins. Then you must try to make the tentorium is like this. So this has to become horizontal with your position. The upper limbs have to be supported properly. The venous return has to be supported because this patient is in sitting position. You have to have long instruments which go in, and you have to have a slow elevation of the patient, because otherwise the patient will go into hypotension. And finally, you have to take care of deep vein thrombosis and all that, which is also there. So in this patient, after a suboccipital craniectomy, the dura is reflected upwards, the occipital sinus is coagulated, and then you see the cerebellum. And gently you retract the cerebellum downward. You see the basal vein of Rosenthal there, and you see the tumor covered by the arachnoid. And this is the tumor which is present, and this was actually removed. Just to tell you, so this is the lesion which is right in the midline. So it is, so this is the child. You can see the shunt here. You have to be careful that the shunt does not come in your surgery. This is the cerebellum. There are some veins. The lesser veins you coagulate, the better it is, because the rest of the veins support the cerebellum with the tentorium. Then as you go in, you see the basal vein of Rosenthal, and you see the tumor right in the center of the veins. And this is quite oblique. So this is the superior vermis. So with your bipolar, you gently bring down the superior vermis, and then you see the arachnoid just superior to that. And as you open the arachnoid, it appears very glistening here, because it is extremely thick because the tumor. You see the basal vein of Rosenthal and the central thing, and they are all superior to the tumor. Then as you go on dissecting, then you see the precentral cerebellar vein. So this is the arachnoid, and you see the precentral cerebellar vein in the center. Now, many times you can work on side of the precentral cerebellar vein, or sometimes you can actually coagulate it. But sometimes this itself may cause superior vermal venous infarct. But as far as possible, you should preserve it. But in this case, the tumor is right anterior to this, and you can see the arachnoid of the tumor, and this is the basal vein of Rosenthal on either side. And the important thing is there is a lot of obliquity. So now you see the precentral cerebellar vein, the basal vein of Rosenthal on either side, and this is where the tumor is. And you do need very, very long instruments. Here we coagulated the precentral cerebellar vein. If it is very lax, then you can shift to the side and resect the tumor. Or you can work from one side of the precentral cerebellar vein. So now, as soon as you do that, you see the tumor covered by the arachnoid. And most of it, you should make sure that you are not going too much lateral, because as you go lateral, there are veins there. And when you coagulate the veins, since the patient is in sitting position, there is a negative pressure. So post-operatively, there is a possibility of hematoma formation simply because you have missed out one small vein. And then within this, you can go on decompressing gently, very slowly. There's no need to hurry up, and go on decompressing, making an arachnoidal dissection there. And as you separate the basal vein of Rosenthal, you can see the tumor, and the tumor has been removed. And you can see the CSF coming from the third ventricle. Then the last part of the tumor, which is just anterior to the vermis of the cerebellum, is also an important portion that you need to remove. And you see that there is CSF coming, and this is the part of the tumor which is like just anterior to the anterior vermis of the cerebellum. And as you do this, the CSF starts draining, and you are now entering the third ventricular region. So this is the last part of the tumor. You can see the CSF coming, and these are the basal vein, and the tumor has been removed completely. And so now coming to the next approach, which is an occipital transtentorial approach, which in fact I use more than the infratentorial supracerebellar approach. And this, especially when the tumor is going to one side or it is going very high up, then of course it is much easier to come. Or if it's a very large tumor, or if you anticipate it's going to be a very vascular tumor, then it's much simpler to come from above than to go from below. And so the important thing is, the better thing is a prone position. This is also the thing. You see the transverse sinus, you see the midline, and then you can just make a small approach here. And this has been given in the atlas that we published. And again, the important thing is that you have the straight sinus in the center. This serves as your landmark. And then you have to just give an incision parallel to the tentorium. So this is the tentorium. You have to give it parallel to the tentorium, and you will work between the straight sinus, the vein of the Galen, and the basal vein of Rosenthal to actually reach the tumor. But if the tumor is on both sides, then you can actually cut the tentorium, the falx above and the tentorium below. So on one side, you're working with the falx in place, and on one side, you're working with the tentorium, and this gives you space above and below the sinus. So you see that this is an interhemispheric approach. This is, you don't lift up the occipital lobe. This is interhemispheric. You hardly get any veins there. You can cut the, then you see where the straight sinus is, and then you cut the tentorium, and you can also cut the falx to go to the both sides. This was an epidermoid, and we removed it. I'll just show you the video. So now you see where the straight sinus is. This is very important. Even if it takes you some time, please go on seeing where the straight sinus is. And there are usually venous lakes parallel to the straight sinus. So just work even to the straight sinus. You can always reflect the tentorium, and the tentorium has 2 layers. So when you cut the 2 layers of the tentorium, then there will be a little bleeding. So always you must make sure that you are cutting both the layers to reach the superior vermis of the cerebellum. By coagulating, continuous coagulation, there is going to be no venous bleeding. The other important thing is that sometimes this is the arachnoid covering the epidermoid. The important thing is that some people will just go subtemporal and never reach the incisura. The incisura is very close to you. So if you are not getting the incisura, it means you are going subtemporal and reaching right up to the, from the occipital region to the tentorial region. But if you are in the right plane, then you get the incisura, and then you just get the tumor, you open the arachnoid, and the entire tumor comes out. The advantage of this approach is that you can do a very good hemostasis. You get the posterior third ventricular region, and you can see the superior cerebellum. The only thing is sometimes you will have to work between the veins, and this is the image. Then, of course, this is an epidermoid. And so now this is a large meningioma, which is a phacotentorial meningioma. And you see that the vein is on one side here. And here, what we've done is, first, there was a lot of hydrocephalus. So a little bit on the parietal lobe, we made a small cortisectomy and drained the CSF, and then went interhemispheric. Then again, I told you, go parallel to the vein and just go parallel to the straight sinus there. Go right up to the incisura, decompress, decompress, decompress. And if you require, then also open the falx, go to the opposite side, and then the final tumor. So this is you can see that this is the parietal small, just did a little cortisectomy there, put some ventric needle, just drained cerebrospinal fluid from there. So that as soon as you do that, the whole parieto-occipital lobe becomes very lax. And you see it almost starts moving away from the falx. It's very important not to put the retractors on the occipital lobe. This is anterior, this is posterior. So you must understand that very gently, you just need to make sure that the lobe is just retracted and not really injured. And then you always locate the sinus, and you see that the incisura is very close to you. If it is taking a lot of time, then you are actually going subtemporal or along the falx. So this is very, very important. And then the other thing is the incision has to be away from the straight sinus right up to the tentorial incisura, so that you get enough reflection, and that is the tumor that you see. This is the meningioma that you see. In this particular situation, the straight sinus and the vein of Galen were opposite sides. So you work on the side where the tumor is located, and gradually, with gradual decompression, you can actually remove the tumor. Even if it bleeds, it is much simpler to actually perform hemostasis from the superior aspect than to come infratentorial supracerebellar. And the arachnoid is being opened, and this is the falx here, this is the tentorium here, this is the straight sinus, and this is the part of the tentorium that has been opened, so gives you a lot of cavity to actually take care of the tumor there. And then gradually, as you go on decompressing piecemeal, the tumor kind of shifts into your field, and then you can actually remove the entire thing. Sometimes what happens is that the tumor on the contralateral side is inaccessible. So in this case, you might have to use another approach. So you do not use a bilateral interhemispheric approach, because that may cause homonymous hemianopy on both the sides. So in that case, you might have to combine an infratentorial supracerebellar approach with a occipital transtentorial approach, especially in cases of a large meningiomas or large infiltrating tumors. And then, you know, even if it bleeds, like a large meningioma might sometimes bleed, it does not matter, because, you know, you're looking from above downwards. And then you again and again get oriented to the straight sinus. That's a very important point. And cut the tentorium. So this will bleed a little, because this is in 2 layers, so it might bleed a little. But then as you cut, then you will be able to see the entire tumor there, and then you can actually decompress the tumor. See, so you get a large space there, go on decompressing, and then finally you get the entire tumor there. The very important thing is, do not use a CUSA too much, because if there is a vein which is right opposite, then it might get injured by the CUSA. So it's very fibrous, small coagulation, piecemeal decompression, and this is the final tumor. So this is, you can see that the vein is shifted to the opposite side, and you must take care of this. Just 1 minute, I'll just take. An anterior transcallosal transforaminal subchoroidal approach is a very nice approach. So you go to the interhemispheric fissure, go to the subchoroidal root here. You can also reach the posterior third ventricular tumor. You can actually do a third ventriculostomy and do an endoscopic biopsy before you remove the tumor, because in many of these cases, just if it is a germinoma or a pinealoblastoma, then just by doing radiotherapy really helps. The difference between endoscopy and stereotaxy is, stereotaxy in this area is very difficult because there are veins on above. But the problem with endoscopy, if you take a biopsy, it's a very superficial biopsy. So if in a glioma, you might not get a representative sample when you're taking it further. And here, what we did was removed an dermoid endoscopically and see that there was a severe ventriculitis, and this child did not do well. They're still living almost blind and with significant cognitive disturbances. So, and of course, gamma knife is also a very important thing, and chemotherapy is also a very important thing. This is my last slide, which actually tells you that the 5-year survival in cases of posterior third ventricular tumors are very, very good. Except for malignant germ cell tumors, most of them have a very nice 5-year survival. So therefore, these tumors have to be treated very aggressively. Thank you very much for your kind attention.
Thank you, sir. I now call upon Professor S.S. Dandapani to deliver a talk on front and back endoscopic approaches to the pineal region. Over to you, sir.
Thank you. Thank you for the wonderful talk, sir. Professor Bihari, sir, had beautifully explained all the nuances of pineal region surgery. Before my talk, I'll just show a video, a 3D video of exoscope. And then I'll start my talk. You can wear 3D glasses. Yeah, it's coming. Yeah, regarding the position and approach nuances, Professor Bihari sir had already covered. This is done, the initial part of this surgery is done with the help of a 3D exoscope. The advantage of 3D exoscope over microscope is that it has greater depth of field. That means you see both deeper structures and superficial structures at the same time in a clear manner compared to microscope. Microscope has excellent resolution, but it has a shallow depth of field. So the point of focus, you see the best, but deeper and shallower parts are not that much focused. So whether it is useful or not, it is up to us to decide. And so rest of the things, and the another thing is, because of the panoramic view and use of endoscope with this, we can make a relatively smaller craniotomy, and we go in. And another important thing is that retraction should be avoided till we open up the arachnoid, and if the vein is, if the precentral cerebellar vein is stretched, it is better to coagulate and cut, and then only, if at all, we can use retraction. Till then, any retraction of the culmen part of the cerebellum can avulse the precentral cerebellar vein from the vein of Galen, and it can create postoperative complications. Because this is a 0-degree visualization, the initial part of surgery first is done with this exoscope, where the head-on part of the tumor, the central decompression is done. And once the central part is decompressed and third ventricle is entered, then we can have enough space to put in endoscope, because endoscope needs a parking position in a large tumor. So, so in large tumors, we have first, after decompression, we can place it. This is a angled endoscope. As you see, what we were not seeing with the 0-degree visualization, we are seeing most of the tumor was still there. Though with 0-degree, we have already entered the third ventricle. Now the angle is directed to one side, and by rotating the angle of the endoscope, we can look at both sides and identify all the venous structures and decide how much tumor to remove, but doing meticulous bimanual dissection. Now the angle is towards upward. This tumor was going into all the crevices, both inferiorly and superiorly. For bimanual dissection is very important. The endoscope is not held by the surgeon. It is in a holder. We can see the internal cerebral veins. We can see in the top. And here we can see the confluence, where it is coming and joining and becoming a vein of Galen. And by this is the most, and this is the part of the tumor which is going into the thalamus area, where we can see the bilateral thalamus, aqueduct, and then gradually we can keep rotating the endoscope as per the need and identify the whichever side the tumor is going more. So the kind of the panoramic view is what is the greatest advantage of using endoscope. Now I think I'll go to my presentation. Thank you. So the principles of transcranial endoscopy is identifying which corridor is the best, and we need a free space. We have to go by long axis of the lesion and look at the attachment, if any, and re-establish CSF flow. The dilemma between anterior and posterior approaches are quite common. And sometimes we need to take an intermediary trajectory based on all these principles which I have already elucidated. And even sometimes the large developmental retrocerebellar cysts, we have dilemma. We had classified them and reported that whenever it's a type A retrocerebellar cyst, the suboccipital endoscopic deroofing and cisternostomy is appropriate. And for any type B type of developmental retrocerebellar cyst, a simple ETV may be sufficient. So these are the results, as you can see. That the compressed cerebellum, which looks like atrophic, it has become almost near normal. And there is a kind of CSF flow is re-established. And when we are decide between anterior and posterior approaches, sometimes the tumor arises from the third ventricular floor and goes till the posterior third ventricular area. Here, the choice is simple. Endonasal endoscopic provides the best, because the tumor attachment is from the third ventricular floor. Here we can identify all the structures which are very important for the long-term outcome of the patients. So this is a case of a pure third ventricular papillary craniopharyngioma giant. And this also we did endonasal endoscopic. So here we can see two parts of the tumor, one here and one here close to the posterior third ventricular area. So these are the tumors which are kind of best suitable for endonasal endoscopy. And this is a case of giant tictal cyst. Here the long axis of the cyst mandates an anterior approach. And sometimes what appears as a cyst is just a diverticula, as in this case, in which a simple ETV is sufficient to reverse most of the manifestations. You don't have to tackle the what appears to be a cyst. And here, this was a case of posterior velum interpositum cyst. If you apply the long axis rule, and if you want to communicate with the ventricle, this is the trajectory which is chosen based on navigation. And whenever we, like for most of these quadrigeminal area cistern epidermoids, here the standalone posterior approach, cross approach is very good. And the advantage of endoscope is that it provides a panoramic angled endoscopic view without any need for retraction. So because any tumor or epidermoid which is going into the superior mesencephalic fissure, we can easily look at it with angled optics and remove this. So this I'll not go full. This is a case of precentral cerebellar vein. Initially, we were coagulating and cutting it. Sometimes recently with endoscope, we have stopped doing it if we can go on either side of this vein. But again, retraction is to be avoided. When retraction is mandatory, it is better to cut the precentral cerebellar vein. By rotating the angle of the endoscope, we can remove most of the parts of the epidermoid. But the disadvantage of endoscopic is also there. Because you tend to see more, you can be over aggressive, which may not be needed. So a caution is need to be, like we have to be very careful not to be over aggressive in removing tumors like epidermoid, which have a very good long-term outcome, even with a near total or subtotal resection. Whenever epidermoid goes laterally, it is very difficult with just a microscopic approach, as in this case. The lateral part is best seen with the endoscope. Sometimes we have a cavernoma, which is from the posterior third ventricular floor, which is actually within the midbrain. So here, as you can see, that there is a vein which is overlaying the midbrain posteriorly, and we gave an intercollicular incision, and using the angled endoscope, we can, under neuromonitoring motor, MEP monitoring, we try to go and remove this cavernoma. So this provides a view which is definitely better than a simple 0-degree visualization, because this attachment of the cavernoma is more towards one side. We were keeping the angle towards that direction. And for most of the other tumors, we always do first biopsy followed by tumor resection, because Professor Bihari sir had already highlighted, when you know the pathology, you can choose for chemosensitive, radiosensitive tumors to avoid. Navigation is absolutely helpful. And we have reported on a single entry 2-stage rotational outside in technique by utilizing the angle of the LOTA system to our advantage. When ETV is done at a faraway distance and biopsy is done more close-up view, so that when it is far away and when it is angled antero-inferiorly, we can, even from an anterior trajectory, we can visualize the third ventricular floor and do ETV. But when you are taking very close, then even at that, the angle becomes very insignificant. So then biopsy is done with a straight instruments, because you need to get maximum tissue. So that's the relevance of this method. And most of these tumors, whenever it is radiosensitive, we can just do a biopsy and then give radiotherapy. Like in these cases, sometimes we give chemotherapy and pineoblastoma. Sometimes it turns, this came out to be a choroid plexus papilloma, which we gave radiosurgery after endoscopic biopsy. High-grade gliomas also, we routinely just do biopsy and radiotherapy when it is small, but large tumors, we may decide depending upon the symptoms to go for resection. So whenever we talk about resection, we have to study the venous anatomy. Whenever the tumor is predominantly superior to the veins, we can take biopsy from the lateral ventricle itself. No need to go into the third ventricle. And also the Poppins approach would be superior compared to something which is predominantly infravenous. This is a case of which we had done in Poppin's approach. Each and every microscope, exoscope, endoscope have their own advantages. We have to use them judiciously. Advantage of endoscope is almost all the structures you can see because of the panoramic visualization. As you can see, all the branches of vein. This one we didn't cut and coagulate the precentral cerebellar vein. We did through one side of it. So this video we have already seen, and this was a papillary tumor of the pineal region. And sometimes we get lots of pilocytic astrocytomas arising from brainstem or from thalamus. So this approach is quite helpful in most of these pilocytic astrocytomas, this approach using endoscopic cross approach. Sometimes we get an epidermoid in which the long axis of the tumor is very much unfavorable. So if you apply the long axis rule, you should come from this transcallosal approach in which you may have to damage more neural structures. And in these trajectories which are easier, but you may not be able to visualize this part in a better manner. So here we decided to do endoscopic telovelar approach in which we opened up the foramen of Megendi and then we put in the endoscope along the fourth ventricle into the epidermoid. And with that angled optics, as you can see now, we are within the tumor and most of the epidermoid was gently curated out. So this is at the end. We can see most of the tumor out, and this is the post-operative view. Because of lack of time, I am just going fast. So endoscopy provides an excellent panoramic and angled optics, which is very much helpful in the surgical resection of tumors or cystic lesions from the pineal region. Thank you.
Thank you, sir. I now invite Dr. Avadesh Jaiswal to deliver a talk on endoscopic supracerebellar infratentorial approach. Over to you, sir.
At the outset, I am thankful to Dr. Ghosh and Dr. Pandey for giving this opportunity. I'll be talking about endoscopic supracerebellar infratentorial approach. Most of the part have been covered by Dr. Pandey itself. And let us see. So basically, this surgery is what we perform with microscope. Here the visualization to be endoscope. You can call it endo-microneurosurgery because the basic principles of microneurosurgery are there under endoscopic vision. So what are the indications of this supracerebellar infratentorial approach? Dorsal midbrain lesions, pineal region lesions, and temporal insular lesions. So this approach may be either microscopic, Dr. Bihari had told, and maybe endoscopic. Endoscopic give advantage of excellent illumination, panoramic view, and in microscope, because patient sitting position, so the arm often get fatigued. In I personally do these cases in lateral position, which I will tell you later, and where there is no arm fatigue. So what is prerequisite? That brain must be lax if you are planning to do this procedure, and it can be achieved by either by putting external ventricular drain, or if there is hydrocephalus present. If there is no hydrocephalus, you can do insert a lumbar drain, or you can do ETV before surgery. You can tap the tumor cyst, or you can tap the CSF from the cisterna magna if there is no tonsillar herniation. So this is the position which we follow in our setup. This is lateral position, and the head, neck is flexed and slightly tilted to the opposite side. And this is the OR setup. So here I'm sitting here. The assistant who holds the scope, I don't use endoscope holder. One can use the holder also, but the disadvantage is that the depth perception is lost, and the other thing that the instrument maneuverability little become difficult. So assistant holds the scope who sits left to me, and he's a staff nurse, and here the endoscope is in front of us. So you have to keep the assistant very comfortable position. Otherwise, if the assistant is comfortable, so you will get problem with doing the procedure. So this is the craniotomy. Dr. Dandapani has already told, this is the dural exposure. You have to expose the transverse sinus and torcula, and this is the durotomy. So this is a patient who has a cystic lesion with a solid component in the quadrigeminal system. You can see here. And this is the video. But no retractor is required. This is the tentorium. This is cerebellum. We are opening the arachnoid over the lesion. And the cyst wall has also been opened. This good picture you will very difficult to get with microscope actually. Now the solid part is being identified and now being removed. And now the cyst wall is being separated from all around. You can see here this arachnoid. The assistant is holding its scope. And following microsurgical principle, that's why we call it endomicroneurosurgery. This is the brainstem, separating the cyst wall from the lateral part. It has good plane. Gentle traction, counter traction with dissection. Now most part have been separated. This is the precentral cerebellar vein. We have not operated about 8 cases with this approach, and in all cases, the vein has been preserved. But Dr. Grandapani has told that in case if you feel one should try to preserve it unless it's really needed. Cut it. Now the cyst has been removed. It gives very beautiful view. You can see, you can operate, you can dissect with use of endoscope. Now the entire capsule has been separated, cyst wall, and cutting it. And this is the operating cavity. So this is the post-op MRI, the complete systemic size. Interestingly, the biopsy was craniopharyngioma. This is another patient presented with rate pressure. Here the tumor was present in the superior cerebellar peduncle going into the ambient cistern. To use the same approach. In this patient, we kept on the craniotomy on the left side. So this is purely endoscopic operation. We are cutting the bridging vein, coagulating it. This bridging vein on the left side, near the midline. And going only on the left side, we have reached to the tumor by retracting the cerebellum, dividing the arachnoid, and directly visualizing the tumor. This tumor was also very suckable, very soft. You can see when I take the instrument, the assistant zooms out, so that I can see the path how the instrument is going in. And same when we take out the instrument. That's why holder probably this is the disadvantage of using endoscope holder. So taking out tumor in piecemeal, you can see the operating cavity. Taking out the lateral part of the tumor. This is the precentral cerebral vein. This part of arachnoid is being cut, dissected and separated. And taking out tumor in piecemeal. This we have recently operated. Now taking out the lateral part. Sometimes you use two suction technique. One suction retracts and one suction sucks the tumor. Taking out the part in the ambient system. You can cut this tent also in case if you need it. Now you are using two suction. One suction is being used as a detector. And other suction is sucking the tumor, which is above the tent. And gently delivering the tumor in the operative field. And after that, you can see some veins. Now taking out tumor which is present in the superior cerebral peduncle. This is the brainstem you can see. And this sitting position, lateral position is very comfortable. This is the branch of the superior cerebral artery, which was preserved. And this is the operative cavity. Solubilized gel foam, and then hemostasis. This is post-operative CT. There's some amount tumor may be left. We don't have post-operative MRI or biopsy till now. This is one other case. Similar approach has been done. This is another case with large tumor, after the same some residual, biopsy was pineoblastoma, received radiotherapy. So this endoscopic supracerebral frontal approach is safe and feasible. It has distinct advantages over microscope. However, there is some learning curve, but it can be done. Thank you very much.
Thank you, sir. We will now have a talk on strategies and philosophy of excision of trigeminal schwannoma by Professor Atul Goyal. Welcome you, sir.
Thank you, Dr. Ghosh, for organizing this. I know it is not easy. But you have made it possible. Of course, your Hanuman is there with you, and that Hanuman takes you with his tail all over the place. And I am going to talk on trigeminal schwannomas, trigeminal neurinomas, probably a historic talk. It is nothing new, but I have been talking on this subject for last at least 25 or 30 years. So just listen to what I have been talking on several occasions. Maybe I have given more than 100 lectures on this subject of trigeminal neurinomas. And many of you must have seen this slide for several times. And this was my article, which was published in 2003 with 73 cases. And in the next 21 years, my experience is beyond 320. So this is one of the largest experiences in the world. On that basis, I'm going to give you some concepts and some issues in trigeminal neurinomas. One is middle fossa, one is dumbbell shaped, and one is dumbbell shaped. And type 1, type 2 is, maybe I'll show you. So these tumors are relatively rare. In neurinomas, they are second only to acoustic tumors and frequent, not rarely, but if there is NF2, they are quite commonly associated. So these tumors may be located only in middle fossa. This is type A. Little bit going in the posterior fossa is very frequent. Whether they go in posterior fossa, whether they go extracranial, whether they remain in middle fossa, Meckel cave site is always there. So first time in the literature, we said that the origin of these tumors is from the region of Gasserian ganglion. So that was first time. Also, first time in the literature, we said that this portion of the tumor remains within the confines of dura. So we labeled it as interdural location of the tumor. So the trigeminal neurinomas are within the confines of dura. Other thing we said, probably we did not say in 2003, that this part of the tumor is subarachnoid, like acoustic tumor. But later, subsequently in my work, we have said that many a times, even this part of the tumor can be within the confines of the dura, particularly the tumors which are multi-compartmental. Type B is when the tumor is essentially located in the posterior fossa. We know all these things. There is nothing new in this, but this is the classification of trigeminal neurinomas. Dumbbell shape is type C, when it is in the middle fossa, in the posterior fossa. So dumbbells are very common in trigeminal neurinomas. And I must tell you that 25, 30 years ago, all these tumors were not really understood. Diagnosis was not clear. Surgical treatment was not defined. And two-stage surgical treatment was a norm. Till in 1989, Malice for the first time said that these tumors should be removed. No, pointer is not working over. नहीं इसमें नहीं आ रहा pointer. So Malice was the first one who said that these tumors can be removed in one stage. So that was the historical perspective. Then we identified, the extracranial extension was the other type of trigeminal neurinoma. So type 1, when it goes along the ophthalmic division. Type 2, when it goes along the foramen rotundum, you see by the side of the teeth, these are along the foramen rotundum. These are along the foramen ovale, V3 division, V1, V2, V3. So it can go along various divisions. And it can go along the division in the middle fossa, in the infratemporal fossa, and extracranial, in the subcutaneous portion. So this is also trigeminal neurinoma. And we said that these tumors, even extracranial, are within the dural confines. Even under the skin, they are under the dura. I will probably show you. So these tumors can be very small and these tumors can be very large. But most important is they have characteristic symptoms like numbness over the face and wasting of the temporalis muscle. They can become huge. You see, even when they become huge, they remain the dural confinement. That is the beauty. And that is what we said for the first time. Even when they become huge, they remain within the dura. Many of these tumors are soft. Many of these tumors are necrotic. And you see this kind of cystic component, these dumbbells, huge dumbbells within the dura cystic component. And you know, these tumors were considered to be quite difficult tumors 35 years, 30 years ago. But if you understand that this is within the dura, they are soft, they are necrotic, they are breakable. They are not very difficult tumors. So many of these tumors can be huge and very huge in size. Many a times they are cystic. There are two types of cyst in this tumor. This is rather unusual. Like craniopharyngioma has multiple consistency, multicolors of cyst. Here in trigeminal neuronoma also possible. Fluid level within the tumor is relatively rare, quite common in pituitary tumors, not so common in this fluid level within the tumor is not so common in trigeminal schwannoma, but you can see multiple fluid levels. You see multiple fluid levels? And I have to give you one information. When you see fluid levels, the surgery is easy, but recurrence rates are tremendously high. And if any trigeminal schwannoma will recur, these are the tumors that will recur. Multiple fluid levels in the tumor. You see multiple fluid levels in the tumor, you can see. But no matter how big they become, no matter how extensive they are, but they remain that dural confinement. That is the beauty. And when you see such fluid levels, prepare for a recurrence. Bilateral trigeminal schwannomas are associated with NF2. You see one is large, one is big. Which one to remove, which one not to remove. Even this may not be removed all the time. In NF2, you have to decide. So this is one acoustic, and I tried to call them kissing tumors. Ossified tumors. You see this I have presented earlier in this Dandy Society meeting. This is one tumor, and here there is a tumor along the fourth nerve, along the sixth nerve, along the seventh. This is along the seventh nerve and trigeminal. So multiple ossified tumors, bilateral, never reported in the literature. In my series, we have 4 cases of ossified, you see, on CT scan ossification. So most important issue is their characteristic clinical symptoms. You can diagnose on the basis of location and on the basis of symptoms. When trigeminal symptoms are prominent, it is trigeminal neuronoma. When you see wasting trigeminal neuronoma, they hardly present ever with pain as a symptom. If it is presenting with pain, it is an aggressive tumor, probably a malignant tumor. Trigeminal schwannomas will never present with pain. We reported presentation with pathological laughter. These kind of dumbbells, I reported 4 cases, but this is a presentation, and you will, when you see such a dumbbell, you ask for this symptom. Surgery is very, very philosophical. In 1992, this kind of tumor, as I mentioned, these were always removed in 2 stages. And these were considered to be difficult or impossible tumors. So first I removed the middle fossa, and then I removed the posterior fossa. This was in 1992. This was another case in 1992 where I removed a posterior fossa first and then the middle fossa. 2 stages were a norm. Then in 1995, we came with the concept of playing with the dura. And that changed my world of trigeminal neuronoma. That changed the entire world for surgery for everyone, I must say, and I have no hesitation to say that. Trigeminal nerve is surrounded by Meckel's cave and subarachnoid space. Tumor arises within this space from the ganglion, and when it grows large, the trigeminal nerve is preserved. So you should come from the undersurface. Most important nerve is V1 nerve division. If you don't preserve this V1 division, and if you remove the tumor, you have killed the eye. You remember that. So coming from underneath is very important. As I mentioned, even this part of the tumor can be interdural, and saving of the 5th nerve is critical. Carotid artery will always be displaced outside the dura and on the medial surface. That is why I say don't come from the endoscope to remove a trigeminal schwannoma, because carotid artery is there and trigeminal nerves, you cannot really identify the course of the trigeminal nerve. Trigeminal nerve schwannomas have always to become lateral because the carotid is displaced medially along its entire course. Recently, I saw some papers of trigeminal neuronomas being removed. I don't think that is a good option. Extradural understanding of dura has been one of my, I have written at least 30 papers on dura and tumors, and this was extradural approach to intracavernous sinus tumors was first described in this article for tumors. Of course, Vinko Dolan's work, everybody knows. In 1995, when trigeminal schwannomas were not really understood, we described not by endoscope, but by microscope, just widening the Meckel's cave and working within the dura. In 1995, you can imagine at that time, it was not, cavernous sinus tumors were not even done properly. This tumor I did in 1995 without a craniotomy. This was tumor going in the posterior fossa. You imagine just this craniotomy, no temporal craniotomy, no petrosectomy, nothing. Just by, I don't do these things now, but this is what I had described, even this tumor. So these are in my 1995 paper where I have done this without a craniotomy. But now, of course, from after 1996 and things like that, initially for large tumors, particularly dumbbell tumors, I did this kind of basal exposure, which I described here. Removal of the roof of the zygoma, roof of the condyle, roof of the external ear canal to get a basal exposure. I don't do these things now. I do just temporal muscle splitting, make a small craniotomy, and work for a large dumbbell shape. Go intradural for large dumbbell-shaped tumors. Retract the brain, make an incision on the dura, and then work within the tumor. Learn the art of breaking the tumor, breaking the tumor, breaking the tumor without coagulation. If you keep on coagulating, you will never save the trigeminal nerve. These tumors are soft and cystic and necrotic on majority of situations. Even if they are large, they are never too heavily vascular. These tumors are one of the beautiful pictures of neurosurgery. We should learn these trigeminal neuromas to resect, to work within the dura. I sometimes do these cases in 20 minutes or 25 minutes, not to give the importance of time, but importance of understanding the dura. Time again, time spent. Sorry for that. So Ajay, my time is done or what? Finish? Okay. I'll rapidly go, of course, I can understand. So these kind of dumbbell tumors, there is no need. Some people describe removal of anterior clinoid process for this, removal of petrous bone for this, petrosectomy for this. That is completely unnecessary. You see, in this case, the anterior clinoid has been eroded by the tumor. Petrous apex has been eroded by the tumor. Space has been made for the dura. You come from lateral, in 10 minutes, you can be on this lateral wall, make an incision, come intradural first, retract the brain. Then you get a lot of space. Then take an incision on the lateral wall of the dura. Then work in the lateral wall on the inferior aspect, not on the dome of the tumor. And once you have removed that inferior aspect, then work, because V1 division is the most critical division of the trigeminal nerve. And in my journey of trigeminal neurinomas, I have removed several of these dumbbells. And you must really enjoy these dumbbells because these are relatively straightforward operations. If you ask me which is the easiest, I should not use this word easy in any case for neurosurgery, but these are the, if I see such a case, I just get excited because I will be able to finish it quickly. And you see, this is coming till here, but that does not mean you have to violate the dura. This is completely within the dura, like I have discussed on several occasions in my journey of neurosurgery. And these kind of dumbbells are very fantastic. When you see this nub in here, it does not mean it is involving the carotid artery. There is dura here, like I have talked several times on pituitary tumors, how the dura remains intact and how you can work your way through the dura. So these are some of the dumbbells which you will like to operate, and you must like to operate. And if you say, I don't like to operate, then you should choose some other profession, because this is a beautiful neurosurgical. And when you see multiple cysts like that, this becomes much more easier. Whether you use, my dear Avdesh, one thing I'll tell you, Avdesh, day before yesterday, I came from China. And I was attending one meeting where they were showing beautiful endoscopic work. And I encourage you, Dr. Dandapani, I saw beautiful work from you. Dr. Avdesh, I saw beautiful work for you. I may talk here and there about endoscope, but I encourage you to take this field further, because what I saw in China was fantastic. And what I'm seeing here is fantastic. We should overshadow them with your hard work. You teach everyone this art of endoscopic neurosurgery. It is important. Now, when you see such cystic tumor, prepare for a recurrence. You see these tumors, now multiple cysts, I can only tell you what a fantastic, now this was a recurrence. Somebody had operated cystic tumor recurrence. And then I operated, removed this tumor, and this was the recurrence after that. And then I operated. So, and this kind of recurrence. Other thing that we mentioned in our article is when the tumor recurs, even at that time, there is a dural cover present. Even if you have violated the dura on the first occasion, the dural cover will be present on the next occasion. So extracranial is covered by the dura on all occasions. So you have to identify in these cases, maybe you can use endoscope or what, I don't know. But if you make a small craniotomy here, we described a reverse skull base. So cranial route for extracranial tumors. I do a small craniotomy in the middle fossa and then come here, then work within the dura and then get an exposure down. So quite a quick and quite a straightforward approach. So dural cover is always present. Cranial approach to extracranial tumor is also a possibility. So this was the paper that we published, and this kind of extracranial extension presentation with NF2, with caveolus spots, with all these kind of things. Rarely they will present with numbness all the time, but with such kind of proptosis is relatively rare, but we reported long time ago in 1995, proptosis and things like that. Multi-compartmental tumor, when you are seeing recurrence rates are higher. And multi-compartment here means it is always dura will be present here, dura will be here. You can, do a quick fire job in these operations. There may not be any need for a huge exposure and working through the day. If you are working on these tumors for 10 hours or 15 hours, you can rethink about what you are doing. And when it recurs, there can be sudden, you may not see recurrence for 20 years, and suddenly they come with an sudden onset apoplectic. Now, recently, I am seeing several cases. In the last 1 year, I must have operated 6 or 7 cases or more about apoplectic, sudden recurrence of the tumor, sudden presentation of the tumor with a huge recurrence. And here, the beautiful thing that we discussed is that even the recurrence is under the dural cover. So this dural cover is a fascinating thing to understand, fascinating thing to prepare during the operation. Don't think that it is the capsule and remove the dura. If you do that, you have taken the cranial nerve. Never think that it is a capsule of the tumor, which is discussed in the literature. Remove the capsule, and capsule is part of the tumor, and dura is part of the body. And these kind of recurrences you can have to do. So I don't want to take too much time, but I have a feeling trigeminal neurinomas are a beautiful chapter of neurosurgery. Understand them, think about them. And when you do, just don't go on doing for, unlimited time. Because more the time you spend, more the coagulation you do, more the chances of saving the fifth nerve fibers. We describe in my article for the first time in literature in 2003 that you can not only preserve the sensation, you can improve the sensation. As a series we presented the paper which I showed you in 2003. That was the first article where improvement of function was described. So thank you, my dear friends, and thank you, Dr. Ghosh.
Thank you, sir. As we're running late, we'll have a brief panel discussion, for which I request the speakers, Professor Vernon Velho, Professor Rajneesh Kachara, Professor Atul Goyal, Professor Sanjay Behari, Professor S.S. Dandabani, Dr. Avadesh Jaiswal, to preferably take up the front rows, and the moderator for the session, Professor Sarat Chandra, to carry forward with the discussion.
So good afternoon. I realize I'm standing between you and the lunch, and we had a really brilliant presentations. So I really don't know what discussion I need to do, but perhaps I will do a very brief moderation, asking just one question from every faculty and requesting that faculty to answer it very briefly. So the first question is to Dr. Vernon Velho. That was a very nice and elegant presentation of CP angle, and we have seen the nuances. But as a student of neurosurgery, we have read in the textbooks that these cases are prone for aseptic meningitis and we need to give steroids for 1 week, 10 days, and then taper. I have never seen a single case of aseptic. I would have operated over 200 epidermoids. So what is your experience? Do you think it has been kind of overrated?
I think the more the tumor you get out along with the capsule, I think there are lesser chances of these things happening. Many times we get a subtle meningitis on the 5th day. If you see on the 5th day or 6th day, there is some little bit of neck rigidity which takes place. And if you have covered the patient, what we do is we do not give up too much of DEXA. If you want, you can give hydrocortisone, and even the washes which are to be given, we use the hydrocort wash. Now, I don't know how much it works, but the most important thing I feel, Sarath, is do not remove as much of the tumor en bloc type.
So
do
do
not
you give
wash
do you give
initially.
post-operative coverage with steroids?
Yes, for 5 days.
Okay. Okay, thank you. The next question is to Dr. Rajneesh Kachara. Very nice presentation, Dr. Rajneesh. The question is, what do you, let us say you have large tumors and going into cavernous sinus. Do you really prefer to go ahead and do a radical resection? Or now that gamma knife is available, you like to remove, retain some portion near the cavernous sinus and give gamma knife? So what is your general philosophy? Let us say the patient is very well preserved. You have a very large tumor, very significant encroachment into the cavernous sinus. No, but these tumors are very good. Once you decompress the tumor and you just separate the capsule, usually these tumors are very much separable from the very important neurovascular structures. So within the cavernous sinus also, you can remove tumor completely actually. So did you ever give gamma knife for your patients for any residual tumors? Yeah, so far, no, we have not given gamma knife. You've been successful in removing it completely. Yeah, our patients are not affording for gamma knife. And last case was which I showed, which we are just following with the MRI. And if required, we have to give some kind of fractionated radiotherapy, which is available in our setup. Yeah. Okay. Yeah. Thank you. Yeah. So next question is, of course, to Professor Atul Goyal. Sir, I have no words for your presentation. I think you are a walking legend. You have always emphasized that one should always use maybe a number 1 or some kind of a suction to take out tumor, not only for trigeminal schwannomas, but for all extraaxial lesions, even for acoustics. So otherwise, most of the people, I have learned that from you, to take a number 1 scoop and take it out. It's much more faster. It's in fact much more faster than CUSA. CUSA actually leads to a lot of bleeding. You use CUSA, there's a lot of bleeding. Again, you tend to cauterize that. But if you use a sharp dissection like a number 1 and you scoop it out, it comes out very fast. So you have any words on this, on how to rapidly decompress?
See, if I have to tell you about tumor surgery, the most critical and most important issue is that we all should be doing tumors on a regular basis. If we go on operating, we know the art of breaking the tumor, art of resecting the tumor, art of preserving the subarachnoid space, art of identifying tumor from normal vessels. As you beautifully know, there is no question that if we are removing the tumor, we take one normal vessel, we can probably kill the person. Now, how you break the tumor, it does not mean that you break only soft tumors. You have to break sometimes hard tumors. You have to break rocky tumors. You have to break firm tumors. You have to break tumors which are encasing and involving the blood vessel. So this art we have to learn with our experience. More and more we operate. So we have to love the operation theater. We have to love the smell of the operation theater. We have to be in the operation theater. We have to know how we do our work. In neurosurgery, as we enter into the world of neurosurgery, we learn the art of breaking the tumors from gliomas, high-grade gliomas. And, we are given as a younger resident or younger consultant, most early in our profession, gliomas are given to us, high-grade. In that, we learn how to get hemostasis, how to remove the tumor. Then we learn about convexity meningiomas, how we remove the convexity meningiomas. So these meningiomas are training grounds for us as when we are young and when we are growing. Like chordomas, for instance, they are jelly-like tumors. You have to remove it much easier. On the other hand, you have a chondrosarcoma, or that becomes much more difficult with bone and artery. They are difficult. So each tumor is different. In pituitary tumors are entirely a different world of tumors. How you break the tumor. As regards my style of breaking the tumor, you very rightly said, I use suction to break the tumor. I used to initially try the CLUSA and all, but my suction is a very beautiful tool for me, as you have seen on several occasions. And when I have to break the tumor, dissect from the surrounding, I use this dissector to dissect and push the tumor into the field. So we have to learn. My strategy is not to coagulate into the tumor. When I operate on acoustic tumor, large tumor or huge tumor, I have removed the entire tumor with coagulation of 2 or 3 times. Many a times I say, if you coagulate within the tumor is waste of time. If you are coagulating outside the tumor, that is a technical mistake. But there are some points in acoustic tumor where you have to coagulate, and those points have to be learned, like the inferior part, as we know, where the artery comes and you have to coagulate that artery. If you don't coagulate, you can create a big problem. But if you go on coagulating throughout the day, you will never finish acoustic. So depend on coagulation when it is necessary. I'm not saying don't coagulate, but don't just go on coagulating. Break the tumor, learn the art of breaking the tumor, dissecting the tumor from the adjoining. Acoustic tumor is a beautiful training ground to learn tumor surgery, learn the philosophy of neurosurgery, learn the art of preserving the patient. You see, if you say, I've removed the tumor and damaged the facial nerve, it will be damaged on many occasions. I'm not saying, but if it is consistently being damaged, then you have to, stop doing all these things. So this is, sorry.
Thank you, sir. Thank you for that meaningful comments. So next is Professor Abida Shah is here. So again, excellent demonstration of anatomy. Literally, I would say brilliant. But as a surgeon, I would like to ask you one question. When you show us this 3D anatomy, it looks as if there's absolutely no space where a surgeon can go. Whereas when you actually do surgery, it's not so difficult as it looks in the 3D anatomy. You have space, you can actually go and work around. So how do you deal with this dichotomy? When you see these 3D images, you find so many vessels, so many veins, you don't even know where to get into it.
So it's the beauty of the tumor and nature. It has already made space for you. So basically when it expands, it will expand in that corridor and it will make space for you to enter. It distorts the anatomy. There are some things that you can, take or sacrifice, but majority, you have to understand which ones are really important and you cannot sacrifice those. Like for subcortical anatomy, subcortical anatomy, you cannot take any major important tract. For these other skull-base anatomy, which you have to preserve the nerves, you have to preserve the important vasculature. There are some things that go into the tumor that probably you can, but basically the tumor makes space, by its growth. Even for example, in the brainstem, it will grow and distort the anatomy, but give you an avenue from where you can enter.
Thank you. Thank you very much. Dr. Sanjay Bihari, again, a brilliant presentation. And you have shown very elegantly what are the supracerebellar approach and what is the transtentorial infraoccipital approaches. So do you have any word of advice for the young neurosurgical trainee on when to choose what approach? A supracerebellar versus a transtentorial suboccipital approach?
Yeah. So thank you for the question. I think the important thing is that if a tumor is in the midline and if the tentorial obliquity is not too much, then it's straight in the midline, then it is easy to just do an infratentorial supracerebellar approach. However, if the tumor is going too much on one side or the other, or if the tumor is going too high up, or if the tumor is going too much anterior to the anterior vermis, then it becomes extremely difficult to go by the infratentorial supracerebellar approach, and there an occipital transtentorial approach is better. The other important thing is if it's a very large tumor which you anticipate to be vascular, then it is much simpler to go from above below, which is from occipital transtentorial approach, than to come from below up. That means going from below up, because the problem is that if it bleeds because of the negative pressure, or even what happens is that you will not know there's a negative pressure in the veins, and later on the vein will cause a big hematoma there with hydrocephalus. So going from above below in a vascular tumor is much simpler, and the hemostasis is much easier to control. Thank you.
Thank you. So then we had two really brilliant presentations by Dr. Avdesh Jaiswal and Dr. Dandapani. And I will ask a question to both of you. and you can independently answer. Now you've shown that beautiful endoscopic approaches, and of this you have shown that how important is the endoscope to look around the sides. Okay. Plus Dandapani again has shown a very good approach to the tumors using an endoscope. Now from your presentation, especially only for the pineal tumors, it looks as if an endoscope is a good adjuvant. You could perhaps start with a microscope and always use an endoscope later on. But from your presentation, it looks as if you have some kind of a clear-cut demarcation. Like if you use an endoscope, you should not use a microscope. Or if you use a microscope, you should not use an endoscope. So the question is, how often do you perform the switch? Or now that you're too experienced, you don't perform the switch at all? Or do you say it is, it's okay to, how many times you go forth between a microscope and an endoscope?
Thank you, Mr. Actually, endoscope is only a visualizing tool. Let me tell you. It is only surgeon comfort and preference, and how in the way the surgeon is comfortable. If you are able to do with microscope, you can use endoscope in the last and find out where the tumor is, and you can do the rest of the job where the tumor is there in some hidden part of us. Is the residue is present or not? But if you can use the endoscope from the beginning also, because I'm much comfortable, so I use it. I don't advocate that everybody should use it. It's only personal preference. But endoscope definitely has revolutionized the neurosurgery, particularly in deeper situation, like in ventricle, it's very deep. Like in supracerebral infratemporal approach, it's very deep. So unless you see it, you will not be able to operate it. So as you can see, the quality of picture you get, it's unimaginable to get with microscope, which is available in India at least. So that's why endoscope, whichever you want, you are comfortable, you should use it, and it should be used. That's what I want to say.
So Dandapani, your comment?
Dr. Avdesh had already covered most of the things. The first part of surgery, the surface part, we can do even with naked eye, but we need to have a recording to show. So either we can use exoscope or endoscope. I have realized that endoscope, you need little bit of space. So whenever the brain is very tense, then I would prefer to use either microscope or exoscope. I have already highlighted the difference between microscope and exoscope. A microscope is better in terms of resolution, but exoscope is better in terms of depth of field. And another thing is that when we use microscope and then switch to endoscope, it becomes a little cumbersome. And recording is also in two different machines. But when we do it with exoscope and then we move it to endoscope, it is very easy because it is the same machine. So our recording is intact. From one export, we can get the whole thing. So I nowadays prefer to use exoscope because the kind of the video is also phenomenally better. When we use microscope, only the point of focus we see best. But when we are using exoscope, you see a panoramic view and we have a greater depth of view. So for kind of teaching purposes, exoscope is better. But when you have a space, then directly you can use endoscope. We need a place, kind of parking position for endoscope. And whenever I use endoscope, I always use angled optics. If we are using only 0-degree endoscope, it is not superior to microscope. It is that we can very well use a microscope also. So the advantage of endoscope lies in the angled optics, and the way we rotate, we can look at kind of all angles and corridors better. That's it. Thank you.
Okay, so thank you. So with this, so yes, we are already late. I don't know if the chairperson will allow. Do you allow 2 questions or comments? So Dr. Bihari.
Just one small point I'd like to make here. When you're approaching posterior third ventricular tumor, go as slow as possible. Don't go fast. If your bleeding is in control, the tumor will come out eventually. But like you do in a meningioma sometimes or in a glioma, you go rapidly. It's a soft suckable tumor. Go on decompressing. It's a complete opposite of that. Every point in your surgery has to be very controlled, because if it starts bleeding, then the cerebellum will bulge. There's going to be acute hydrocephalus and it will start bleeding laterally, which you will not be able to control, and it will become one big mess. So please, as slow as possible, actually wins the race here.
Dr. Rajneesh?
No, my just, I mean, you are using assistant for you're holding the scope, and he was what I show. He was very uncomfortable position, looking, and with the microscope, you don't need any assistant. You can move up, down, here, there, corners, but you are so comfortable with the endoscope, that's okay. But I think microscope has its own advantages. You don't need an assistant.
So Dr. Suri also had a question. Maybe we can quickly take it.
Comment. I think microscope or endoscope for pineal regions is just for visualization. We have to understand. I could see. I would not like to rebuttal here or point. I think the more important, which I learned from Albino Piccolo probably 2 decades ago. I think more important is a paravermian dissection down and opening the arachnoids as down as possible. That helps your cerebellum to come down. After that, you use a microscope or an endoscope or an exoscope, or put your eyes inside. That is not important, I think. I think the space actually is from the arachnoid dissection right down to the, it is preserving the lateral veins. I think that is more important. That is if you're not opening the arachnoid, you have to put the endoscope, and then you have to put a 30-degree or a 45-degree or a 70-degree. It doesn't matter. The damage will be there. But if you open the arachnoids down below, you'll have space right till the inferior till the superior vermis lower end, and that is the most important point, I think so.
So, okay, thank you very much. Now we break for lunch.
Thank you so much, sir. We shall now break for a quick lunch. Let us meet again for another interesting session at 2:50 p.m. as we are running late and we have to catch up with the schedule. Thank you.
Although we've had a late and quite brief lunch, I hope it was to everyone's liking. Now, we're moving forward with the session on anterior and middle skull-based tumors. Once again, I'd like to emphasize on all the speakers sticking to their allotted time so we can progress smoothly. May I invite Professor Sukhdeep Jawar to demonstrate the anatomy of anterior and middle skull base.
Hello. Good afternoon, everyone. Welcome back after a very delicious lunch. I hope all of you have your 3D glasses. And now, if anybody don't have 3D glasses, he can ask for it. As this setup is going on, we are coming to this very important aspect of skull base, anterior skull base and the middle cranial fossa. I will be covering in this talk, and the next talk will be on the lateral aspect of the skull base. And then we have the posterior skull base also. So anterior skull base as such anatomy is little straightforward. If you see, not much of the complexity involved compared to other skull base areas. And approaching also is relatively easy. So for a beginner or for the young neurosurgeon, it is very important that you learn how to, reach this area, how to retract the brain, how to make release the CSF, how to, reach the areas of cellular region, supracellular, paracellular, and of course olfactory and orbital skull base. So if you see there, this is the bone, which is, you can see a projection here. There's a crista gala, then you have numerous openings of the olfactory filaments, and it is all part of the ethmoid bone, which I showed earlier in the morning. Very important, very neglected kind of bone, but you have to understand it is a very important part of your approaches to the skull base, whether you are doing endoscopic or, transnasal, and then of course subfrontal approaches or other approaches. So you remove, this is the frontal bone here, and this is the view from below. You can see this is all part of the ethmoid here. Then this is the perpendicular. These are two lateral lamella with lot of air cells, and they help you in to reach this area. And you see, and this is the whole of the skull base you can approach from below. So this is the top of view. Now this is the anterior skull base. Now you can see part of the middle skull base also. So sphenoid along with frontal bone part forms the part of the anterior skull, anterior cranial fossa, and the majority of the middle cranial fossa is formed by our sphenoid bone and then part of the temporal bone. So this is the side on view. We have already seen this bony anatomy. So I will be just revising for you. So this is the frontal view, foramen rotundum, median nerve, and our pterygoid processes. This is with the palatine bone here. So this is again with the maxillary bone. This is the lateral view showing the maxillary sinus opening here. And just to revise, already we have seen this. I will be just going quickly through these slides. This is again the beautiful picture of ethmoid bone here. This is the crista gala with the numerous opening of the olfactory filaments here. So close-up view. So coming to the skull, anterior skull base. So mainly it is related to your frontal lobes here. We have the olfactory nerves here. And of course, then we have the optic nerve with the optic tracts. So these orbital elevations can be sometime, they can be different or depending upon the convolutions of the basal frontal lobe. And sometimes, you have to drill them a little bit. Even a small drilling can give you a lot of perspective in the depth. But before doing all that, when you, of course, for the beginners, you have to remember how to, reach this area. So here the CSF and the cisterns, basal cisternal anatomy is very important. If you know which cisterns are where and how to open them, how to release CSF. So whenever you are approaching a tumor, already there is some mass lesion is there, so that is causing some sort of edema. Don't try to directly attack that area. Just go some subfrontal here, and release the olfactory systems here, and slowly you will see that you will get a lot of space. You can retract all of the frontal lobe. Here you can get a beautiful picture of the bifurcation. Then you have the third pituitary stalk here in the depth. So this is the, of course, gyrus rectus from the below, which you'll see. And this is, of course, all of the dissection of the suprasellar areas and the brainstem. This of course, now this endoscope thing is also, very, many of the youngsters, they are learning and, very much interested. So here anatomy is also very crucial. If this is all the interior, almost all of the interior skull base can be accessed through the nose. But the only disadvantage is that you can damage the olfactory area. Patient or the person can lose his olfaction if it is already not lost. So here you have to be careful pre-operatively. So if you see here, this is the sella here. This is the sellar ICA. This is the chiasmatic sulcus, and this is the tuberculum sella. Both these. This is the plenum here. So if you go more forward, you will see these two branches here, two vessels which are coming from the orbital side, and you have a lot of olfactory mucosa over here, and these are the anterior and posterior ethmoidal arteries. So it is very, they are a very useful landmark. Even in the preoperative CT and all the imaging, you can study this, and you know how to, when you encounter intraoperatively, they really help you to, navigate and, find your pathology according to your approach. This is the whole of the skull base. You can see even the frontal sinuses has been opened just to give you a perspective. There's a little panoramic view here. So this is a close-up. This is again chiasmatic sulcus, planum sphenoid, then olfactory mucosa. So once you remove, you can get this beautiful view of the gyrus here. This is olfactory nerve, optic nerve, and this is the pituitary stalk here. So this is again not today's topic of concern, but you can see, of course, nowadays very many people, are doing this eyebrow approaches. Very useful, very handy approach, easy to access. And if you learn the art of removing, there's no retraction actually involved. Just if you release the CSF and do your job properly, you see this initially you may not see much of the skull base. And sometimes even a small, drilling here or some part of the this frontal bone can give you a much basal perspective. And once you remove that, if you see the Sylvian fissure is a very good, your friendly this thing, and it has a lot of, this is a superficial part and deep part, and it almost extend till here. So you just open the cistern, don't go directly medially or to the suprasellar area. Just remove some CSF here, and just wait for a few minutes, and you will see this beautiful picture of both the suprasellar area here, this optic nerves, and you keep on removing. Even you can see some part of the ACOM here, contralateral circle of Willis is also visible. And if then there is this beautiful view of the oculomotor triangle. Is a posterior clinoid here, anterior clinoid, and this is the oculomotor. And you can see basilar artery also. So this is how you can, this even the pathology sometimes makes space for you. And coming to the middle cranial fossa, again, we have seen in the morning part of the cavernous sinus. So it is almost extension of that anatomy. If you see cavernous sinus, as I already show you, is involved just extending from here all the way from anterior cranial fossa to the posterior cranial fossa, and majority of it is in the middle cranial fossa. So if you see now, this middle cranial fossa is mainly by the sphenoid bone here. This is the greater wing, and then the part of this petrous part of the temporal bone, which just fits here, and for the foramen lacerum, and also this squamous part. This is all part of the. So if you see middle cranial fossa from outside, it looks very small, but temporal lobe is a very large lobe. And there are so many hidden structures and how it is turned on itself. And if you see from the scans and from outside, it looks like just this part of the temporal lobe. But then there is a large part occupying here that you can see beautifully. So once you know this, again, bony anatomy of the temporal bone, you have to revise mastoid. You have to do mastoidectomies also sometime. So this is the top-up view of the temporal bone here. And this is the petrosal surface. You can see here internal acoustic matters here. This is the ridge here. Basically, this will be in the posterior fossa. So this is how the view is there from the oblique side. So this we have already seen how we can use use this subtemporal approach. Here we can cut the artery, then peel off the dura, and beautifully see this lateral wall of the cavernous sinus. This is this again now for the middle fossa approaches. Then you have to shift your focus little posteriorly, and if you see here is the anatomy here. So this is from the lateral side. Now you can see this is the trigeminal nerve here. You can see internal acoustic matters, then the facial GSPN going along with the carotid artery here. And then this part of the bone, which is devoid of any important structure, can be used to, approach this front of the brainstem. Now we will show in the next dissection. So this is the part of the internal ear here. Then there is the superior petrosal sinus has been cut. This is the internal acoustic. This is the seventh now coming with the cochlea. So now once you remove that part, bony structure, that gives you a very highly panoramic view. Of course, then you have to do a lot of drilling and all those things. But as Dr. Goel showed, now most of these tumors, they can be dealt only with the middle temporal fossa approach. But then you have to know how to, retract the lobe. And these are the nerves which are on the, temporal surface of the petrous surface of the temporal bone. This is here the seventh nerve going like this. This is the GSPN. This is the lesser petrosal actually. This is the GSPN. This is lesser petrosal. This is a chorda tympani. So all this anatomy, it's very complex for the our temporal bone. But you have to do even our ENT fellows, their whole life revolves around this temporal bone. But for us also, it is very important to do the dissection of temporal nerve to see the whole root of the seventh nerve and how it is related to this internal carotid artery. This is a little out of focus for 3D. So if you see here, this is the fifth nerve here, and then you have the carotid artery here. So many times, this bone can be very thin or decent while, you have to be careful. So the GSPN is a good landmark. So it goes parallel to this carotid artery. Then it joins the deep petrosal nerve to form the median nerve. As I showed you the median canal from where it comes out to form the sphenopalatine ganglion. So if you see, this is the middle meningeal arteries, foramen spinosum. Then we have a big artery, we have a nerve, then there is a muscle, then there is a tube. So there are four structures which are running here in the petrous part of the temporal bone. One is the eustachian tube, tensor dependent muscle, then we have artery, then we have the nerve here. Just remember this anatomy. So of course, these kind of pictures, they just give you perspective. As Sarah told that in intraoperatively, you can't see all these pictures. So we have to understand there are like 3-4 types of anatomy. One is your anatomy, book anatomy, one is surgical anatomy, one is functional anatomy, and one is pathological anatomy. So we have, as a neurosurgeon, we have to know all this anatomy, but we have to start with the normal anatomy. Once you know the normal anatomy, then you know functional anatomy. Like some supplementary motor area we have to preserve. So these are the functional aspect of the anatomy. Then there are like surgical anatomy, like cavernous sinus, which are not very important, but we should know from surgery point of view. So this is the, of course, the picture of all the anterior cranial fossa and the middle cranial fossa, even showing the infratemporal and the pterygoid area here, and how these nerves are oriented, how ICA is coming. And with this, I think I should stop.
PD is basically done by a person who is our own person. I congratulate, means I have never seen. You know, when you see, we always say, oh, Roten's dissection was, always say, we learned, he has also learned. I'm not trying to downgrade his monumental contribution, but what I don't think anyone from India has ever achieved this level of sophisticated dissection. What do you have to say, Ashish?
I think it's excellent work. Nothing else to say. Remarkable work.
That is one thing Professor Moedi was saying, that Indian neurosurgery is the best. I think Professor Goel is a part of that torchbearer, and that is true. That we have achieved something which is very, very significant much before the Chinese or even the Japanese. So good afternoon. I'll be just talking on surgery of anterior skull-based meningiomas, which has the anatomy which has been beautifully described by Java. So we have, at least in VHS and in my experience at Apollo, have a significant institutional experience. These are, a lot of these things when we say, we also carry that institutional experience of tackling these meningiomas. And these anterior skull-based meningiomas comprise about 8 to 13%, predominantly in females. So 3 of my recent cases, I'll show you and one which was done some time back. One was a pediatric case and 2 adult cases. Teaching neurosurgery has been a passion with me, and we really need to tell that to the residents who join that, these are, especially in the anterior cranial fossa, these lesions can be very large, and where even without seeing the tumor, we have had patients referred to us because the brain was bulging and probably the institutional memory is required for a lot of these tumors. So the incisions have, at least in my testing, has gone to a bicoronal flap. But as you can see, this pediatric case, the schoolgirl, 11th standard schoolgirl, and this is a few days after surgery, you can see that it really matters to them that we don't shave half their head and bring an incision coming right in front of the face. This also provides adequate large vascularized pericranium for repair. This I used to do quite a lot. I actually got inspired by A.K. Singh when he came there, and I did a significant number of these along with the other approaches for these tumors. But as is there, these tumors can be quite difficult. The mini craniotomy gives very good vision, and you can see that this is the mini craniotomy, and the axis and the lights off, please. The axis is quite significant, both the optic nerves, and this is from one side, it is from the right side. And you can see that by angling the microscope, we can go below the optic nerves also and see the lesion. And these, perhaps the contraindication would be significant edema, which is seen sometimes in some patients, where in these small things, although Dr. Jawar said that you can do mini cisternostomies and try to release CSF, get your anesthetist to do that, but it will not be always possible, as I'll show you in one case, that the edema, which is there in the pre-op scan, while operating can be quite a difficult thing. But anyway, in this case, I got off without it. So now, he was talking about anatomy, vascular anatomy, and then there is another 3-dimensional anatomy which we put in, or we model in our brain before we go in for the surgery next day. So we try to look at the scan from all different angles. If you have the gantry, you go there and try to rotate it and see a CT angiogram. If necessary, have an angiogram done in case you think the tumor could be hypervascular. Many of them are hypervascular, and in our place, at least in Apollo, we sometimes get an angiogram done, and then my Dr. Sengoton, my interventional radiologist, says, sir, I would be only able to take off 20%. But then that 20% has a certain amount of risk while we embolize, especially to the obtubation. So now this is the first one. This is a pediatric case. This girl was in her 11th standard. She was a brilliant student. and there was a gradual decline over a period of 2 years. That's what the family noticed, that she was not doing very well in her school. And so this is, I did a bicoral because it was a very large lesion, and then I tried to avoid the frontal sinus, and so that's why you can see that slight prominence which is there in the front of the thing. But as I told you that despite the anesthetic giving the maximum seeing, just see what happens when I sort of open the thing. The brain definitely tends to come out. And then one thing which I have learned is do not use any form of retraction. In fact, most of the injury we were causing in earlier part of my career also was due to the retraction which we applied. You know, you kept the frontal lobe away for hours on an end trying to go and get the attachment at the base. So that has significantly changed. Now, as Professor Goel likes to say, the tumor tells you what type of hand movement you will do. And so obviously, I also have taken this thing from both from Dr. Ghosh and Dr. Ravi Ramurthy, that run when you can. So when the tumor is allowing you then don't waste your time chasing after RBC. At that point of time, you should be very aggressive, use a dural scissor if possible, and remove large bulk of tumor so that the final part of the tumor, which is the more difficult part, the posterior part, you will be able to avoid any inadvertent injury to the anterior circulation. The reconstruction is of great importance to make sure that there is no accidental area of the thing, and then you make sure that there is a vascularized pedicle flap. Cosmesis is also very important, and so I really am very particular that we use burr-hole buttons and this. This young lady went on to pass her 12th standard, and now her scholastic things improved. She's trying to clear the IIT entrance exams as she wants to be an engineer. This is another case which is similar, a large one. This I have gone a little lateral approach I have chosen. And there, each of these tumors, it depends on how much of a vascularity which you are seeing. And as you can see, even in this tumor of this size, I have not used any retraction. And the post-operative scan is witness to that fact that the retraction has not been done, and there has not been any collateral damage caused by my surgery. So the key is that to use the different types of thing, and in fact, I am very fond of using the irrigation forceps. That really helps you because you don't require another assistant to keep on pouring water for you. So have a real good, that is one of the big advantages in VHS. We have nearly about 80 types of bipolar forceps which are there available for us to use. And so this helps us with our surgery. The hyperostotic part, which is the thing, there is actually ample evidence in literature that if you chase that and you create a leak, CSF leak, and then you may lose these patients because repairing that breach can be very, very difficult. So this is the last case. As you can see, it's a large olfactory groove, and the pre-op and post-op I have put the same technique, and all three judiciously we try not to use any form of retraction. The only retraction is with the suction, and probably once or twice with a handheld retractor to go to the basal cistern to release the CSF. But the point is to go as fast as possible. We no longer think. The part of the tumor which is going under the fox, you may need to cut it sometimes. Other than that, in fact, all the three patients, only the unilateral access was used. In one, I did a bifrontal bone removal, but the access was only from one side because I was a little worried that in that young lady, if I get into bleeding, I may require to open the other side. But the other three tumors have been only from one side. So the techniques for the juniors is always the same. You go, depending on how the tumor behaves, you modulate your seed, use CUSA, Be very, very careful posteriorly, inferiorly, know all your critical structures. And in these tumors, remember that the vascularity would, especially the posterior anterior communicating complex, is one thing which can cause devastating injuries. So in all these relatively large size tumors, the sometimes when I feel that thing is there, after adequate coagulation, we sort of put glue and also cover that area with a fascia, because we have had a few cases where we have lost them due to CSF rhinorrhea. So as you can see, this picture is specifically put to show you that the different areas and to show you that there has not been any retraction induced injury at all. And these are the patients in their first post-op days, first post-op day and in a post-op day just before discharge. In fact, both this lady is from Assam, she is from near Guwahati, and this other lady is a politician. She has been campaigning for her MLA seat. So this is the functional outcomes in these patients, and it is possible. And this is for the young people, that as we get into navigation, we should use every type of appropriate technology and then keep on improving our skills so that each of these patients go back with excellent functional outcomes. The pediatric case gave me a little unpleasant surprise. That was an atypical meningioma grade 2, and we had to subject the patient to proton therapy. This is the lady who is preparing for her IIT. Now, we have residents, and this is what we teach the resident. We teach them where to run, where not to do that. We teach them how to get hemostasis. The interhemispheric and subfrontal approaches, obviously with their increased retraction, would be their thing. So I think this is the future. The era of retractorless neurosurgery is here. So it is not that no hands type of concept. It is a concept very simple, that if you can get away, neurosurgery is all about doing retractorless neurosurgery. Thank you for your attention.
Thank you, sir. Yes, moving on, I would like to invite Professor Adil Chagla to deliver a talk on microsurgical approach of craniopharyngioma. A small announcement, participants for the microvascular anastomosis workshop, the following doctors, Dr. John Royce, Brahmania Momin Sheikh, Miran Mary, Imam Hussain Ali, Rahul Saha, Dr. Harshal Jambulkar, Saurav Zambre, Rahul Jain, Ajay Kumar, Ashish Patnaik, Satish Anand, Raviraj Gorpade, Anshul Galav, Akula Sanjeev Kumar, Tamajyoti Ghosh, Sumant Kumar, and Lamkoda Tinkan are asked to head to the nearby hall. Thank you.
Good afternoon, everyone. For those who can keep awake, I hope I can add to that and not make it worse. Thank you, Dr. Siddharth Ghosh, for having me here. And it's always an honor to be part of this team. So let's start with something which is a rather difficult topic. And the reason for this is affects a lot of pediatric age group patients as well. So I would just like to say that a lot of this work has been done at the King Edward Memorial Hospital, and I'm presently at NIA. Craniopharyngiomas, we all know, are remnants from the Rathke's pouch. They're in a very precarious location, this right in the center of the head. And they're also over 50% of suprasellar pediatric tumors. What are the aims of treatment? Total but safe excision. So the aim is total, yes, but it has to be safe. So if a patient comes with visual problems, we must make sure that the visual problems go away. We don't add to the problems. Unfortunately, craniopharyngioma surgery cannot be done or should not be done if these problems are not sorted out. So how do we do that? No damage to perforators, no damage to surrounding brain, no damage to pituitary stalk, no damage to hypothalamus, no damage to visual pathways. That's a hell of a lot. And then with all this, we have to restore the normal CSF pathway. So this is the mindset of a surgeon doing craniopharyngioma surgery. And we all know that total excision is the goal, but there are dense adhesions sometimes of the capsule with surrounding tissues. The tumors are multi-compartmental, they are multi-cystic, they have large cysts, they have calcifications, and sometimes recurrent tumors pose further challenges. So this is the database on which I have this talk. And I always look at the clinical picture of these patients. Headache, vomiting, diminished visual acuity, among so many other things. We found out that patients who present with seizures have to be really looked after, may need prolonged ICU care, because there were some that came in altered sensorium as well. So these are the routine tests along with the hormonal workup. And of course, imaging considerations today with the quality of imaging that we have is very important. So the cystic components of the tumors have to be studied. Sometimes they are multicystic. Sometimes these cysts are in multi parts of the various fossas of the brain. And then, of course, you have the solid component. Sometimes the solid component enhances, sometimes it doesn't. And of course, you've got to study what vital structures are being compressed by these tumors. Calcification plays a huge role, and you have different types of calcification. You have calcification in the walls of the cyst, you have blob calcifications, you have speckled calcifications as well. So this is the suprasellar tumor, which is the most common. Then you have suprasellar with subfrontal extension. Then you have suprasellar with the sellar, which is sometimes endoscopically easily tackled. Then you have this huge medial temporal tumor, the retrosellar tumor. And of course, you have the intra-third ventricular tumor. Sometimes we call them giant when they're more than 5 centimeters. But what's more important is you can have supergiant, which is not only more than 5 centimeters, but they also involve the anterior, middle, and posterior cranial fossa. So of course, management entails surgery, which is what today's topic is. But one should also know you have adjuvant therapy today, which also works in craniopharyngioma, and you'd like to use it when appropriate. I have never used intracystic bleomycin. So surgical approaches, you have a craniotomy, which is the frontotemporal, the workhorse. Then you have the midline approach. You can have a lateral subfrontal. You can have a transcallosal, a subtemporal. In fact, Hakuba has gone on to say a petrosal approach as well to get to the retrosellar portion. Then, of course, you have transsphenoidal and the endoscopic. And as we've seen, the surgeon must know the microanatomy. He must know how the tumor is associated with this microanatomy, and the best approach in the interest of the patient should be used. So we've seen fantastic slides, and we've seen various relevant anatomy, but I just like to say that you must know the placement of the chiasm. The chiasm sometimes is prefixed, and often clinically you can even tell whether the chiasm is prefixed depending on the signs in the visual pathway. Of course, size matters. Most of our tumors are over 5 centimeters, but then even the small ones can cause a problem. So surgery, which is the frontotemporal, I always like to use the word basal because we excise the lateral 1/3 of the sphenoid ridge. We always open the dura towards the base. The sylvian fossa is open wide. The CSF is drained from the cisternal spaces. I have never needed to tap the ventricle. Advantages of this are obvious. The sylvian fissure, of course, the shortest possible route to the sellar suprasellar, the minimal handling of the brain, and as we just saw, Anil state about the fact that you don't need to even use retractors. I use the retractors when I find that the brain seems to be falling in path, so I do tend to use them at times. And of course, you have exposure of the contralateral structures, very few blind areas, and retrosellar access as well. So looking at the disadvantages, it's the oblique orientation. So those who are used to operating this would be at a better end of the stick. So you should always try and get more exposure. And of course, cadaveric dissection and courses like this would always help. Extensive bone work may be necessary and may increase your operative time, but that's not a rule. And if you have to see the tumor behind the ipsilateral optic nerve, then of course you have to angle the microscope or maybe even have a slightly bigger approach. So I prefer a bigger approach. I prefer a slightly typical frontotemporal rather than the T-ronal craniotomy. And this is for most of the large craniotomies that I operate. The important thing is I fix the bone back with sutures. I use the residue bone dust to reconstruct my flap. And I put the Surgicel, which is lying waste, on my table so that that bone dust remains in place and you get a good cosmesis. And it almost appears that the patient has not been operated. And the instruments that we have, fortunately, unfortunately, I'm in a teaching hospital in Mumbai, which makes me use just these few instruments. So I have the suctions of different caliber, dissectors of different caliber, the micro scissors, and a dissecting needle, which is often a 2 cc syringe with a 21 number needle. So these are the instruments. I try not to use CUSA. Occasionally, I have to use the drill when I need to drill the calcification. So we all know the routes of access, the interoptic, optocarotid, lateral to the carotid, and lamina terminalis. I just like to state that the lamina terminalis, even if I open it, I don't dissect any tumor through it. I just use it to displace the tumor down, and then I use the other avenues to access the tumor. I used to use the interoptic, but as you see in the pediatric age group, there's not much space between this. So as you look at the pediatric tumors, you're more tempted to go lateral to the carotid. And I'd like you to imagine the perforators like the crown of a king. So the perforators all going towards the brain, and you want to go below the crown, below this, and lateral to the carotid is probably the safest. So this is an interoptic dissection that you've seen. You can see that the tumor is radically excised. What I'd like to point out is the carotid. So the opposite carotid is likely to get injured if you don't know where it's lying. So this is the opposite optic nerve. This is the ipsilateral optic nerve. This is the ipsilateral carotid. And you can see the opposite carotid just there. Now, this is, again, this is the optocarotid space. This is the ipsilateral optic. This is the ipsilateral carotid. What you can see in between, a little fuzzy, is the pituitary stalk. And beyond that is the calcification that is adherent to the pituitary stalk. So you can dissect that if you're good with sharp micro scissors. Don't try to yank it off. You might yank the stalk. So you can clear it off using micro dissection, micro scissors. And what now you see is the pituitary stalk well in focus without any tumor attached. And this is the posterior clinoid. So, excuse me, can we have some signs? Now you can see this tumor, which is being accessed through opening the Sylvian fissure. I use a 2 cc syringe, and I use my zero suction. Using the drill, it's got configured into a particular shape and dimension, which allows me, it's like my cricket bat. It's the same weight. It's, so I'm handy with this kind of a technique. But then you can also use the scissors, and you can also use the 2 bayonet technique. Now, this is the tumor, which you can see. Try to keep the arachnoid dissection neat. So to keep it neat, try and avoid bipolar coagulation because that destroys it. And if you need to use 2 bayonets when you're dissecting this, try and use it. Then you use, my left hand is not as steady as my right, but nevertheless, I'm holding the tumor with my right hand and I'm separating the arachnoid with my left. And remember, the arachnoids are the ones that allow you to keep the perforators intact. So try not to cause any form of handling or injury to any perforator. In fact, hypothalamus and the pituitary stalk. And your outcomes will be what you would like to see in the post-op period. Now, I like sharp dissection and it's often done, but the trick here is not to go too close to the eloquent structures. Cut fairly in a comfortable way. It's like knowing where your off stump is. If you do that, and you will find that the dissection planes kind of tend to help you. And then the whole tumor will just deliver itself out. You don't have to really pull on this tumor. So the trick, like I would say, is to cut as distal, not as proximal. So you have a little bit of the tumor that you can handle. You can also use that tumor to dissect further. And then you can also use your scissors as a micro dissection tool and cut the pyearachnoid in a way where you don't touch or don't even handle the perforators. So with some of the do's and don'ts, open the sylvian fissure wide, gentle piecemeal excision, do not pull blindly. Both sharp and blunt dissection has a place. Preserve perforators and pituitary stalk at all costs. So total excision is always into quotes. Don't try to be bravado because you have second options. You can give radiation. It depends on the age of the patient. So in the observations that I've seen, total excision is more possible in solid tumors as compared to the cystic ones. Large blobs of calcification are hindered. Okay, no blood transfusion was required for any of the cases because you hardly have any bleeding if you follow the rules. With permission of the chair, maybe I should go on, or there is no time. We can stop. Okay. So anyway, these were the results. So we'll quickly run over with the results. Some of the pre and post-op scans of total excisions and the results as everyone would see. Well, I would like to just run through most of the results past. I would just like to conclude saying that frontotemporal basal approach, which is the mainstay of most of my excisions, is a safe approach, number one. Giant cystic tumors pose greater challenges for total excision. Near total excision may be followed up. You don't need to radiate upfront. Just watch the patient and the patient may not have a recurrence at all. Subtotal and partial excisions will require radiotherapy. Again, the mindset it should be adequate and what is tailored for the patient. So the bottom line is what you need to do is always with the skills that you have in the interest of your patient. For recurrent disease, I just suggest that sometimes you might need to just observe patients and see only when they complain and symptoms get worse, then you need to go back in again. So the take-home message is neck arachnoid dissection, avoid bipolar cautery, and with advanced microscopy, we get good results and we can not have any problems in the post-op if we just follow these rules. Thank you very much.
Thank you, sir. Next, can I please invite Dr. Avdesh Jaiswal to discuss endonasal endoscopic approach for craniopharyngioma? Thank you.
Once again, I am thankful to the Professor Ghosh and Professor Pandey for giving this opportunity. You see, using endoscope for craniopharyngioma, we have many weapons to deal with the same tumor. I think one should use the one about which somebody is comfortable and can give the best. So the surgical approaches are basically two, it being microscopic or endoscopic. Microscopic has been beautifully discussed by Dr. Adil Chagla, and I will be talking about endonasal endoscopic approach. So what is the rationale of this approach? This approach offers direct and is the start surgical route. It gives excellent view of hypothalamus and pituitary stalk, its blood supply, and inferior aspect of chiasm, which is not possible with probably with microscope. Every dissection with the tumor and the hypothalamus is done under vision. There is no brain traction at all. There is minimal approach-related morbidity and better cosmesis. So what are the indications? This approach should be used for midline craniotomy, not suitable for the lateral craniotomy with lateral extension. House for a big tumor, but present is restricted to midline. This approach is ideal. So this is the position of the patient. You should prepare for taking fascia for to do the reconstruction after the surgery. Lumbar drainage is very important consideration because most of the tumor at the end of the surgery, you get the third ventricle gets opened. It becomes high flow CSF leak. So you have to repair very meticulously. So for this lumbar drainage is required, and we use in every case. And we put lumbar drain night before surgery to avoid to reduce time in the operating room, and usually it's kept for 72 hours. The next thing is Hadad flap. We use Hadad flap in every case for meticulous reconstruction, and along with this we use fascia also. This is dural exposure. After doing wide stenotomy, you can see you have to expose the plenum. You have to remove the tuberculum. You have to remove the cellular floor. These both sides, optic nerve, lateral CR, ICA, everything should be exposed very well. You can see this MRI. You can see the MRI. Other thing is it preserves superior hypophyseal artery. You should try to see it and preserve it. As you can see here, this is the superior hypophyseal artery, just beautifully preserved. The other big thing is tumor calcification. Please remember that if there is calcification area, around that you will see tumor capsule. So you have to work inside. You can crush it with biopsy forceps. Sometimes you need to drill it, and you can very well remove it. I'll show you a short video. You can see this calcified area. The video is running at twice speed just to cover more part. You can see I'm dissecting all around the calcified area under vision. And I'm pretty sure that all around there is some amount of tumor capsule is there. So it can easily done. And you can take it out. You can crush it, take out in piecemeal also. So showing an example, this patient presented with bilateral visual deterioration, field cut, and endochronopathy. You can see large tumor, multi-compartmental, but restricted to midline. So this is the video. You can see the big exposure. This is dural opening in midline. Here this pituitary gland making lateral cut. You have to what I do after making bony exposure, I myself take break and my assistant also take break. Then only you can do this meticulous dissection. Otherwise, you all will not be comfortable and probably it might require. A result had dramatically better after doing this thing. So this is only piece of advice. I think not more than 15, 20, 30 minutes. You have food, you take tea, your assistant also should be comfortable, then only do it. This is my personal thing, but I do it. Kuntal is smiling. So now I'm dissecting the arachnoid. And Dr. Goel said that arachnoid is the mother of brain. This stands true here. So right now I'm working in midline, taking out some part of tumor and dissecting it. See, this beautiful dissection can only be done by under vision, under endoscope. Directly attacking the tumor, separating from all around. The tumor is very big, going up to the posterior third ventricle, but it's restricted to midline. So we chose this approach. take out some tumor in piecemeal. You see, I saw some calcific area. I'm trying to dissecting from all around because I know everywhere there is tumor capsule is surrounding it. So I'm quite confident I'm not damaging anything. Breaking with the ball probe dissector. Try to take out, separating from all around. This was a small calcification, not very big, as I've seen in radiology. And at the same time, some cysts also gets opened, and the material is coming out. You take out calcified area in piecemeal, and then after you take endoscope further deeper, and now you can see I am dissecting the tumor with the arachnoid. And as Dr. Gold says, arachnoid is the mother of brain, so it protects all the perforated and everything. This beautiful vision is very difficult to get by microscope. And now you can see how meticulously with the blend dissection. And this dissection you can do only after taking lunch. You see, now I'm separating the floor of the third ventricle in hypothalamus under vision. There is good plane. You can see the tumor. You can see this hypothalamus. Very beautiful plane. And believe me, this gives a lot of satisfaction. And you enjoy the procedure. So you can see how meticulously you can dissect the tumor from the hypothalamus, and same continues with all around. And it's very well possible. Don't think it's not possible. If I can do it, then everybody can do it. You have to give perseverance. And once you dissect, then take out some part and then debulk it to make more room inside for instrument manipulation. And Dr. Gold said there is no coagulation being done. So now separating from the left side. This is the pituitary stalk, this is the gland. You see how beautifully I'm trying to separate, trying to get the plane. And plane is always there, most of times. This is the floor of the third ventricle. After remove some part of most of the tumor, you can see I'm getting very good space. You see how I'm separating it. You can do everything under vision. And please remember, I'm assistant is holding a scope. I don't use any endoscope holder. This is the stalk. Now separating the tumor from the, if you see, I'm getting a very good plane here. That is the retroinfundibular part of the tumor. And this arachnoid, everything is protecting all the perforated everything from getting injured. and only two instruments are being used. One microdissector and suction. You have to have a lot of patience. And once you separate from all around, then take it out. It was a big multicystic tumor. You can see here the third ventricle opening. This ring curate is also very useful. So once you separate from all around, take it out. You can see how small the opening and how big the tumor. But you take endoscope inside and then work all around. So I have done all the dissection. Then only after I delivered the tumor. And now cutting in. Just rolled it. This part attached with the stalk. The third ventricle opening. It is very little flingy tumor was left behind. I could not manipulate my instrument with this. So I put gel foam first to cover it. And then after fascia, then some amount of fat. And then hard flap. We do not use glue at our institute. So this is post-op scan. It appears complete tumor has been removed, but I know that a small part of left behind. So to take home messages, this approach is useful for the midline tumor. It is safe and feasible, had distinct advantages. However, there is learning curve. Thank you very much.
Thank you, sir. Now, can I please call upon Professor Adil Chadha, Professor Anil Pandey, to be part of the panel discussion? And may I please request Professor Vernon Velho to moderate?
Thank you, speakers, for a wonderful session. And we have seen some beautiful surgeries. And to the students, do you all have any questions? Any doubts? Because none of you are asking questions. And the reason for me to moderate is to get questions from you all and to clear your doubts. None of you all have questions. Because if you don't have questions, then I'll have to ask the speakers. Well, my first speaker was Sukhdeep, and I think I can only congratulate you for the work you and Abida are doing. Keep going and see that you'll keep doing more of this. That's what. There are no questions for you as such, and keep going. That's what. Yeah. So we have our first speaker of the day who has shown us some beautiful surgical excisions of the anterior cranial fossa, meningiomas. So Professor Anil, what would be your take on olfaction in these patients? Because it's a big problem here, especially in those where olfaction is preserved. If it is gone, then you are good to go. But if it is there, what would be your take?
The entire debate is whether you use endoscopic and extended endoscopic, because the olfaction always goes. In fact, the best way to preserve olfaction is the transcranial way. So, I mean, the debate doesn't arise here because that approaches. We are doing the transcranial, so this is the best chance for the patient to preserve olfaction. Obviously, olfaction, which is already lost, that is not done. So, I mean, that we cannot do anything about.
Because many times the nerve snaps. Bigger the tumor, sometimes it gets played laterally, but sometimes it is not, and there are chances that the nerve can snap as you're doing it. Of course,
that's why perhaps the best thing would be to do as much of violence within the tumor,
yeah.
Make the capsule very thin, And then as VRM used to say that slow down towards the end of the surgery. We come very, very slow towards the end of the surgery. We fast in the beginning and the middle. I
So
think that
good
would be the ideal thing.
decompression
Yes,
first and
yes.
then disconnection.
Yes.
Thank you. Thank
Thank
you.
you.
I think using microsurgical techniques, you can dissect the olfactory tract quite a lot and you get a lot more space. It's not like the optic nerve. So it's very doable to dissect the entire optic tract along its path. Then it will flap and then you get even more space. So you won't have to snap it ever. It'll never, you'll get a lot of redundancy in the olfactory tract.
Okay. Anybody else has a question or comment? Okay, then we'll move on to Professor Adil Chagla. You've shown beautiful demonstration of microsurgical techniques. And my question to you is the worrying part after the surgery. So what were your comments on that? Because the monitoring, post-op monitoring of these kids is it's a nightmare sometimes, especially when you go for total excision, when you try to take out most of the tumor. So what would you advise and how would you monitor these patients?
Most of our cases would have diabetes insipidus to begin with. So that is also a nightmare. Sometimes you have outputs going into thousands. So you have to give your vasopressin early. Don't wait. Monitor the sodium very critically. So that's very important that we monitor electrolytes. Monitor the sensorium. That will give a very good indication because you're handling the hypothalamus. Sometimes kids also start having fever, which could be hypothalamic injury. So you should, to recognize the hypothalamus is not so easy. And I'm sure even through the endoscope, when you're dissecting, the hypothalamus and the pituitary stalk, I think the endoscope shows the pituitary stalk quite early. So maybe they're at an advantage there. But when you're doing the microneurosurgery, you should be able to identify the stalk as early as you possibly can. Otherwise, you're going to have even more problems. Post-op is always a worry, post-op care. And we are very thankful that both at KM and at Nair, I have a very good endocrino team. They're very abrupt when we call them and they come very quickly. So we manage these hormonal disturbances well. If you can't, then I think craniopharyngeal surgery is going to be difficult. One more point I'd like to mention is about seizures. Sometimes they have seizures. That requires even more critical care. So these are the two areas where one would have to be careful.
Yeah, Sanjay.
Thank you for asking this question. There are 2 points I'd like to mention here, especially in children. So one of our residents, Dr. Devesh, what he did was 14 days of every patient of craniopharyngioma and chiasmal hypothalamic glioma. He did urine output measurement, sodium, potassium, every single aspect. And we came to some very interesting conclusions. The first of them is that in the first 24 hours, don't give any vasopressin. Because what happens is that there is a time when the recovery will take place. And if you give vasopressin, this will cause sudden SIDH and renal failure or congestive cardiac failure. So the first 24 hours, don't give any vasopressin. Then after that, the second important thing is within 7 days to 10 days, all DI and everything will stabilize. So that's the time when you have to really take care of it. If it doesn't stabilize in 10 days, then it is going to be for a long time. This was one aspect. The second aspect is very interesting. You will have a patient who will not have an increased urine output, but will have progressive sodium level increase. And that is because the patient is dehydrated. So when the patient is dehydrated, you will have the sodium going into 110, 120, 130, 150, 160, 170. And yet the patient, and this is one patient where you have to give vasopressin. Because if you do not conserve water in this patient, he's losing water and his sodium is increasing. And here there will be a central pontine myelinolysis. That's the second point. And the third very important point which we noticed was that if a patient has persistent tachycardia following surgery, please keep a very close watch on this patient because after third day, when the hypothalamic edema increases, some of these patients will become unconscious and actually die. Thank you.
Thank you, Sanjay. My question for Avdesh is, we've shown some beautiful surgeries, and I think the indications are mostly for retrochiasmatic tumors. So what would you do if it is more suprachiasmatic and if you have a prefixed chiasm?
Sir, for endoscopic surgery, for craniotomy, Kassam has given a classification. Pre-infundibular, that means the tumor is in front of the infundibulum. This is the easiest tumor to operate by endonasal route. Then infundibular variety, where the infundibulum is involved by the tumor and expanded, and it cannot be saved. This can also be dealt with the endonasal route. The third is retroinfundibular. This can also be done where they have prescribed that you have to do transposition of the pituitary one side, and then after approach the tumor. And the fourth is the intraventricular, that is tumor entirely located in the third ventricle, and which should not be done by endonasal route. But both the tumor, this classification was given about 10 years ago. Now both our tumor are done by endonasal route, intraventricular also, by transtuberosinium approach, as well as the retroinfundibular, not by mobilizing the pituitary stalk, but just shifting towards one side and working in the tumor from one side. So all the tumor can be done, there is no problem. The tumor has to be in midline, that is the consideration.
And what about the age? Do you have an age bar in this? Because the smaller the nose, more difficult it is to put the scope.
Actually, I have Dr. Dandapani, he operated case, I think, 1 year.
Dandapani, you can
1 year
comment
age.
also.
I have operated about 4 year age. There is no issue. Even in recently, we operated a case where the stenoid sinus was non-pneumatized also, but still we could do it. There is no issue at all.
Dandapani.
Sir, regarding craniopharyngioma, I would like to comment 2-3 aspects. The first surgery is the best surgery, and you give the best chance for surgical cure. So we always try to be aggressive, except in 2 situations: when it is a child and when there is a documented invasion of hypothalamus as per the radiological grading. And second area is when there is a large calcification stuck to the ACOM complex, because ICA is very easy to dissect. ACOM complex calcified part is very difficult to dissect. Regarding the position of chiasm, actually endonasal approach is very easy between chiasm and the stalk window. So for a prefixed chiasm, endonasal surgery is very easy. For a post-fixed chiasm, if you have to come from anterior to the chiasm, you have ACOM complex and perforators, that becomes very difficult. So most of the surgeries which I do are between the chiasm and the pituitary stalk. And regarding the intra-third ventricular craniopharyngiomas, most of the time the craniopharyngiomas arise from the third ventricular floor. So the tumor per se provides a corridor into the third ventricle. So there is no contraindication for the third ventricular invasion per se. And for the postoperative management, we usually tell our residents hypernatremia is not to be managed, it is to be prevented. By the time patient develops hypernatremia, patient is already in lots of damage, neurological damage because of osmotic imbalance. So we are very aggressive in managing DI, but our yardstick is that DI should be avoided at all cost. Thank you.
What's your take on vasopressin? Should it be IV or should it be nasal? Because now the endocrinologists are going towards IV vasopressin.
So we give kind of, in the initial postoperative period, we give subcutaneous pitresin injections on SOS basis because they are very short lasting. And by the time we know that the patient needs a long-term medication, we go for oral tablet Minrin.
Rather than the nasal spray.
No.
Yeah. Professor Goel, you can have the last comment and then we'll close this section.
Okay. Thank you for that. See, for me, there are 2 things. One is nasal approach, one is cranial approach. My take will be when the sella is large, it will be nasal approach. When the tumor is very big, it will be cranial approach. When the tumor is going lateral, it will be cranial approach. when there is a distance between the pituitary gland and the tumor, if there is a centimeter of a distance or millimeter of a distance, then it is a cranial. You see, the thing is, craniopharyngiomas are relatively straightforward tumors. Once you open the cyst, the whole thing collapses, and the dissection can be relatively easily done. My question to you, Avdesh, and also to Dandapani. See, when you are removing a large craniopharyngioma, you do such a big bone work that you have to actually stop and take breath. You are removing tuberculum sella, you are removing planum sphenoidal, and you are removing the sella, and you are opening the third ventricle to the nose. I want to ask you, give me a very honest answer. How many of your patients, no matter how you reconstruct, I know this flap, that flap, this muscle, this fat, this fascia, I understand. You give me an honest answer. Where the CSF leak you could not control, and the CSF leak killed the patient, you give me honest answer in your series. In craniopharyngioma, I'm not talking of other tumors.
Only one answer. We are running short of time.
Sir, frankly speaking, I have not analyzed a comparison between pituitary tumor and craniopharyngioma, so I cannot give you the exact answer. But one thing, let me tell you, in pituitary, we do not use, because this is matter of CSF leak. We have done, stopped doing standard Hadad flap in pituitary surgery, only small nasoceptor flap. In every craniopharyngioma, we use standard Hadad flap. We close it meticulously with fascia, and the leak of craniopharyngioma is much, much less than the pituitary tumor. Actually, I have not realized, so I cannot tell exactly. No, not big leak, not big leak.
Okay, one more and then that's the end. Yeah.
I think this controversy is very pleasant. I do both. So, absolutely, I agree with Sudesh. If you're doing endonasal approach, you have to have strict indications, especially for craniopharyngiomas. You're doing an extended approach. The cella is small, the width of the cella. I'm not but you're not interested in the width. We are interested in anterior to the width because we are not going to touch the normal pituitary gland. Pituitary gland is actually pushed down and back. So you are actually drilling the face of the cella and the tuberculum and part of the planum. So that is a 1 centimeter. It's around about 8 millimeters to 1 centimeter width, around about 1.5 centimeter there. But we are over prepared for that. We're taking a Hadad flap, we're taking fat, and we're taking fascia. So it's a 3-layer gastric repair. For a central midline tumor, I do it for less calcification. MRI proven no invasion into the hypothalamus, no multi-compartmental. Many of our patients that we get in government institutes are very few patients come into that criteria. Even retrochiasmatic, you can do that. The CSF leak, I've done only 10 from endonasal, but I've done probably around 100 from the transcranial because our patients, they're multi-compartmental and all that stuff. But I've not had a single leak. If you're having a good plan. But then I put a lumbar drain in all the patients, take the lumbar drain out on day 3 or day 4, have a very strict protocol for management of hypernatremia. Regarding transcranial approach, I think transcranial approach, Trigeminal is good, but if it is a multi-compartmental, if it is going posterior fossa behind the clinoids, a lot of posterior, taking off the anterior clinoid process, cutting the falciform ligament, widening the opticocarotid cistern, or a temporo-based polar approach actually helps. The main morbidity and mortality is not because of stalk sectioning. I practically divide the stalks in now recently over the last 3-4 years in all cases, because I think these patients have to be dependent on mineral. It is better that they are, otherwise there'll be recurrence. So it is the main morbidity and mortality is because of the hypothalamic invasion. If prior hypothalamic invasion in which you're handling, or mere hypothalamic invasion which you're handling is so bad. The handling always happens because of the unseen areas, the blind areas, and this more happens in the microscope than in endoscope, because endoscope you're actually end on. When the microscope, that area is blind unless you are taking off the ACP, cutting the falciform ligament, looking into the falciform.
Thank you. Thank you.
Thank you, sir. Now we have connected with Professor Manas Panigrahi online. Sir, are you able to hear us?
No, I can hear you, but I'm just listening. Means you're running short of time. I don't want to present again.
Right, sir. We're very glad that you can connect with us through here. Do you have any thoughts or views you'd like to share?
And no, I would like to listen to the next lecture.
All right, sir. Thank you so much. And with that, thank you all for making this brilliant session. And that concludes the topic of anterior and middle skull-based tumors. I'll hand it over to Dr. Preeti.
Moving forward, we have the next session on lateral skull-based tumors, moderated by Professor Atul Goyal. For the first talk, I invite Professor Abida Shah and Professor Sukhdeep Jawar to take us through the 3D surgical anatomy of lateral skull base.
Welcome back, everyone. So after now, anterior and middle skull base, I will be, talking little about lateral skull base. And, lateral skull base as such is not a, some very well-defined entity, but here is some overview of this dissection. If you see, can I have the pointer? So as the talks in this session are mostly on the CP angle and tumors around the you can say pontine cistern and the anterior skull base. So I will be showing some anatomy related to CP angle, how to approach CP angle through. We have already seen the subtemporal approaches, but here translabyrinthine, or you can say transmastoid approaches, then the retrosigmoid workhorse for this kind of lesions. And this is the area, of course, this is the basilar artery and all the cranial nerves you can see here, right from optic, and you can see fifth nerve, and you can say sixth nerve, oblique, highly oblique course, then seventh, eighth here, and the lower cranials. So this is the internal acoustic matrix. This is the area of interest, how to reach this area, how to reach from subtemporal areas. Then there are translabyrinthine approaches, and some are defined from the pre-sigmoid, post-sigmoid. And sometimes nomenclature can be confusing for a beginner or young neurosurgeon. But just to have the overview of this anatomy, this is the petrosal surface, this is the internal acoustic matrix, which is located somewhere around, you can say, 1/4 and 3/4 of the petrous part of the temporal bone. This is the groove for the sigmoid sinus here. And this is the IAM, and then the trigeminal impression. Then we have the arcuate eminence of the superior semicircular canal. So these are relevant bony anatomy which you should understand, and the bones which you will be dealing to, reach this area most plays your temporal bone, petrous part of the temporal bone, mastoid part of the temporal bone, and part of the occipital bone. So this is the endocranial surface here. This is you have this sagittal. This is the sulcus for the sigmoid sinus going into the jugular foramen here, and on top of that, this is the area which is how to approach. If you see, this is the hypoglossal canal here. It's just over the occipital condyle, and this is the view from the below. And you see, this is the carotid canal. Carotid, very interesting anatomy here. You carotid canal entering here, then forming a bend, and then horizontal section, then again a vertical bend again to enter the foramen lacerum and going into the cavernous sinus. So all our skull base is revolving around these neurovascular structures. So if you understand their anatomy in 3D and do you know how these structures are related to each other, it becomes very easy to navigate and plan your surgery. And this is stylomastoid foramen styloid. This is a styloid process over here, and this is stylo, and this is a mastoid. Between them is the stylomastoid foramen for the seventh nerve. So for these approaches, just see this picture, beautiful picture, which will show you how this is the carotid artery going here. Then it have a forward bend going into the petrous apex. This is the structures of the middle ear and the internal ear here. Then we have this sigmoid sinus coming like this, then the jugular foramen and coming to the IJV. So these are, the anatomical structures which we deal when you are going from the lateral side. We have a labyrinth here, and you have the seventh nerve coming like this. So artery is internal carotid artery, nerve is seventh nerve, and the veins are the sigmoid and the major IJV here, and some part of the inner ear. So these structure you should know how they are oriented, how they are related to each other. Then this is just the top of view. This is here you can see this is seventh, eighth, the depth not very clear, little blurry. If you see the depth, fifth nerve is very clearly seen on this side. Here's the Meckel cave. This is the internal acoustic matters, and all this lateral. Just I showed you lateral skull base here. Now we will see stepwise. This is just to show you some just a stepwise. You take a flap. This then you have the gastric the gastric muscle. Then you remove. Then I'll move quickly just to show you. So this the facial nerve has been retracted. There's an opening of the inferior petrosal sinus. Sigmoid has also been retracted. So it gives you this very narrow kind of view. But of course, sometimes these approaches can be useful if you are dealing with some tumors of the jugular foramen. And this is how this in the next dissection, you can see a better picture. This is all the, this is a facial canal here, which has been preserved. Here is the facial nerve coming out, then dividing into its terminal branches, this external carotid. And this is the posterior band of the internal carotid. So we have a narrow window here. So when you are dealing with these approaches, you are handling some to the facial nerve, then you may be destroying this labyrinth also. Some that can, there can be loss of hearing. So if it is, so these approaches are suitable when this hearing is already not there. So now you can see all the ICA. This is the middle fossa dura, which we have seen in the subfrontal approaches. So now we are seeing the same picture from below. First we saw from the above how this ICA is going. So this is again the ICA, the beautifully all the facial nerve has been dissected here. This is how it is related to the external carotid and going to the parotid gland. And this is the labyrinth now coming into the picture. So once you remove this labyrinth and you can have some anterior view of the, you can brainstem here, ICA and internal auditory matters. So again, if you see it in this picture, now we have this very prominent here is the sigmoid sinus. So it is better to understand some are the pre-sigmoid approaches, some are post-sigmoid. So pre-sigmoid, they require a lot of bone work. They require assistance of sometime your ENT fellow. And post-sigmoid is the very favorable approach if you want to reach this area, and very familiar approach to the neurosurgeon. And I think all of you should know how to handle the brain, how to handle the cerebellum. Here you can see the labyrinth has been preserved. Fifth nerve is there. Then we have the fourth nerve here. Third nerve is going. Almost all the cranial nerves of the skull base you can see. So just to have for the beginners, the retrosigmoid approach, very friendly approach. You take a curved incision, straight incision, whatever you like. Expose the astrion, make a burr hole, and some vascular, this occipital artery and some branches of the muscular branches of the facial arteries. They can be there. You can cut them and make some space. And once you remove the bone, you will see the cerebellum. So now, many times these some ENT fellows, all other people, they say there is cerebellar retraction, you can injure the cerebellum. So there is a counter view, to go through translabyrinthine approaches. But if you know how to handle this cerebellum, and here again, you have to understand the cisternal anatomy, which I showed in your previous, this anterior skull base. So here your friend is the cisterna magna. So cisterna magna, generally our picture of cisterna magna from textbook is like it is a central kind of structure. But if you see, it's a very elaborate kind of cistern, very large cistern, and it comes all the way to, quite laterally. So you just lift the cerebellum, don't attack directly your internal acoustic matters. Lift the cerebellum, just release the CSF. And again, you can wait for 1 or 2 minutes. You will have a beautiful picture. Then you can try to, retract the cerebellum, and you will see the tumor here. And of course, the petrosal veins, you have to, be careful about them. Try not to, damage them. So once you retract the cerebellum, then you will have a very panoramic view of the, CP angle. Here you can see the fifth nerve. This is a motor part. This is a sensory part. The seventh, eighth, ICA loop you can see. And you can see lower cranials here and the jugular fossa. So very nice view, and you can keep on dissecting, keep on removing the tumor. And again, you can get more. Tumor will keep on giving you the space. So there is no need. You can have a retractor, but that will not be retracting the cerebellum. It will be just holding it in its place, because now CSF is not there to hold it. So it will fall. So just hold it. No need for any retraction or, be aggressive with the cerebellum. And if you see, if you are careful in all this, then you will have no problem with the cerebellum. So now for that, you have to understand how to deal with this anatomy. So this is again the far lateral kind of picture. You can see here the 12th nerve coming out. These are lower cranials here. And this is the vertebral artery going inside. This is a little confusing. So here you can see the 6th nerve going all the way, quite oblique course. And this is again the internal acoustic meatus and the 7th nerve coming like this. And this is all the picture of the lower cranials here. So again, this is the view from the posterior side, which we will be covering with the posterior fossa anatomy. So for this relevant anatomy, you can see all the cranial nerves here, 6 nerve here. This is again the internal acoustic meatus here. This is the lower cranial. I think with this bell is ringing. So I will just stop and we can see this anatomy. Thank you.
Thank you, sir. We now have Professor B.K. Mishra connected with us for a talk on microsurgical excision and approach to vestibular schwannoma. Are we audible, sir?
Yeah, very well.
Yes, over to you, sir.
Okay, thank you, Dr. Ghosh. Unfortunately, I'm not in India, so let me see if I can share with you online. I don't know what the quality of the presentation would be, but let me see. Are you seeing my screen? Can you hear me? Hello?
Yeah, I can hear you, Dr. Mishra. Anil Pandey here. It's quite clear, the presentation. Yeah.
You are seeing my screen?
Yeah, seeing your screen. It's multi-slide
Okay.
thing.
Now it's slideshow.
Yeah.
Right.
Not
okay.
yet. Yeah, it is there.
All right. So I have a long-standing interest in vestibular schwannoma surgery, and this, in fact, is the historical patient of mine in 1986 when I was a registrar in Edinburgh. The first patient we could save the facial nerve and the facial function and hearing. And that, of course, gave me a lot of interest in that. And I learned the interaortic canal drilling from the ENT surgeon there, Edinburgh, Dr. Dale. And this was the presentation we did in Chennai NSI meeting in 1993, 100 consecutive cases from Sri Chitra. And that, of course, led to a lot of interest in preservation of function in vestibular schwannoma surgery. So this is my current experience, and this is how they have been managed. You see about 1,000-odd cases by microsurgery and 600-odd cases by gamma knife, because we get a lot of patients from other centers to residual tumor gamma knife or primary gamma knife. My patients who have been operated by me, 17% of these patients have gone on to get adjunct gamma knife during their follow-up. So this is, I will, Dr. Ghosh asked me about two presentations about COOS 3 down and 4. So I'll give you first the COOS 2, 3, and then they go on to the last part, and maybe because it's consecutive talks. So in my practice, all cases have been operated in acoustic by only the retrosig approach, because we think that all sizes of tumor can be removed. Hearing preservation is possible. And there's very small bone anchoring at the intra-aortic canal. And that's the area you need to drill. Once you have decompressed, you need to go there. So that I don't think there is any need for extensive approaches, as we need some other skull-based tumors. So the two different positions which I have generally used, the lateral position, and of course initially we used to use supine head turn, but mostly I use today lateral position or the semi-sitting position. For a period of years, we continuously monitored all our patients for 12 to 2016 by semi-sitting position. But we have almost more or less abandoned this procedure because of some complications which is not under control and not under my control, except giant tumors or tumors with centrally high fiber meningiomas. Most of the tumors in the CP angle are now operated by this lateral position because there are some things which is not under my control. The critical thing, if you are doing semi-sitting, see that your leg is above the neck veins and your anesthetist is not asleep. But we'll skip that and we'll go on to, sorry. So as I said, from 2016, most CP angles have been operated by this lateral position in my practice. What about monitoring? I think it's the standard of care today. You can't get away from monitoring. It doesn't make a bad surgeon good surgeon, makes a good surgeon better surgeon. Your quality of preservation function is definitely better because it keeps giving you warning when you are close to the facial nerve, and then that preserves your function. The problem in our countries is failure of systems, so you need to have multiple systems. The critical instrument in my practice, both for tumors and vascular neurosurgery, is this calibrated suction, and which is used for different things, decompression, dissection, and what have you. The craniotomy, standard retrosic craniotomy, what I tell my residents, you need to see the sigmoid sinus and the transverse sinus always. I don't think there is any advantage of this extended retrosic approach, which has been talked about some people. There's no meaning at all. It's not necessary ever in my practice. Intra-aortic canal drilling, again, in my practice is standard of care, which I learned, as I said, 1985-86 from an ENT surgeon. You need to know how to drill it. Once you know how to drill it, it's a beautiful thing to do to achieve total excision. Do we need to do all the time? No, you don't. If the preterus is destroyed, the tumor is not going into the intra-aortic canal, it's a medial tumor, you don't need to do it. But if it is in the intra-aortic canal and the intra-aortic canal is reasonably intact, it's always better to take it out to have a total excision, number one, and number two, have a good facial function and sometimes hearing preservation. The key to the drilling is a wide drilling. If you do a narrow drilling, you will damage the nerves. And that's the recent publication in Neurology India, where they have talked about when they drilled it, they had the worst outcome because they didn't drill enough. And you want to do hearing preservation, don't drill laterally, you use the endoscope assistance to take out the tumor, lateral part of the tumor. So this is the Coos classification of which I was asked to talk about, this 3 or less than 3. So this is, I'll go through one tumor from the beginning to end. So we'll see how it is. Now this is the tumor, you see the sigmoid sinus, the transverse sinus, you see that. Now, the linear incision, some textbooks give this lateral cuts. I don't do it. It's better not to do it to have a watertight closure. The first step in my practice, the coagulation of the petrous, posterior petrous. This is the blood supply to the tumor which comes from there. And this is the tumor arachnoid plane. Some people have different connotation, different meaning to what is this layer with this epineurium or arachnoid. Don't worry about it. The one which is shining layer, which is in between the tumor and the normal brain, take that out. If you have a worry about what is that layer, go towards the tumor or towards the tumor, and you can leave some tumor there and then you can always come back. And then lot of decompression till you have enough decompression that the wall of the tumor which is left is falling on you. And then we can once you have done that, we dissect. This is the medial part of the tumor. We are dissecting this two-hand dissection. This is in lateral position. You still can do it. And once you have done enough dissection, enough decompression, and then we go on for the intra-aortic canal drilling. And the first thing, we coagulate that because there's a little bit of blood. I need to have a clean picture in my view. And then we first use a burr, and then so quick drilling there, it reduces your time. First use a burr. And then once you have reached thin layers of the bone, we change over to the diamond drill. And a lot of irrigation. And one of the important things, I just want to make it a point to the young neurosurgeons there, never have a patty or a cottonoid inside when you are drilling. That would be disaster. And then this is the dural layer, you cut it there, and then we decompress with very low power CUSA. And once we have had enough decompression, we use different instruments. This is a hook we use, or the nerve stimulator which you use to take out the lateral part of the tumor. And if it is a deaf patient, then you can drill enough. There's no problem. If it's a patient which you are trying to preserve hearing, it's better not to drill more than 5 to 6 millimeters. There are a lot of measurements you can have, but the ballpark figure is not more than 5 millimeters, 6 millimeter. You can have good hearing preservation if you want to preserve it. So that's the seventh nerve. You can see with arachnoid over it. You can see that arachnoid layer. And this is the layer, this is signing layer which protects that. That's brainstem intact. And now again, we are seeing the cochlear nerve, that's the facial nerve. There's a total excision there. And always important to pack the intra-aortic canal if you have drilled it with fat, because sometimes there can be air cells there, and that could be a disaster post of CSF leak, which we can lose the patient. Now, before you close, that's a linear closure. Before you close, put water there or saline. And this is one thing which has reduced our risk of CSF leak from the wound or the CSF rhinorrhea, is reinforcing the incision with fat always. And then, of course, the mastoid air cells have to be reinforced. Intracanalular tumor, same principle. You can have a total excision. Again, very few patients were doing it now. More and more patients are getting observed. And the last lateral part of the tumor taking out by the endoscope. This is a little bigger tumor. The only thing I want to show you here is once you have removed it, we do not open the arachnoids which are covering this is the 7th, 8th nerve. You can see that is the tumor there. We're dissecting it out. You have a total excision and you have removed the intra-aortic canal, drilled it. At the end of surgery, you can see the arachnoid still covering the lower cranial nerves. And that is the best protection. We don't open. We have had some debate whether you need to see everything. I don't think you should, because the more you open, the more likely you are going to damage it. So the risk areas, we all know, this is the most significant maximum adherence mechanical, which is just medial to the anterior canal, which is not well described in the literature, is the sharp angle in large tumor between intracanalular component and extracanalular component. And that causes the risk of injury. At the brainstem, this risk of injury is because of venous injury. Inside the intra-aortic canal and meatus is the arterial injury, thermal injury, and labyrinth injury because of drilling and use the endoscope assistance. This is a small adjunct which we have found useful using the fluorescein to differentiate between tumor and the nerve. The nerves do not enhance, the tumors enhance, and that does sometimes help. Preoperative tractography, this is 5th nerve, this is 7th nerve, 8th nerve is not so well defined, and this is also sometimes useful. This one, again, this is a Cous3 tumor. When the tumor is a little smaller, Cous3, but a little smaller, you can have a much better preservation of, you can see much better. You can see at the end of surgery, you see the nerves very well distinct. The facial and cochlear nerves are very well defined there. You can see that. And we always, at the end, I'll show you that we tend to do a cranioplasty today rather than craniectomy. So this is the Iranian girl whom we operated. This is fat there. You see grade 1 facial function and normal hearing, which is not always the case. Even a Cous3 tumor like this is a lady from Northeast, and this is total excision. And this more likely in my practice, there is a hearing drop rather than normal hearing. And that's more common than having a normal hearing, which is as good as the preoperative hearing. So that is there. So this is a Cous3 type with a cyst, a very nice tumor to operate. But she has this a lady who has good hearing. And again, we have to discuss all the pros and cons of different procedures. And this radiosurgery is a very strong competitor. This is 2 years down the line, tumor well controlled, the hearing is normal. So it's very difficult to beat that kind of thing. So one has to be aware of that. Now, in our practice, so intracanalular tumor, if it is asymptomatic, most of them go through a period of observation. Significant symptomatic vestibular dysfunction. If they're deaf, they go for radiosurgery. If they're good hearing, we still continue to advise for microsurgery because we can still, I think, preserve hearing, which is functional. But we need to audit your own cases, your last 100 cases. That should decide what you need to do, because surgery is not like medicine. It is your cases and what you can achieve that should decide what you should recommend to your patients. So earlier on, about 10, 15 years back, this is how we used to advise the patients, young patients, good hearing, small tumors, microsurgery, and we realized that in our hands, The gamma knife radiosurgery has a better hearing preservation in small tumors than microsurgery. And so today, if the patient is very conscious about his or her hearing, and the patient has good hearing, a small tumor, we would not hesitate to give radiosurgery as the first choice. Now move on to the giant or large and giant tumors. And what about the risk of hearing preservation? Is it possible? Is it useful? And what's the problem? So this is one 4-centimeter tumor, cystic solid tumor. You can see that there. This is the mastoid. This is a lateral position. So this is the anatomy. You just saw that the zygoma. My resident edited this video. The zygoma, draw it down to zygomatic inion line. You draw that, and 2 finger breadth behind the occipital, the mastoid groove. At that point is the asterion, and that's the point where there will be the transverse sigmoid sinus junction. So that is where we start with the burr hole just below that. And this is the mastoid. 2 fingers below the mastoid, 2 fingers above the junction there, and then you get. So that's my incision, a little bit curvilinear incision. And you see the lines, the mastoid tip there, 2 finger below, 2 finger above that zygomatic inion line. And this is the transverse sigmoid sinus, which has been opened. This is a large tumor of cyst, and this cystic tumor bulge. So I always take out the foramen magnum, especially in lateral position. Now this should not be done. Don't try to open on the cistern there and superior to the foramen magnum in these large and giant tumors in lateral position. Lateral position, go down below the foramen magnum, open the CSF there, and then once you have done that, because cyst starts to bulge and the cerebellum starts to bulge there. So we decompress the CSF, the cyst there, and the cerebellum is a sigh of relief. You can see relax there. And then you don't damage when you're operating. You don't retract the cerebellum. No need to do that. And you can have quite quickly you can take out the tumor. So that's the solid part. So same thing again, and the drilling. Now you saw that's a 4-centimeter tumor. I'll just go back so to save time. And this is again the 2-hand dissection. And this is the cystic part of the tumor. You can still take it out. This is traction, counter traction. Whenever you are in doubt, leave that part of the tumor. If you have a doubt that that is a nerve or tumor, you're not sure, leave that. You can always come back to that. And this is my suction without any, suction there. It's a calibrated suction acting as a dissector. Now this is the intra-aortic canal. We are putting there some air cells have been opened, so we are putting bone wax. If there is air cells, we put bone wax, otherwise just fat. And then again bone wax. Fat. Glue. We use glue all the time. And this is reinforcement of the dura with fat, mastoid fat. And this is 3rd day post-op. You see normal face function. Of course, he was already deaf. This is post-op CT before discharge. So you can have normal facial function, 4-centimeter tumor. Sometimes, pleasant surprise, you can have hearing preservation. This gentleman with this tumor, large giant tumor, this is fat there, total excision, hearing preservation, which is better than pre-op. Very, very unusual. Doesn't happen. This is again functional hearing, almost as good as the pre-op. Giant tumor, normal face. This is a lady with a large tumor, again normal hearing, normal face. And this is a lady with a significant edema, which is very unusual in acoustic, why this happens sometimes. And then you can have still functional hearing. And this is 3 months down the line in my clinic, talking to her mother-in-law. And she can hear her mother-in-law, she's definitely hearing. And what happens to the hearing which is preserved over a period of time in microsurgery? So this is 12 years down the line. You can see there is a little bit of drop of hearing, but still hearing is preserved. So this was last year, the patient came for a follow-up. So is it possible? Yes. The normal face is almost predictable in our practice. The hearing preservation is very, very unpredictable. So always warn, especially large tumors, that she or he is going to lose the hearing, and they should accept that. Otherwise, they will be very, very unhappy. What about very giant tumors? And for young neurosurgeon who are having a problem when you're operating a large tumor, don't feel bad about coming out. Don't hesitate to come out if the brain is bulging, because these are benign tumors. You always can go back. No shame in coming out rather than damaging the patient. So these are patients who have been referred to me. These are post-op, first post-op. They said NF2, giant tumor, and the other side's large tumor. Again, you could remove, still you can take it out and normal face. Another patient with similar problem, some problem with that surgery. This is post-op, first post-op. You can see, and you can completely take it out. And this is again huge tumor, first post-op sent to us. And there was small residual which we opted to go on for a gamma knife radiosurgery. Is it necessary to always do radiosurgery when we see enhancement post-op? No. Most of these are post-op changes, especially the first MRI after 3 months. We don't do anything. We just follow it up. And many of them just disappear, or they don't need any treatment in their lifetime. Now, what about gamma knife? We do gamma knife, and does it always work? No. 10% to 12% do fail if you obtain the appropriate indication less than 2.5 centimeter. And this is one such patient treated by us, 70+ lady with a lot of comorbidities, 2.5 centimeter plus tumor. And this was the time which was gamma knife, failed, significant edema, symptomatic. So we need to be prepared to take care of that, and which it did. We operated on this. The tumor looks almost white. They become avascular. They become firm. Remaining in the tumor arachnoid plane is the most difficult part of this surgery. The key to having a good outcome is to leave thin sliver of tumor attached to critical structures like the facial nerve, brainstem, and then you would have a this is almost a near total excision. You see the intra-aortic canal, we drilled it, we removed the tumor, and this is the post-op CT scan. This is a thin layer of enhancement, maybe thin layer of tumor which is left, grade 1 facial function before the discharge from the hospital. You can achieve that, so you should be prepared to do that. So this was published, I think, 2019, first 16 cases in Neurology India, and this is what I talked about. And this is very recently, last year, I think we published our current data of 24 cases. And there is a predilection for cystic recurrence in these patients who fail. Now, if it fails, now this is a tumor which had failed, which had one operation, one surgery, and a gamma knife, and then failed. And this resurgery is sometimes extremely difficult because of all these adhesions. So we use knife most of the time to separate, to remain in the plane. You can still do it. Now you see that. That is, the tumor looks white, and I'll go to the end of it, and we could remove the tumor, but at the end you can see the very scary, kind of sight of the bare brainstem when you have removed the tumor. See, that's the brainstem. That's the bare brainstem. I was very, very worried. I thought the patient must be damaged. But for whatever reason, and when we see a bare brainstem like this, I put a little bit of Surgicel. Otherwise, normally I don't use Surgicel at all. These are the lower cranial nerves that was intact, and we closed with fat. But you see, the patient did so well, surprisingly. Again, the reinforcement of fat with on the dura there. You see, this is second day post-op, normal face and complete excision of the tumor. So that can be achieved if you take care to leave thin sliver of the tumor attached. Now, air cells, I already told about that, and sometimes you need to use the endoscope to see it. Now, you see this air cell there, sometimes the microscope, this is the intra-aortic canal with the tumor there, and that's the air cells. So one has to be very, very carefully look for this, because this can be a disaster. CSF leak can kill a patient. Patient can die because of that. So one has to be aware of it. Now, sometimes we can't decompress the tumor because of some anomalous arterial, displacement, and sometimes the intra-aortic, the ICA is stuck to the intra-aortic canal, intra-aortic meatus. So I can't decompress before I can release this. Many times you need to drill it out, and sometimes you don't. And this patient, did not have to drill it out. We just have to take the dura out, We coagulated that. We cut the dura, and the artery was just stuck to the dura. It was not going inside the introductory canal. So we could save some time. We just cut it off. And once I have opened that, I cut that dura, I release it. And then artery is released with the dura, and then I can go on do with my surgery. So it's very, very careful. You can't sacrifice that artery. And this is another which can be disaster. This is the jugular bulb, high jugular bulb. This is semi-sitting position, and it's much more dangerous than in lateral position when the jugular bulb gets open. When you're drilling, you see that the gush of blood, but more important, the gush of air going in there. So you see that you continuously suck it there, put gel foam, and then we put glue there. We put a little bit of fat graft there. The problem is you have to be very careful after that if you want to drill anymore. So I think that is the final slide. Today, the function preservation is critical because we have adjunct treatment. Facial function preservation is the critical part. I think to my mind, hearing is a bonus in large tumors. Total excision, subtotal excision is okay as long as you can preserve function. Today, it's not appropriate to have total excision or subtotal excision with functional compromise. Having said that, many times we have patients who get damaged in spite of all our efforts. And that's a very, very, the last part of the tumor when you are very, very, you're doing everything going fine. You get excited, remove the last part of the tumor, and that you kill the nerves. So that's a difficult task, comes with experience, but unfortunately, experience comes at the risk of having a damaged patient. Thank you very much for your attention.
Thank you, sir. I'd now like to call upon Professor Manjul Tripathi.
Sir, this is Dr. Anil Pandey here. Both your talks are completed, no, sir?
Yes.
Thank you, sir.
Dr. Mishra, I would like to talk on the chordoma later in the chordoma session. Will you be available?
I have petroclival meningioma before that according to the program.
Yeah. That will come later on again.
Yeah, I'm here for 1 more hour. After that, I'll go for my meeting.
Okay. Then we should be able to do that. Okay, thank you. Then we'll call you again.
Yeah.
Thank you, Professor Mishra, and thank you for these 2 great talks, actually. And so now we are in a situation when we are here with the gifted people, and with the current armamentarium, we are able to achieve a gross total resection in majority of these vestibular schwannomas. My talk is actually, once you treat and there is a near or subtotal excision and there is a tumor, either it's a residue or it's a recurrence, now what to do with that? So 74 to 99% you can achieve a gross total resection, but even if you have achieved a gross total resection, there are 10% chances that you will have a recurrence of the tumor because there is a small residue usually at the facial nerve or the brainstem, and that's close to around 10%. If you have already done a partial resection, then there are chances in 44% cases that you are going to have a regrowth of the tumor in a very short span of time. And if you follow these patients for a longer duration of time, this percentage is going to be much higher. And in those cases, actually, you miss your chance of FF80, means the free from additional treatment, what you expected for this vestibular schwannoma. The axiom of rarity shows that the clinical controversy is inversely proportional to the incidence of the disease, and with the current pace, we are adding close to around 30,000 vestibular schwannomas in Indian population per year, and many of them are either getting a primary radiosurgery or a adjuvant radiosurgery to these patients. Being a radiosurgeon, I am in a unique opportunity while looking at the pre and post-operative scan and the face of the patient. And then the diagnosis post-operatively is in the 3 category. Either it's a gross total resection, subtotal resection, craniotomy with a bird beak appearance. Many times I get these kind of tumors where only the biopsy has been done and sometimes only the craniotomy has been done and the total tumor is still in situ. And now this patient is referred to you for the radiosurgery. So I come to know, looking at all those things, whether the approach of the primary surgeon has been the tumor-centric or the nerve-centric one. So you have a residue now, but now your approach turns to the tumor-centric. You start talking about, because the patient starts asking what are the chances that it would increase, it would remain static, or it would regress. If the patient is still symptomatic because of trigeminal neuralgia, because of the brainstem compression or cerebellar compression, I ask them for a second round of the surgery for the decompression. If that is not there, then I discuss the treatment options with him. And I think that there should be a realistic realization between your promises and his expectations. The problem is that nobody is sure about the natural history of a vestibular schwannoma, neither of a naive vestibular schwannoma nor a wounded vestibular schwannoma. And if you search it on the PubMed, the natural history of a vestibular schwannoma, you will find close to around 200 articles. And when you have so many articles, you probably do not know the natural history of the disease, especially for the microgroups when you have already excised some part, left some part. But if you go with a comparative volumetric assessment, you will find, and this has been reported repeatedly, that the growth rate is close to around 33.6% per year if you follow these patients with the 3D volumetric imaging. The chances of growth are much more when you leave the tumor in the cisternal component rather than in the internal auditory canal. And 69% of these patients have a growth of volumetric growth at a median of 1.1 year. Now the patient asks me, what are my chances that this tumor would remain stable? I say them that this residue, if it is small in size, there is a good chance that your tumor would remain stable. But most likely it would remain stable for a short duration of time. If you follow these patients for a longer duration of time, you will find that up to 2 to 3 years, they remain stable, but after that, they start showing the growth. So that depends. Your answer and your further treatments need to be curated according to the longevity of that patient. If he is a 78-year-old man, it's okay. But if it is not that, he is a young person, you need to be really careful. And then his next question is, my hearing is preserved. Would it be preserved or not? Well, your hearing is not only just is getting compromised, not only just because of the tumor size. There are other factors. There are vascular factors, there are biological factors, and definitely there are mechanical factors which are affecting your hearing. And for all possibilities, whether you observe a non-growing tumor or you give a proactive radiosurgery, your chances of hearing preservation down the line 1 decade are not more than 40%. By 5 years, you would be able to preserve it in 70% patient. And if the primary surgeon is actually an aggressive one, he might have this kind of a philosophy. So if you want to observe, be very careful in your observation, because your clinical and radiological observation needs to be very, very vigilant and with a comparative evaluation all the time. And at least this should be followed for next 2 decades. Now, the patients are very smart and they want the answers for the natural history of their disease. They ask me, what is going to be my growth rate if I do not do anything? Do you have any idea that whether this radiosurgery would work in my case or not? Because I say that 98% it's going to work, and 2% it might not work. He wants to know, am I in that 2% category? I do not have any answer to this question. Some have started asking me, can AI help me? Does my pathology tell you that it would work or not? No, nothing of that actually has any predictive value. What we have observed actually, that if there is a residue and it is more than 0.7 cc, and if the residue is in the cisternal component, then you are at a much higher risk of the tumor growth rather than having a very small residue or the residue in the internal auditory canal. Apart from it, if you have a recurrence when you have a completely clean postoperative scan, the situation is something like that. You left a snakelet, it's going to become a snake and it's going to bite you again. The tumor is growing. There is no doubt about it. Your postoperative scan was clean. Now there is a tumor. It's a sign that it's growing. So if you offer radiosurgery, what are your goals? Your goals are to maintain cessation of the tumor growth, tumor stabilization or regression, elimination of the open surgical risk while maintaining the functional quality of life, meeting the expectations of the patient, and being medico-legally secure. And most of these patients are actually now being subjected to the proactive radiation or at the sign of their first growth. And that's an observation which has been followed worldwide and even in our own practice. What's the usual pattern which happens to these patients? Like, this is a residual tumor. It gradually shrinks, and it shrinks to such a small extent down the line 4 to 5 years that you can say that it has reduced to close to around 40 to 50% of its original size. If you follow these patients, depending on the size, if it is a large one, then the chances of 10-year progression-free survival would be somewhere around more than 90%. And you get rewarded for your proactive treatment. The usual pattern which happens, you start developing a central necrosis, then the size starts reducing. These are co-registered images, and you can see that the tumor is gradually reducing in size. And if you follow these patients for a longer duration of time, this regression continues. I have a preserved hearing after surgery. Would I be able to hear again? Yes, you would be able to hear again. Whether your tumor grows or not grows, if I give a proactive radiation or not, if your tumor grows, then the chances of hearing loss are at a much higher pace. But if it remains stationary and I give radiation, then close to around 40% chances that you would be able to preserve your hearing. I never say that your hearing is going to improve. If it is already at a toss, this is going to remain at a toss. There wouldn't be any problem on your left side of the hearing. There are certain factors in radiosurgery which you need to follow. If you follow these practices, your hearing would be preserved. The best approach these days, because the facial nerve outcome is dependent on the size of the tumor, and that's the plant partial resection, where you just leave a sleeve of the tumor circumferentially over the facial nerve, wait for some time, let the tumor crumple, and then treat that tumor aggressively with the radiation. So the justification of the proactive GKRS for a remnant is basically on the historical sites and registries which show that your tumor control would be better while maintaining the good quality of life. The chances of persistent or new worsened facial deficit after radiosurgery would be close to around 1%. There wouldn't be any worsening of the tinnitus, vertigo, or disequilibrium, and the permanent trigeminal nerve deficits are close to around 3% if you follow these patients for the longer duration of time. You should attempt not immediately, but if your patient is having an Hausen-Breckman grade 1-2, wait for 3 to 6 months, let the nerve recover. If it is worse, then wait for around a year. Do not be proactive and follow these patients radiologically. Cystic tumors, if it is an intratumoral cyst, this is actually an excellent indication for gamma knife radiosurgery. The earlier concept was other way around, but now this is a routine which I am following and seeing these patients. When the tumor is intracystic, it gives a beautiful response. Large vestibular schwannomas, this is my international trial in which I was a part of it, 627 patients treated with the 12 gray, and these patients were actually not the good candidates for surgery, or there was a residual grade 4. So these patients had a tumor control of more than 94% down the line 3 years, with an excellent functional outcome as far as the facial trigeminal nerve is concerned. So SRS is safe and effective treatment for patients with COOS grade 4 presenting with non-life-threatening or disabling symptoms, especially when the surgical comorbidities are pretty high. Similarly, irrespective of the age group, it has a role, and you can actually try this. Sometimes the tumor shows some edema after the radiation, and you do not just jump to declare it a treatment failure. This is a pseudo progression, which is a very well-known phenomena. Until the patient is showing some clinical deterioration, you do not need to operate over it. These tumors regress on its own. Dr. Mishra just showed his series of the microsurgery after post-radiosurgery. Tumor becomes a little firm, arachnoid adhesions make it difficult, but if you operate with all these care, you can actually operate and give the similar outcome as a primary radiosurgery. If you need to give the repeat radiosurgery, yes, this can be safely done. And this is a very good series treating about 1352 patients, and all had control in the long term. This is the latest ISRS guidelines, which have shown that the tumor control for these large vestibular schwannomas of the residue and the small residues, you can maintain the good functional quality of life. And they have found that the results are better in the patients who were never operated and were administered the primary radiosurgery. Though it is a level C evidence, and there are ideal indications without disabling symptoms, with serviceable hearing, with comorbidities that make the resection difficult, and those who wish to avoid a surgery. Sometimes you get some complications. Like in this case, I developed a radiation-induced edema and I needed to give bevacizumab. Now this tumor is reduced to close to around 40% of its original size. The chances of radiation-induced carcinogenesis, this was my NF2 series in a trial, which we published in 2023, 15-year tumor control 52%, 15-year freedom-free additional treatment is 72%, and no radiation-induced malignancy. Post-radiosurgery, chances of intratumoral bleed, out of 10,000 patients, 25 bled, only 2 needed surgery, rest were all asymptomatic. And this is a much cost-effective procedure, and this is a much safe and day care procedure in comparison for redo surgeries in these patients. There are upcoming markers which can show that some tumors may progress, some just remain stationary. These are under evaluation. We do not have a final verdict toward them. So while deciding, you need to look at the age and the life expectancy, whether it's an sporadic or syndromic, and whether the patient can come for a regular follow-up in your patient OPD. That's very important to check. So the take-home message is that you can definitely wait, but you need to be vigilant, and at the time of the first growth, attack over it. Gamma knife is definitely useful in these patients with an excellent risk-benefit profile. It has a non-comparable tumor control and quality of life. I would definitely recommend to these patients, and I'm confident about it with my own personal experience and the literature resonating with my experience. Thank you so much. And I would like to use this opportunity to request you to visit, to come to the NOELCon, that is a Noble Art of Lesioning Conference. This is one which is the first of its kind in India for pallidotomy, thalamotomy, all these things which have gone into the sabbatical after the resurgence of the deep brain stimulation, all those techniques. These are very cost-effective techniques for our Indian population. This is the first of its kind. Takumi Taira, Horishawa, and Yamamoto are coming for this. This is in Bangalore, and this is going to be a fantastic meeting. So I request you, whosoever are interested in this, please come. Thank you so much.
Thank you, sir. Moving on to the next talk, may I please invite Professor Ashish Suri to discuss the modified Kawasai's approach to petrous apex pathology. Thank you.
Good afternoon. I thank the Walter Reddy team for the kind invitation. Well, I'll be talking about the modified Kawasai's approach to petrous apex. Petrous apex is, it's here. It's a complex area, posterior clinoids, posterior cavernous sinus, the upper clivus, and the bony anatomy is very distinct. And this is the posteromedial, the Kawasai's triangle, well known. And that is the triangle that Professor Kawasai proposed, and this we modified into a rhomboid with cavernous sinus dissection. And there was the posterior cavernous sinus dissection, posterior clinoid, and petrous apex. And these are my guiding lights. And after becoming a young faculty, my teacher, Professor Mehta, said, if you want to learn cavernous sinus surgery, you have to visit Dollins. And there I was in year 2000, I think 25 years earlier. And I started operating such cases. And I was invited to the 2006 Ljubljana meeting. Dr. Goel was there, I still remember. It was 20 years ago. And there I presented these two, the posterior cavernous anterior, and I think 15th cases series, and where so Vinko came on the stage and he said this would be named as a Dolin-Kawasai approach. Then I was very confident. I came back to AIIMS, did a lot of surgeries. Then a very bright young man, Dr. Manjul, joined us, and he was there with me for 2 years. And he did a volumetric analysis kind of based on the difference between the Kawasai and the modified Kawasai. It was published, Neurosurgery, Journal of Neurosurgery. And we found that it had the larger area and the volume than the other standard triangles and rhomboids described. The angle of the trajectory to the temporal lobe was more anterior rather than the posterior temporal lobe being dissected. The area and the volume were bigger. And these are the differences. I'll not go into details, but more important thing is there was a more medial mobilization of the V3, which I'll be coming down to. So standard approach, a temporal craniotomy incision, a patient the head tilted to the opposite side, a zygomatic osteotomy, temporal craniotomy, and a standard zygomatic osteotomy. These are the only instruments I use, except for the navigation, the intraoperative monitoring, and long forceps. These are my favorites. The steps, basal temporal drilling, and division of the widening and division of the middle meningeal artery, and the tentorial duplicature of the ACP drilled. And then we have the anterior cavernous sinus being mobilized. And that is the GSPN that we have to dissect from anterior to posterior, never from, do not dissect it away from the geniculate ganglion. That is the cavernous sinus exposure. When you open a cavernous sinus, this area becomes a rhomboid, and that is what it becomes. Drill the petrous rhomboid, and then after an appreciable drilling, you do a basal temporal urotomy. The tentorial incision is given behind the fourth nerve, and that is converted into a occipital, the posterior fossa opening, and then this is superior petrosal sinus that is divided, and then this is and then there's an incision over the gastric ganglion, and the fifth nerve is mobilized medially as well as laterally, and then this bridge of bone is drilled more, and then you can actually, this is the oculomotor trigone, which is mobilized and cut. Then we can actually see the seventh head complex, And we can see the sixth nerve at the Dolores canal. That's very important for petroclival meningiomas. So just to describe some cases, a 48-year-old male who was operated by retro-sig approach in another hospital had come to us with a petroclival meningioma. And this was, and we decided to do for the anterior petrous approach. That was a petroclival meningioma. Yeah, so temporal craniotomy, and we do, that is the foramen spinosum widened and the middle meningeal artery divided. And we open the two layers of the cavernous sinus. That's the nucleate ganglion, the GSPN mobilized. And that is the drilling of that's the basal durotomy. You can see the detailed videos is already published last year, I think. And that is the middle superior petrosal sinus, which is divided. And that is the tumor devascularization now done. After we decompress the tumor, then we can dissect the tumor from the nerves. So the first nerve is the fourth nerve, the fifth nerve. That was the fourth. I'll run through the videos because there are too many of them. And then use two forceps to dissect the tumor. The basilar perforators are important. That is the 7th-8th complex there. That's the fifth nerve. And then that's the last bit of this over the sixth nerve. And complete excision was performed. And the basal dura was closed. So that is one tumor in which we have used this approach in most of the cases. Many of our cases, the series published in World Neurosurgery last year. Especially in bigger tumors going lateral to internal auditory canal or down into the lower clivus and the mid clivus, we combine a retro-sig approach along with that. I don't like the complete petrosal approaches. I think it's too mutilating. These are the cases. Another case, a 60-year-old lady, left-sided facial numbness and 50% V2-3 loss. This was a bony tumor in the petrous apex, indenting into the midbrain. I'll just rush through this. Was an elderly lady, a lot of burr holes because the dura was stuck. And again, I'll just skip over the peeling of the lateral dura. That's the vitreous rhomboid being drilled. The basal durotomy. And that's a division of superior petrosal sinus with Liga clips. Cutting the tentorium behind the fourth nerve. And that is, we're using the bone CUSA. It's a very bony tumor. Chondrosarcoma it came out to be. We used everything that would, so we used a drill, we used a sonopet. And then you could remove the tumor, and the sixth nerve was seen and preserved, the fifth and the sixth. And that dura was reinforced with fat and fascia. And the tumor was completely removed. And patient had improved. We use this approach in chondrosarcomas. I don't use endoscopy except if there is a pure midline chondrosarcoma or chordoma. So this we used then the extended temporal approach. Later on, this one was with an endoscopic, which was one going with sphenoid sinus. Another case, a 9-year-old boy with 9-month history of vomiting, diplopia, blurring of eyes. This is a giant craniopharyngioma. There's a lot of calcium, but extending into posterior fossa. You cannot use endoscopy in this. And so you need only a transcranial approach, but you have to plan a transcranial approach, which side it would be. So a lot of calcium over the suprasellar, a big lateral retrochiasmatic. We had a preoperative planning done. And again, a temporal craniotomy, zygomatic osteotomy, division of the middle meningeal artery. Vitreous rhomboid was drilled. We combined both the extended temporal approach and the temporopolar approach for this. Superior petrosal sinus is divided, and we attack the tumor in the ambient cistern first. See the fifth nerves, then the ipsilateral seventh, eighth complex. We go down the vertebrals. You could see the lower cranial nerves on the both sides. It took nearly 2 hours dissecting it over the sixth nerve. That was the most difficult one. Then we could see the opposite side, PCA, and the fifth nerve opposite side. And the basilar. And we dissected between the third and the ICA complex. This is the place where the anterior carotid artery is the most important. You cannot injure, but you cannot even put it into spasm. Keep on irrigating with papaverine the moment you are in that area. Take off the tumor from the hypothalamus. So it's a combination of an extended temporal and a temporopolar approach. And we had a complete excision. The patient still under follow-up on Minirin. We had published such the giant craniopharyngiomas, especially for extensions earlier as well. Then dumbbell shape, which fifth nerve schwannomas, is a standard approach. Extended middle fossa with drilling of this petrous. Part of the petrous apex is already amputated. Just run. So same procedure. I'll just run speed idea. The moment you have reached that interdural plane, we decompress the tumor. These tumors are much more firmer than the vestibular schwannomas. And then drill a bit of extra petrous apex. Decompress it more and then dissect it from the nerve fascicles. What I learned from Vinko Dolenz 20 years ago, that these patients' sensation should either improve or remain the same, because you must search for the fascicle from which this tumor is arising from and divide that fascicle. If this patient deteriorates, that means your surgery has not gone well. So that is the last fascicle from which the tumor is actually arising from. Usually it is the V1 fiber. And that is the brainstem down below. Yeah, we back it. And multi-compartment epidermoids going into posterior fossa, bilateral middle fossa. And we use this approach again. This is the only unilateral approach that can remove the complete tumor, a small question mark incision. Then the temporal durotomy. That is the fourth nerve, cutting the tentorium behind the fourth nerve. And the suprapetrosal sinus. And then the epidermoid comes out from the ambient cistern, the CP angle cistern, the crural cistern, and we have 7th, 8th, 6th, 5th undervision. And then we go to suprasellar cistern. And we use the endoscope to see the extent of the dissection. Again, complete excision. Use this approach for histiocytosis. Basilar aneurysms, I'll skip this. Interesting case of 2 cases of P2 aneurysms in which embolization was a failure and they wanted us to operate. It was a planned STA-PCA bypass. Took the superficial temporal artery, and this was the shortest route to the ambient system. Did a petrous apex drilling, reached the ambient system, the fourth nerve, the PCA, saw the aneurysm, the partly thrombosed giant P2. We harvested both the vessels. We did an N2 side of the parietal branch. We kept the frontal branch for salvage. Documented the flow with Doppler ICG, and then did a parent trapping of the aneurysm and divide the frontal nerve branch. Another case which was done the same. To conclude, transcavernous anterior transpetrous rhomboid approach, we can treat a wide spectrum of cases. We have used for extradural lesions like chordomas, chondrosarcomas, angiofibromas, intradural lesions like umbilical-shaped schwannomas, intradural petroclavimangiomas, basilar aneurysms, P2 aneurysms, epidermoids. Cadaver training is very important, and master microsurgical skills like microsurgery skills, arachnoid dissection, and high-speed drilling. Thank you.
Thank you, sir. May I call upon Professor B.K. Mishra next to deliver a talk on petroclival meningioma treatment strategies.
Okay, so come back again on the management of petroclival meningioma treatment strategy in our practice. As we know, the definition of petroclival meningioma is important because clubbing all the tumors in the petrous apex and CP angle is not appropriate. These are meningiomas arising from the upper two-thirds of the clivus and the petroclival junction. And this part, the medial to the trigeminal nerve, is the one which was added on by Sam Al-Mefti. The first part was by Professor Yasegel. They constitute about 10% of posterior fossa meningiomas, and they could be of different varieties: soft, hard, firm, vessels inside, easy, difficult, and impossible. So the issues are whether to go for total excision, subtotal excision, what approach, radiosurgery if you want to do it, what timing, primary radiosurgery, whether to treat them at all or not. So this is my practice about 35 years back, and during Sri Chitra time, majority of my patients were operated through a dedicated skull-based approach, and these are some petrosal approach, large tumors, pre and post-op, central clival tumor, similar approach. This is the first patient, in fact, which was, eye-opener to me. This 1989, this lady with had gone for this petroclival meningioma, middle fossa, and posterior fossa. We went for a embolization, which I have never done after that. And the patient deteriorated in the angio suite, coned, and then we had to operate 6 p.m. starting at 7 p.m. in the evening, coming early morning next day. And this we operated, though we had planned for a combined approach, but because of the late night, I thought I'll try to remove through the retrosig, and which we could. And the patient had multiple, of course, cranial nerve paresis, but 3 months down the line, she came walking to me with only 6th nerve paresis. And this is, we talked about it, the supracerebellar approach, and 1991, I presented this, and Neurology India, it was published in 1991. The Harkar's meeting, we talked about it. So some of these tumors are a very good arachnoid plane, and they're easily excisable. And this is one you see going into the medial to the trigeminal. Through the nerves you approach, and this is critical. The tumor arachnoid plane decides what you can't do. When there is a breach of pia, doesn't matter how good you are, if you're trying to achieve a total excision, you damage the patient. And this is something which we removed through the retrosig approach, and the standard now, many surgeons do it. This was earlier on in our practice. And you see, this is that the 6th nerve, 7th, 8th, 9th, 10th there. This is the, you see that's the arachnoid there. And that's very, very good sign that you have not damaged, that the pons there. And that is actually the 5th nerve. That's not the, so that's the 3rd nerve. That's not the 5th nerve. That's the 3rd nerve. So there's a supratentorial compartment. And this arachnoid, seeing at that's the 5th nerve. So that arachnoid at the end of surgery suggests that you haven't damaged the patient. The brain is not injured. Now, this is a little bigger tumor, and going into the middle fossa, this is a lady which we said that we'll do in 2 stages. First, we did retrosig, but this was a soft tumor, and there was no middle fossa attachment. So we could take out the whole tumor through a retrosig approach. Complete excision could be achieved from a simple retrosig approach. So if I had gone for a big approach, that would have been unnecessary for this. So you see the complete excision of the tumor delivering like very nicely there without any problem. This is the post-op. You can see the post-op MRI, the complete excision of the tumor, no damage. The T2 image is critical. There's no brainstem damage, no neural deficit. And this is before the discharge from the hospital. Tumor more central, a little more difficult, and this is where the semi-sitting position, we still use it. And this is what we call the supra-paracerebellar approach. My trajectory is much more supracerebellar than the retrosig approach. And this is, of course, a significant attachment to the tentorium also these tumors have, and the blood supply also there. And so we take that, the blood supply out first, and then we remove tumor in piecemeals. Again, I will skip many parts of the video just to go to the last part. You see there is no retraction have been used. The cerebellum is very nice and soft. This is the type of dural incision we use for this kind of approach, and you can achieve a total excision, like you see the post-op complete excision this achieved in this type of tumor. When the tumor is a little more firm and it is the middle fossa extension is stuck there, then again you need to have a little more than what just doing a supraparacerebral approach. We need to do the same thing, but then we need to do the suprameatal drilling. So once we have decompressed, taken out the posterior fossa part of the tumor, that's the basilar artery and the branches, we dissect that out, and then we have removed the posterior fossa component, and then we drill that's some part of the posterior fossa component still being removed. Again, this is semi-sitting position. This is superior. This is the drilling of the suprameatal drilling, and that gives you that about 3-4 centimeter space to remove that part of the tumor which is going to the Meckel's cave and to the middle fossa, not into the cavernous sinus. We don't today. I don't go to take out tumors from the cavernous sinus in meningiomas. Some other tumors, yes, not meningiomas, at least not in my practice. And then you can achieve a total excision through a retrosig, suprameatal drilling. You see this complete excision of the tumor. That's the CSF space there, no damage, and complete excision achieved. A tumor much more higher, clival meningiomas. You see this is a young man who presented with headaches and visual compromise. All the circle of Willis is completely inside it. So it's scary tumor because I don't know why this comes up. So we were worried about what to do, but anyway, finally we did it. A OZ approach and extradural anterior craniotomy. A standard for many surgeons are doing this. Nothing very unusual about it. Why this is coming up? And then once you have done that, you have that enough space, and then you open up the sylvian fissure widely, and that's the critical part. So tumor is going very high, so we need to take out the anterior clinoid, so that gives us space so that we reduce the retraction. Wide opening of the sylvian fissure again helps in no retraction. You see, there is no retractor there. That's the frontal lobe, that's the temporal lobe. The attachment has been coagulated. Again, the tumor decides what you can do much more than the surgeon's expertise. The tumor is a tumor which a very good plane, no pile breach, and not very firm, soft tumor which you could decompress. So we could achieve a total excision through this approach, no retraction. At the end of surgery, you see the basilar top with both the posterior cerebral, and that's the most beautiful sight for a surgeon at the end of surgery, that you know that you haven't damaged the patient. And this is the post-op. You see the complete tumor excision, and the didn't turn a hair. That doesn't happen always, but when it happens, it's the most kind of pleasurable experience for this neurosurgeon. Now, this is a lady from Pakistan actually who came to us. This is had one go. The Pakistan neurosurgeon had one go. You see that there. The tumor was all there because they may have had some problem. They backed out. So we did this in 2 stages. We first took out a retrosig approach, and this is high up in the clinoid, that attachment. We took out to a frontotemporal approach. But in spite of that, there was some tumor still left. You can see that there. And since this patient is unlikely to get followed up with us, this was about maybe 15 years back. And we went on to give gamma knife. They came back after 3 months for gamma knife. That's the usual time we give gamma knife. We are going to go for upfront gamma knife. And then, of course, I don't have any follow-up on this patient. This patient is a lady in 1997. I operated through a retro lab approach or a translab approach. And you see the translab approach, and the tumor in the cavernous sinus was left. This is a lady from Oman. And again, they opted for upfront gamma knife. So 3 months down the line, we did the gamma knife. That was 1997. So after 12, 13 years, I had gone to a meeting in Oman. When she came and met me, the tumor had remained, static. There was no growth in the tumor, and the patient had no symptoms, no deficit. So very, very happy patient there. Now, this is an ugly tumor, and this is the pile bridge in T2, irregular outline in the T2, which should give you that warning that doesn't matter how good you are, don't go for total excision, which we did. This was in 2000, and we tried this a patient from actually Delhi, and we tried to remove in 2 stages. We didn't achieve that. We achieved what? The brainstem damage. This T2 damage in the brainstem, tumor still there, and then she subsequently went on to get gamma knife. He took 1 year. He was a highly functional multinational company high up in the cadre. It took 1 year to come back to job, has compromise of the cranial nerves, but otherwise functional, but took 1 year to come back. So these are ugly tumors. Today I wouldn't go for that tumor total excision. I would go for subtotal excision. Now, this is a young lady from, husband is a doctor from UK. And this is a tumor we operated. We had a lot of monitoring problems, warnings, and we left this tumor. Now, we didn't do anything. This is about, I think, 8, 9 years back, I operated. And subsequently, about a couple of years back, they told me that she has a recurrence there, and they're getting treated in London there. Sometimes you do upfront a primary gamma knife, and this is one such patient. It's an elderly patient with lady with atypical facial pain. It's a plaque tumor, not a big volume. And so we went for gamma knife. The success rate is not very high. It's about 50 to 60% pain-free. Fortunately for us and for the patient remained pain-free, so that was good. So this is my personal experience. There's some analysis there. I'm running out of time. This is how they have been treated. Out of these 114 patients, 24 have gone on. These are my patients who have gone on for radiosurgery, and these are primary radiosurgery. This is a patient who I had operated some 20 years back through a retrosig approach, 2005, almost total excision or near total. I was okay, and then came back with a recurrence in the foramen magnum, which we have operated now. So we need to follow them up. Now, so this is a man which I've shown many times who came 96 to me with this tumor, 6th nerve paresis. I advised surgery. He ran away to come back after 10 years with a swelling on the forehead. And that was a tubercular abscess, which you put a needle, and the patient died after 1 year of that. The tumor was there no functional increase in the deficit. He died of a myocardial infarction 11 years after my advice of surgery, which he did not do. This lady we're still following up. Is almost now 10 years now. This tumor, extensive tumor from infratemporal fossa, heavily calcified, nothing done. The patient has put on weight. The tumor has remained stable. So I will skip all this. This is something which he debated with Sam Al-Mepti in his book. This is something which published. I'll skip all that because I'm running out of time. I know you are having. So this is our current protocol. Brainstem symptoms are there. Yes, surgery. Cavernous sinus involvement, yes. A subtotal excision, radiosurgery, no. We plan to take out the tumor if there is a good plane. If the bad plane, they go for a subtotal excision. If there is no brainstem symptoms and the patient is elderly patient, they always go for a period of observation. If you need to do gamma knife, it is always staged elective unless the patient is difficult to follow. The temporal course suggests there is a large tumor which has a rapid growth. Otherwise, always on recurrence. For the young neurosurgeon there, you need to learn it. You need to go to the lab. Don't follow blindly. These are difficult tumors sometimes, so we need to have the patients to do it. And some of these tumors, but not all, should be totally excised. Some can be conserved, some radiosurgery. Retrosigmoid approach is appropriate in the majority. Dedicated skull-based approach is essential in some, so the young neurosurgeon need to have that expertise of having skull-based approaches. And tumors should dictate approach rather than the surgeon dictating approach. Today, about 30 years back, I would sit there for 12 hours, 14 hours. I don't do that today. I would stage it if I think it is going to take more than 7, 8 hours. Radiosurgery, useful adjunct, there's no question about it. And our philosophy today is radical but safe excision. Thank you very much for your attention.
Thank you, Professor. Next up, can I please have Professor Kuntal Kantidas to talk about combined transcavernous and transpetrous approach for petroclival meningioma? Thank you.
Good evening, respected chairpersons. Thankful to the organizers. I'm actually David looking at Goliathic skull-based surgeon sitting here. And this presentation is primarily targeted for the junior neurosurgeons because that is where I belong, I think. So even in the days of minimally invasive surgery, I think the expansive approaches are still relevant. As you know, if you are having a pathology in this area, the petroclival region, with or without extension to the interpeduncular and the suprasellar area, as Dr. Abdis said, he'll probably not go endoscopic, and most of us would go for transcranial route. So when you talk about transcranial route, the most commonly employed route is the anterolateral route, with or without removal of the entreclinoid and peeling of the cavernous sinus. The second way of dealing with such a lesion is going posterolateral, that is the Kawase approach, wherein you drill the petrous apex and you reach this lesion. But if you have a very extensive multi-compartmental pathology, you may like to combine the two, and you get an exposure, what is called the Kawase Dolling approach, what Dr. Ashish has shown. We need to know certain important things. We have to deal with these bony structures, the entreclinoid process. We have to deal with the posterior clinoid process, and we have to deal with the petrous apex in order to have an unrestricted view of this area. Once we deal with the bone, we also have to deal with certain neurovascular structures. For example, the optic nerve, internal carotid artery, the clinoidal segment, and all these nerves which are running from the posterior cranial fossa to the middle cranial fossa to its foramen across the cavernous sinus. So we need to peel the cavernous sinus out here. As this line demarcates, beyond this is the extradural part, and within this is the intradural part. So even if you have to work intradurally, we may have to go for extradural peeling. And we have to be mindful of these two important bony triangles, what we call as Kawase rhomboid and the Glasscock triangle that I'll show you. So the key to skull-based drilling is to understand the bony anatomy. If you look at entreclinoidectomy, extradurally, we have to know that there are three routes with which it is attached to the skull base. One is the lateral route, which is nothing but the extension of the lesser wing of sphenoid. The second one is the optic canal or the medial route. Once you drill it, the optic canal gets deroofed. But this is not enough. In order to mobilize it completely, you have to drill the optic strut as well. This optic strut actually attaches the entreclinoid process to the sphenoid sinus. So once you drill these three attachments and you make it free from the ligamentous attachment, you can take the clinoid out. Now let us see the petrous apex area. We have this V3 running from the posterocranial fossa until the foramen ovale. We have the GSPN here. We have the free edge of petrous, and we have the arcuate eminence. But is it enough? What we sometimes tend to forget is the internal auditory meatus. Let me tell you that. So if you join the GSPN and the arcuate eminence, the angle it makes, you just divide it into half. And if you draw this line towards the free petrous edge, this is what is your internal auditory meatus. And why it is important? Because here you have the suspected location of the cochlea. So in petrosectomy, if you're not mindful of this anatomy, what you can do is you can damage the cochlea and it can lead to hearing loss. So petrosectomy actually is done here. This is the Kawase's rhomboid. And if you see, if you want to increase the exposure, there are two ways of doing it. One is mobilizing the V3 and extending the drilling here, which I'll show you. And the second way is go lateral to the IAM. So this is called post-meatal triangle. So you can combine the two, but be mindful that the cochlea is sitting here and it can cause a hearing loss. So I'll show you a video to show the steps. This is a frontotemporal approach. We are starting with the meningeorbital band division. We use sharp dissection to start peeling at this point. We use knife and we start peeling. Now what you'll see out here is the spinoparietal sinus. We seldom pay attention to this. We have to remain anterior to the spinoparietal sinus. So I've gone more anterior now. The peeling is continued posteriorly, and unless you peel up to V2, it is impossible for you to expose the entreclinoid process. In our institute, what we prefer to do is we release some amount of CSF at this stage. Even though we are extradural, we find that the dura collapses and creates space. The next step is to deroof the optic nerve by drill and stop technique. We use a lot of irrigation. So what we are left with is the optic strut, the third attachment. The optic strut is drilled end on. Be careful that the carotid is lying behind. So once this is drilled, the clinoid is easily mobilized and it is taken out. You can see the clinoid. So what we're left with is the optic strut. Now we continue the peeling posteriorly. We see the V2 here. What I want to show you is the spinoparietal sinus and its drainage between V1 and V2. So this is very, very important. You have to expose this area, and this is the area where the fibrin glue should be injected between V1 and V2, and this will immediately stop the bleeding. Once it is done, you go posteriorly. The middle meningeal artery foramen has been already dealt with here. This is the V3. And as you go posteriorly, we like to expose the GS pin by anterior to posterior dissection because it reduces the traction on the geniculate ganglion. We have the petrous apex now in front of us. This is the GSPN. This is the free petrous ridge. Now, this is the Michel's cave, the Michel's impression. So mobilizing third nerve gives a quadrilateral view. So this is what we are going to drill. We have to be mindful of the cochlea here. So the petrous apex is drilled. Now, it is very important to elevate the fifth nerve, the V3 division, and remove the apex of the petrous as well. So we see we have been able to extend the petrosectomy here. So we have the posterior fossa, we have the middle fossa, we have the tentorium, where the spinoparietal, suprapetrosal sinus is running. So you can cut the dura across like this. So we start the opening dura from the posterior fossa. This is the fifth nerve. So we extend it anteriorly. Here is the fourth nerve. And what I have learned is the dura should be opened parallelly at the skull base. So this is how you avoid the brain and you reduce the depth of the surgical cavity. So this is the exposure that we get at the end. We have the fifth nerve, fourth nerve, third nerve, second nerve, ICA. So, and the entire middle and posterior fossa is connected. So far, I have done 12 cases over the last 1.5 years, mostly petroclival meningiomas, some trigeminal schwannomas. As you can see, some intra-axial tumor conditions like brainstem glioma or even cavernomas can also be dealt with this. I'll show you a short video of a petroclival meningioma in a 30-year-old lady. As you can see, she has the bicompartmental tumor. Maybe some of us would try a retrosigmoid approach here, but for me, the first time is the best time. So why not go for an approach through which I can take out the tumor completely? So we chose the right-sided combined Doling-Kawase approach in this patient. This is the exposure, frontal side, temporal side, sphenoid ridge. We generally begin with a limited posterior orbitotomy. Once this is done, this is the meningio-orbital band. We sharply divide it. And once this is divided, the peeling starts. As I said, it is our practice in our institute that we release some amount of CSF from here. And we find it extremely useful in collapsing the dural sac. Then the peeling starts, continues posteriorly. You can see that the Michel's cave is full of tumor. Otherwise, this is a point through which we can release some amount of CSF. So here the tumor is going to the posterior fossa. Some amount of petrous erosion is there, but it is still not enough. We need more space. So what we do here is we do some drilling at this point, but you will see that this drilling was not enough and we had to drill more later. So once this petrosectomy is done, so the dura is open now and the tent is open behind the fourth cranial nerve. Here is the fourth cranial nerve. The tentorium is stacked up and we have the tumor out here. The tumor is exposed. Temporal lobe is entirely covered by the dura because I have opened the dura in the, along the skull base. The rest of the principles are same. The base of the tumor is coagulated and it is divided. This is the area of the suprapetrosal sinus and the posterior cranial fossa out here. So you see now the rest of the petrous bone is being removed now. Now removal of this bone gives us control on the lateral aspect of the posterior fossa portion. Without removal of this, a tumor like meningioma, which has a broad dural base, cannot be removed. After that, the middle and the posterior fossa are connected by suprapetrosal sinus division. Now we have the tumor in front of us, the fourth cranial nerve, and the middle and the posterior cranial fossa are all connected. Now all you have to do is reduce the bulk of the tumor. Make sure that you work on either side of the fourth cranial nerve. Now the Michel's cave is being opened and the tumor from the Michel's cave is removed. So we have seen that sometimes meningiomas would extend into the Michel's cave, and it is very important to liberate it from here. Otherwise, it will be a source of recurrence. Now you see that the posterior fossa part of the tumor is being delivered into the cavity. We have the fifth cranial nerve, which, as Professor Goel showed in the morning, like fifth nerve schwannoma, they are draped laterally. But nevertheless, you have to bring it into the field. Now we're on the anterior side. This is the third cranial nerve. So an extended exposure gave us a wide view. So we can see the posterior cerebral artery. The plane between the tumor and the third nerve was divided sharply. And as the tumor was already debulked, all you had to do is apply some traction with counter traction. This is the area of the oculomotor trigone. And we have started seeing the brainstem over here. Now this is the fourth cranial nerve. The fourth cranial nerve is mobilized right up to its brainstem area. And it is liberated and pushed aside. And the rest of the tumor is delivered into the capacious field that we have created here. Simultaneous debulking and dissection is necessary. And you have to be mindful not to pull the tumor too much. This is the area of the fifth nerve. We see there is some adherence of the tumor here. So we use some sharp dissection. This is the fourth cranial nerve. This is where the tumor was actually adherent. We reduce the size of the tumor here. And as you do that, the brainstem is exposed. Some amount of tumor is densely adhered here. So we decided to leave that small bit of tumor over the brainstem. We coagulate the dural attachment, cut off the remaining exophytic component. And as you take this tumor off, you can see the basilar artery here, the basilar perforators, and the basilar is bifurcating into two PCAs. Beautiful view you can have. And no wonder some of the basilatum aneurysms can be dealt with this approach. The major bulk of the tumor is out. Small bit of tumor was left over here. Whatever basilar junction is seen, and we close that whatever dura is possible, and we put a piece of fat that we obtained from the skin incision. Post-op scan, the patient is doing well at 6 weeks follow-up. What I want to show you is, this is where the fat was placed. So as you can see, our petrosectomy was right up to the 7th cranial nerve here. So this amount of exposure gave us the maximum chance of taking this tumor out. What are the other indications of this? Some tumors will require corridor expansion and a simultaneous vascular control. Let's see one of those. This was the case of acromegaly, recurrent, following endonasal surgery. So we open the optic nerve sheath here, release the CSF, keep on dissecting, peeling posteriorly. This is the area of the Mickel cave. And by continuing this dissection posteriorly, we expose the area of the petrous apex. Now, what I want to show you here is a different angle. This is what was the Cavernous rhomboid. Now I want to show you the importance of Glascock's triangle. This is where the petrous carotid would be lying. So to be able to control the petrous carotid, you have to first divide the GSPN, because it is in this groove that the petrous carotid is. You have to be mindful that sometimes there would be deficiency of bone over here and the carotid could be right beneath it. So this is where you need to work now. This is where you worked in the earlier case. So by cautious drilling, you expose the petrous carotid over here. Now, why do we do this? It is being done because if there is an intraoperative injury inside the cavernous sinus, we have immediate control here. And this can be also used for a short segment bypass. Now, once this was done, we shifted our attention to a couple of minutes maybe to the cavernous sinus portion. The V1, V2, V3 are pushed below. This is the V1. And this is the fourth cranial nerve. I have learned from Professor Ali Christ that the fourth nerve can be identified by its oblique course. So this is the fourth cranial nerve. So we liberate the fourth cranial nerve on either side. And we utilize both the infra and the supratrochlear triangles. It is not always that you utilize the infratrochlear triangle. It depends on case. So you enter into the cavernous sinus by utilizing one of these triangles. And we can see the sixth nerve inside. So petrous carotid control was taken because we thought that there could be some inadvertent injury. So here is the fourth nerve, here is the third nerve. So you work between these nerves, supra as well as infratrochlear, and you take this tumor out. But as you saw in the scan, there was some amount of tumor which was still intradural. So this is our strategy of dural opening, a T shape. In the basal side, we go anteriorly and posteriorly. So as you see, this kind of dural opening limits the amount of brain that is exposed. The distal dural ring is opened. And when you open the falciform ligament and the distal dural ring, the carotid optic space expands. So you can take out the tumor from the carotid optic space, which is expanded by this maneuver. We can see some amount of fat left from the first surgery. So we took out whatever tumor was possible for us and left the rest of it to be taken care of by gamma knife. So this is another advantage. So to conclude, even in the era of minimally invasive endoscopic surgery, these classical skull-base approaches, they do have a role. They provide extensive exposure, better neurovascular control, and in extensive lesions of the central or the upper posterior fossa skull base, this can be really helpful. Thank you.
Thank you, sir. Now, may I please call upon Professor B.K. Mishra, Professor Ashish Suri
Professor Manjul Tripathi and Professor Kuntal Kantidas to take part in the panel discussion, with Professor Atul Goyal to moderate.
I think you have heard enough, seen enough, and learned enough. So what I will like to talk few sentences about what I have learned in my 40 years of skull-based surgery. There are two beautiful articles written by me which I would like you to see. One is, once an acoustic, always an acoustic. Once a meningioma, always a meningioma. This is in reference to what Manjul said, that even if you remove the acoustic completely, you can never say it will never recover. It has great implication. You see, you know what? Sometimes people say, okay, there is small tumor stuck to the facial nerve. Let me cut the facial nerve so that at least I can cure the person. So there is no question of curing an acoustic. Once an acoustic, always an acoustic. You cannot just say, I have removed grade Simpson grade 0 or grade 1 and I have cured. Don't ever use the word cure for benign tumors. Of course, never for malignant tumors. So this is one thing. So this gives us lessons, and this has given me lessons. After having done several and all my life in acoustic tumor, all my life in pictoclival tumors, I have come to very important conclusions. One is, having a damaged face is absolutely a disaster for the that you must realize. You just cannot ignore it. As I have said in many of my meetings and my lectures on acoustic, that in my own career of acoustic, in my own career of damaging facial nerve, I have got one divorce, one suicide, and one murder following facial nerve palsy. Also I have said, when my daughter was about 6 months old, she was watching the mirror. And I was, amazed at this 6-month-old girl watching her face. Imagine the whole life you watch your face and you have a damaged face, which is not just ordinarily damaged, it is massively damaged face. So we must remember, and over the years, what I have done with my facial nerve, with my acoustic is, I have stopped teasing the facial nerve from the tumor cuts, which I have shown in several meetings. See how I tease the facial nerve. See how I do the facial nerve dissection. I have stopped this maneuver. I never tease the facial. Of course, in small tumors, it is much more. I'm talking of relatively big tumors. So when you have a big tumor or a relatively big tumor, my advice to you is, don't try to showcase your dissection. Leave tumor behind. Don't try to tease the facial nerve. This is my suggestion. You want to follow, you follow. You don't want to follow, that is on you. If you think that you can tease the facial nerve and save the facial nerve function, you may be able to. I have been able to do in several cases, but the cases which I have demolished, I know what I have done to the patient. So this is lesson number 1. Because you cannot cure the person, even if you remove the tumor completely, it is better off to leave some tumor behind on the facial nerve, not in 1% of case, not in 10% of case, at least 70-80% of case, leave some tumor behind. This is my suggestion to you. Second thing is, what I love dissection of whatever was shown in my own career. And if you have read my papers, you see, whenever I used to operate on pictoclival tumor, the drill used to come in picture. Extensive pictosectomy was in picture. And you must have read my papers. Those who have, Ashish always wing Dolan's Kowasi never refers my material. But you must, Ashish, if you have seen, I have done one technique which I used to do, cut GSPN, mobilize tympanic and labyrinthine segment like this, mobilize the carotid artery anteriorly, mobilize the gastrian ganglion up, and have a very beautiful extended exposure, which I used to do, and I have published this extended middle fossa approach. So I used to do anterior craniotomy was always in my operational schedule. But over the years, what I have done is my vitrectomy has dramatically reduced. My anterior craniotomy has quite significantly reduced. So my bone work has reduced. My the speed of operation has dramatically increased. On the other hand, Ashish, I will also tell you, I saw your beautiful, one thing, Ashish, you must remember, I love you and you are my favorite. As you know, and you have copied me. You can see you copied me back. See, you know what, this dissection of cranial nerves off the tube. You showed a beautiful dissection where you said that I took quite a bit of time to dissect the sixth nerve of the meningeum. Sixth nerve, you were showing whatever you were showing. My suggestion to you is, if you need half an hour or 1 hour, or you said 2 hours to dissect the nerve from the tumor, you don't do it. Because you damage little bit of sixth nerve, you damage the eye movement, you have damaged one full eye of the patient. So my dissection will be now, after 40 years of my skull base. Whenever I'm dissecting around the sixth nerve, wherever I'm dissecting around the seventh nerve, if the dissection is becoming difficult, I leave. Whenever I dissect around the perforators, if there is a perforator and I need 20 minutes to dissect off the perforator, I will say, don't do it, Atul Kumar, don't do it. I leave some tumor behind. Because you know what, you do beautiful operation, you damage one perforator and you have killed the person. And don't try your skills beyond your skills. Don't do anything to showcase your material. Now you know what is happening is endoscope. I see endoscopic surgeon showing, you see what I am showing you, what I am showing you. You see, you should do what is necessary. You should not do something that you should not say, I can do it, see what I can do it. Sometimes even petroclival meningiomas, what nonsense I have seen a petroclival meningioma being done by the nose. I have seen greatest nonsense by seeing foramen magnum meningiomas from the nose. I have seen tuberculum celli. I will say, unbelievable for me. Tuberculum celli, you want to go from the nose. You will say, my indication is midline. My indication is around the optic nerve. These are nonsense. According to me, you should do what is good for the patient. And you should not do what you should not say, I can do it. You see what I can do it. You should say what is necessary and good for the patient should be done. And the other thing is, which I am really, Manjul is a fantastic, where is Manjul? Manjul, my dear Manjul. Now Manjul, you tell me. You gave me a beautiful demonstration of what gamma knife can do, and I do not respect you, I love you. If you say I respect you, means that will be too much. You know what? Now I have said just now to you, once a meningioma, always also meningioma. You showed one beautiful slide where you showed that tumor was completely removed and still the tumor recurred. So you got the message. Next time you'll refer my paper. Once an acoustic, always an acoustic. Once a meningioma. Now the issue is, I have said now to you that I leave some tumor behind. And sometimes, believe me on this, you see, nowadays what I'm doing is I'm operating very high profile people. Because, my KM, my property of KM is now out of my hand. So now my property is high profile actors and all, you can not even imagine. And if I damage the facial nerve, I will not be able to stand here. So my concepts of surgery have changed because of my profile of patients also. Now I'm saying, but this is not related to any profile. I am saying, don't dissect, don't tease the facial nerve of the tumor. And if you are doing it, this is nonsense after having done 1,400 acoustics. Now I'm leaving some tumor behind. You said that you can observe this patient. And sometimes I leave a significant chunk of tumor behind to save the patient. You are saying that you can observe this patient. And if it grows, then it comes to you. Now, if it grows dramatically and if it comes into the surgical range, I will say I will still like to operate and leave some chink behind. If I have to operate a cystic tumor, you say cystic tumor, I showed a cystic tumor and it has reduced, but cystic tumor is also quite an easy surgical operation. You remove the cyst and remove the debulk the tumor, and cystic tumor, as we all know, facial nerve can be difficult to dissect. You leave the shed. You leave the shed. What you showed from gamma knife and post gamma knife was a good result, but that can be achieved very easily by operation. My feeling is gamma knife is a very useful tool, because if your knife works, let the knife work, and if the knife stops, let the gamma knife come in picture. Do you agree with that? As long as the knife works, use it. Now, if the tumor recurs, if you think my knife can work, use the knife. And and pray to God for let it recur. So as long as you can use your knife, you keep the gamma knife at the backyard. Do you agree with that? Wait. The thing is, you know what, in neurosurgery, I have realized over the years that neurosurgery is not easy, my dear friends. One is you have to do extensive dissections to learn the anatomy. Second thing is, and as Ashish, spend time in the operation theater. Just love the operation theater, spend time, see the operation, do the operation. That will make you what you will eventually. The most important thing in our life is, for which we live and what we aspire to deliver, is our patients. Don't try to show your skills with the patients, okay? Don't try to show your mastery with the patient. I have realized over the years, if you have seen me here, heard me 20 years ago, or 25 years or 30 years ago, I was showing dissection after dissection after dissection, pre-op. This is my pre-op, post-op, pre-op. There is a neurosurgeon, Bao, Shengdai Bao. Ashish must be knowing in China, very senior neurosurgeon. He called me Buddha. I said, why you are calling me Buddha? He said, your lecture are pre-op, post-op, pre-op, post-op, pre-op, post-op, pre-op, post-op, like a Buddha. But now what I would like to showcase is, of course, I would like to be aggressive neurosurgeon. If you're conservative neurosurgeon, I'd say I am conservative, I leave tumor behind because I want to save the facial nerve. You will leave 80% of tumor behind. You cannot be a conservative neurosurgeon. You have to be an aggressive neurosurgeon. But aggression does not mean you have not used your brain. You have not used your philosophy. You have not used your concept. You want to showcase your technique and skill. Please don't do that. My best wishes to you. Enjoy this subject. And there is no question answered, but I will respect my dear Manjul, who was continuously standing up and down. Okay, Manjul. Beautiful sentence he used, remember. He used a beautiful sentence. Whether the surgeon is nerve-centric or tumor-centric. My dear Manjul, this is the greatest sentence you have used. And I will give you an answer for that. You should be nerve-centric, my dear. And the people who are tumor-centric are showcasing their work. Don't showcase, not showcase, focus. This is historical perspectives of neurosurgery. The other thing is that, and you must know what I mean to say, if the tumor has recurred and it has come to me, and I have a feeling that I can do a reasonable job without a complication, that is on me. I will operate. But I think if I'm not able to do a reasonable job, there is a potential for complication, potential for dangerous. Manjul will be my friend. Ashish, what you have to say? Give some beautiful sentence. What is excellent? Thank you very much. So that is the end of the day.
Atul, hello, can you hear me?
Thank you, sir. That was a very interesting way to conclude the session on lateral skull-based tumors. Next up, we have the session, the final session of the day of posterior skull-base and foramen magnum tumors. Just before we begin this session, I humbly request everyone to stick to their allotted time as we're running very late of the schedule. Thanks.
Let's come to the last anatomical session of the posterior skull base and the foramen magnum. Since we have seen much of the posterior skull base, I'll start with the posterior view and the foramen magnum. So this zone here, the craniovertebral junction, as we all know, is a transition zone between the cranial cavity and the spinal cavity. And it is also the zone of stability and mobility. It holds the head on your shoulders, and a lot of important neurovascular structures actually traverse this foramen magnum region. So this is the osseous anatomy. This is the osseous anatomy and a view from the superior surface. This is the foramen magnum. As you can see, it is made up of, the anterior rim is made up of the clival bone, the occipital condyle, and this is the squamous part of the occipital bone, which continues posteriorly. This is the view showing the whole foramen magnum rim. I will quickly go through this. Again, another view showing the foramen magnum rim. And this is the view from the posterior aspect. Here you see the occipital condyles. You see the anterior posterior diameter of the foramen magnum is more than the transverse foramen. And here you see the squamous part of the occipital bone going on to complete the foramen magnum rim. And this is the clival portion. These are the other two bones important in this region. This is the axis. This is the atlas. The atlas and axis are both atypical vertebrae. Here you see that there is no body. There is no spinous process. There is an anterior and a posterior tubercle. And this, of course, is the magnificent bone, the odontoid process. Again, another atypical vertebra where you see the superior and the inferior facets are not in one line as they are in the rest of the spine, but there is a region of bone beneath that. And the vertebral artery actually goes into the region of the superior facet and grooves it and forms an important anatomical relation. So quickly, we will go through this midline suboccipital approach to the foramen magnum. So you see, this is the craniovertebral junction. These muscles, we actually, when we do a midline approach, we just perform an incision in this avascular plane, but it is important to know these layers. So the first layer is made up of the sternocleidomastoid and the trapezius muscle, as you can see here. Once you retract that, you will see the semispinalis capitis. Once you retract that, you will see the splenius capitis as it is running. So this is the first group of muscles that you will see. More deep here, you have the more important region, that is the suboccipital triangle, and we'll see the muscles in this region. So this one here is the superior oblique. This one here is the inferior oblique. This is the rectus capitis posterior major, and this is the rectus capitis posterior minor. So this region here is the suboccipital triangle, and the contents of this triangle is there is a membrane, that is the posterior atlantoaxial membrane, which is removed here. And then you have the vertebral artery with this venous plexus and the C1 nerve root as they traverse on a groove on the arch of the atlas posteriorly. So this is a closer view showing this region. Here you see the muscles, the superior oblique, the inferior oblique, the rectus capitis posterior major, the minor, and here the vertebral artery as it is going on the arch of the atlas, and then it will turn here and go medial to the occipital condyle. Now you can see it here very nicely. All the muscles have been removed, and you see the occipital artery going here medial to the occipital condyle joint and going and entering into the intracranial cavity. This is the bone work that has been done to expose the posterior cranial fossa and the foramen magnum rim. More inferiorly, you see the axis. Here you see the C2 nerve root, and let's go more inside now. So now the dura is being opened, the foramen magnum rim, the last portion of it is present here, which will then be removed. And here you will now enter into the intracranial cavity. Once you lift the cerebellum and you enter this cerebellomedullary fissure, you see these important structures here. These are the lower cranial nerves. You see this nerve that is coming from down up, that is the spinal part that is going into the jugular foramen here, joining the cranial part of the accessory and entering the jugular foramen. There, more anteriorly is the 7th, 8th nerve complex. Here you see the vertebral artery as it is entering here medial to the occipito-atlantal joint. Here you see the groove on the arch of the atlas where this artery is lying. More inferiorly, you see the C2 nerve root and going here and forming the C2 ganglion, whose anatomy is also very important, as I will show now. Here you see the vertebral artery as it is going up from the C2 and going into the C1 region. So the region where you say the medulla ends and the spinal cord begins is this region where the C1 nerve root actually exits the spinal cord. And this is the transition zone between the medulla and the spinal cord. So this is a closer view where you can see the lower cranial nerves, the spinal part of the accessory coming up. This is the 7th, 8th complex. And now you see this vertebral artery going in the intracranial compartment. Now more of the bone has been removed and you can see the structures more clearly. So you see this vertebral artery here, as it comes out from the C2, it goes laterally and then curves above and goes on the arch of the atlas and then enters here intracranially. This is the sigmoid sinus, and here you see the medulla. Here more bone has been removed now, and you see these nerves that are coming down are actually the extracranial course of the lower cranial nerves, as we will see in the next image. Now all the bones have been removed and you see these structures. So this nerve here is the hypoglossal nerve. This one here is the accessory. Here you see the spinal part of the accessory coming, the cranial part of the accessory coming, and then this nerve going down. This is the 9th cranial nerve as it is coming down here and going laterally to enter the neck. So now I cannot complete the craniovertebral junction without addressing this region. And you see this is the C2 bone, the C2 spinous process, and this is the C2 ganglion as it is coming out from the spinal cord. And as Professor Goel has described, this C2 ganglion, transecting this C2 ganglion, gives a window into the atlantoaxial joint, which you can see here. And someone recently referred to this as Dr. Goel's joint, and I fully agree with this. This is the C1, C2 joint and the atlantoaxial region. And the C2, removing the C2 ganglion actually gives you a complete access to the C1, C2 joint. And it is very important to understand this anatomy of this joint for operating in the craniovertebral region. Now we are looking at it from a lateral perspective. So these muscles have been reflected. Again, you see the C2 nerve, you see the vertebral artery. This, as Shukdeep showed earlier, this is the occipital artery. And this is the lateral view to the foramen magnum. Once you remove the bones, this is what you see from the lateral aspect, the cerebellum, the spinal cord going. You see the C2 nerve roots coming here and forming the C2 ganglion. The vertebral artery as in its course as it is entering into the intracranial cavity. And here this is the pica actually having a very low origin and going all the way up into the cerebellomedullary fissure. Here you can see where the pica is originating. So this region, this C1 nerve root where it comes out is where the medulla becomes the spinal cord. And this is the region of the 4th ventricle. Both the picas are going in this region. So now this is a view from the top. Here you see these are the lower cranial nerves. These nerve roots which are arising more medially are the nerve roots of the hypoglossal nerve. This is the vertebral artery going up. This is and forming the basilar artery. This is the ICA, and then more superiorly you have the superior cerebellar artery. Here again there is a view showing the hypoglossal nerve rootlets as they originate from the medulla and entering into the hypoglossal canal here more medially. These are the lower cranial nerves as we have already seen before. So now again, just a quick view of this anatomy. So you see now this is the 4th ventricle. This is the choroid plexus in this region. This is the vertebral artery as it is going up into the anterior part and forming the basilar artery. I will go quickly now. Now we have just removed this whole 4th ventricular floor and you see this, both the vertebrae joining and forming the basilar, and here you see this vessel. This is the anterior spinal artery as it is running down in the ventral median fissure of the spinal cord and going all the way down. These cranial nerves we've already seen nicely. Also just see here these venous plexuses that come in the way when you're operating in this region. This is the extradural venous plexus and the venous plexus around the vertebral artery. This will cause, venous bleeding when you're operating in this region. Going to the little bit on an intraaxial part, when you remove this, when you actually go into the 4th ventricle, and this is the structure that actually causes the cerebellar mutism and the structure that you're supposed to be aware of. This is the dentate nucleus. It lies at the junction of the lateral part of the fourth ventricle and where the inferior cerebellar peduncle enters into the cerebellum. This is where the dentate nucleus remains and then goes on to form the dentatorubro-thalamic tract. This is the floor of the fourth ventricle. This is the facial colliculus, the facial nerve. This is the median sulcus. This is the sulcus limitans. Here you can see the locus ceruleus. Here in this region, you will have the trigeminal lemnisci, the medial lemnisci, and the spinal lemniscus as they're going up. This is the superior cerebellar peduncle that has been cut. This is the middle cerebellar peduncle. And this structure here is the inferior cerebellar peduncle. On this side, the ependyma of the fourth ventricular has been preserved. And going down here, this is the hypoglossal triangle. This is the vagal triangle. This is the calamus cryptarius, and you can see the pigmented color here. These are the acoustic striae or the stria medullaris as they are entering into the cochlear nuclei more laterally here. And this is again an overview of the vascular supply and the anterior spinal artery as it is entering down. Now, quickly, we have seen the foramen magnum, quickly the posterior cranial fossa. So there are a lot of nerves come in this region and there are a lot of vascular supply. So as Roton has described it, you can understand the posterior fossa by dividing them into three groups. That's supplied by the SCA, that's supplied by the ICA and the PICA. The brainstem, midbrain will be supplied by the SCA, the pons by the ICA and the medulla by the PICA. There are three peduncles, the superior, middle, and inferior cerebellar peduncles. There are three fissures, the cerebellomesencephalic, the cerebellopontine, and the cerebellomedullary fissure. There are three cerebellar surfaces, the tentorial surface, the petrosal surface, and the suboccipital surface, and the cranial nerves that lie in relation to the brainstem in this region. So this is looking from the front. Here you see the various nerves. So this part is the upper group, this part is the middle group, and this part is the lower group. The upper group will have the fifth cranial nerve, the middle group will have the seventh, eighth complex, and the sixth cranial nerve, and the lower group will have the hypoglossal and the lower cranial nerve complex. Here you see the superior cerebellar artery, the ICA, and here you will have the PICA. So this is the upper group as I just showed you. So this is the superior surface of the cerebellum or the tentorial surface. I've already shown you this image earlier. This is the cerebellomesencephalic fissure. You see the superior cerebellar artery as it is running between the third and the fourth cranial nerve, dividing into two parts, the superior and the inferior division, and going on superiorly to supply the colliculus and also to supply the dentate nucleus. The dentate nucleus supply comes from the superior cerebellar artery. And here you can see one of its branches going on to supply the dentate nucleus. This is the superior medullary velum on the superior surface. The middle group, the CP angle, we are all very familiar with. I will rush through this part. Here you can see the flocculonodular lobe of the cerebellum, the seventh, eighth complex, and the sixth cranial nerve as it is coming here. And you see this is the ICA as it is running here. The ICA has a very, intimate course with the seventh, eighth nerve complex, and it gives us the labyrinthine artery, which goes on to supply the labyrinth and the subarcuate artery, which supplies the dura in this region. This is the identifying mark for the facial nerve. This is the choroid plexus, which comes out from the foramen of Druschka. And here you see the lower cranial nerves. And the lower group is the PICA and the medulla, which you will see best from this. So the suboccipital surface of the cerebellum. This is the midline. And here you see the cerebellomesencephalic fissure. And as the PICA is forming all its loops and entering into this region, this is the region of the fourth ventricle. Once you retract the uvula, you will see the fourth ventricle. This is the inferior medullary velum, and in the midline you have the tonsil, and these are the loops of the PICA which cannot be damaged when you're doing a posterior fossa surgery. So this is the region of the foramen magnum, and for the short of time I'll stop here. Before I end, I would all like to invite you in August for our meeting, which is going to be held from 2nd to 6th August, and anyone who's interested, kindly let me know after this. Thank you very much.
Thank you, ma'am. Now I'd like to call upon Professor Siddhartha Ghosh to deliver a talk on the combined microscopic and endoscopic approach for Chordoma.
To present one very interesting case because these patients came from Saudi Arabia and he was related to the the king of Saudi Arabia, and then she was operated initially there, where there was partial excision done, and followed by the patient came here basically for proton therapy. But when we did the imaging, we found there is a very large tumor still there. So the question came to me whether the tumor can be excised totally so that the proton therapy can be useful. Now, to one thing, for proton therapy, it's very important that they actually need at least 2 millimeter free of the brainstem for the proton therapy to be effective and not to have any adverse effect on the brainstem. So it's very important to remove the tumor in that part of the brainstem to have a complete clearance. So just a brief introduction about 2021 WHO classification of chordoma, the usual conventional variety, the chondroid variety, and dedifferentiated variety, and poorly differentiated variety. So these are the 4 types. And the proton therapy is definitely the most useful for chordoma, especially after the excision, because but it needs a very high dose, 70 to 74 Gray is recommended for skull-based chordomas. And overall survival is 3 years is 89% in proton therapy as compared to 70% in other photon therapy. And 5-year survival is 78% as compared to 46% for other one. And 10 years is 60% versus 21%. So this is the lady I was talking about. Do you have that? So this is a lady with a 36-year-old lady who came from Saudi Arabia, who was, this is the presenting symptoms. Now, if you look at this, this is a very large tumor, which is occupying almost all of the clivus and mostly on the right side, as well as the left side, occupying the cerebellomedullary cistern, gone into the CV junction, and gone into the up to C1, C2. Now, she was already operated. They have done a biopsy initially, which was negative. Then second biopsy was done, which was second biopsy was came as a clival chordoma. She already had a lower cranial nerve palsy. She had a 7th nerve. After the surgery, she developed a gross 7th nerve palsy. So she was tracheotomized, and then a peg tube insertion was also done. So this is the stage she came to us. So as you see that she had the cranial nerves right from the lower cranium, right from lower motor 7th, 9th, 10th, 11th, as well as 12th. She has a gross deviation of the tongue. Now, this is the tumor, as you are seeing, occupying the most of the, in chordoma, the most important thing is T2 hyperintense signal. That is the very important, the fat suppression technique, where it gives much better delineation than even the contrast MRI. So this is the tumor which is occupying the whole of the clivus with extension to the premedullary, right cerebellomedullary cistern, right side of the upper cervical spinal cord, and significant compression on the medulla, C1, C2 spinal cord. And the lesions in also seeing the encasing the V4 segment of the vertebral artery and invades the right sigmoid sinus as well. So I planned for the surgery in 2 stages. The first one, actually, the first case, I didn't have the first part of the surgery. It was not recorded. So I just extrapolated by another patients, which I have taken for the first part of the tumor. But unfortunately, it's on the left side. This tumor is on the right side. But just for have the orientations, I'll just show the first one. So you have the curvilinear incisions, and you have to do, I planned for an infratemporal fossa approach and far lateral approach combined. So you do this part as a what is called the blind sac closure of the external artery meatus. And after that, you do a subtotal petrosectomy. So this is what you can see, the subtotal petrosectomy being done. The patients already had a compromised hearing loss. So the labyrinth was sacrificed and the subtotal petrosectomy was done. So at this point, I'll go to the actual tumor. So this is the one where the tumor was seen it was right now what you see is in the middle fossa. That was the tumor which was taken out, and the part of the petrosectomy is completed here. And this is the facial nerve. The facial nerve was already involved by the tumor, but even then the rerouting of the facial was was done just to have not to give further damage to the facial nerve and to get a full access of the petrous bone. So here the rest of the petrous bone is being drilled here. And as you see, the petrous bone is being drilled here. Do a complete like posterior part of the, actually the posterior petrosectomy. And this is the part where in the, near the CV junction, it was already the C0, C1 junction was already destroyed, so which I took it out, and the tumor was taken out from there. So this is the tumor part which has been taken out from the CV junction as well as from the lower part of the spinal canal. You can see the vertebral artery here. So this part, there was a large part of the tumor was there, which I took it out from the by the far lateral approach. Now after that, so then we did immediately, as you know, if you have to see how much is the residual tumor, you have to do the MRI within 48 hours. So we did the MRI. As you see, the tumor, quite a bit of tumor has been removed, but still there is a tumor here in the cerebellomedullary cistern and part of in the middle part of the clivus. The center part of the clivus is still there. So this is the part which I thought I'll go through the transphenoidal through the endoscopic approach. So this is the morphology of the tumor. So the first part was done by my ENT colleague. It did an extensive dissection of the clivus because here we needed a Haddad flap. So this is the clivus is being dissected, including the upper part of the CV junction also. And after he drilled it, I took over and removed the tumor. It's still being done. And now the tumor is being removed from the rest of the clival part of the tumor. So the center part of the tumor and the tumor below CV junction up to C1, C2 was taken out by that. I thought the tumor must have been completely removed. But to my surprise, when I did the MRI again, because my challenge was there, I have to remove the tumor completely. I saw there is a small tumor still in the cerebellomedullary cistern here. So my Dr. Adityan, who just gave the talk, he told me, sir, there is a small tumor still there. And if this tumor is very important, because if this tumor is not removed, then the proton therapy will not be fully successful because that part of the tumor might cause the damage to the medulla. So I took her up again, and this one I just did opened up the same area and cleared that area, and then dissected that area again. And then opened the dura, the pre-sigmoid dura there in the cerebellomedullary cistern, as you will see now. As I am dissecting the previous plane, now opening, that's the pre-sigmoid part near the cerebellomedullary area. And so once I reach there, I open the dura there. Got the CSF. Here the navigation definitely helps. So I just removed the rest of the tumor from the cerebellomedullary cistern. As you can see, this is the part of the tumor, small tumor, which was left behind. So it's always important to have a, immediate MRI, which will give you a very clear idea whether you have done a complete excision or not. For this case, it matters. So when so rest of the tumor being taken off. So for the radiation oncologist, you have to keep a fat there to keep that area, so that this fat prevents it from the, when they give the proton therapy, it just prevents to have any dissemination into the radiation into the medulla. So you keep a piece of fat there in the cerebellomedullary cistern, and then close it. So the wound has been closed. Now this is the, you see the MRI after the first surgery, the second surgery. By the arrow, you can see after the first surgery, this part of the tumor was left. After the second surgery, you can see that small part there. It's been there. And after the third surgery, that the whole thing has been removed. So this tumor was excised completely, and she tolerated the surgery well, and she completed the proton therapy, received about 70.4 Gray and 32 fractions to the skull base. And she came for a follow-up in February. I did it in December. She came back in February, and which shows the total excision of the tumor. And this is her follow-up. She's okay without any more deficits. She already had a 7th nerve. She already had a 9th and 10th, but with 9th and 10th, she was compensated, but she started eating without our knowledge. We found that she was sitting in the nurse's chamber and she was having some biscuit. So she herself was, started eating herself. So I have this small series of about chordoma from 2014 to 23. I have 6 clivus chordomas, 3 sacral chordoma, C2, C3 chordoma 2, and 1 chondroid chordoma of the sella and suprasellar region, and 3 chondrosarcoma. So the literature says that outcome, overall survival for 5 years, for this is a literature with a 20 years experience and systemic literature review, says that overall survival 5 years is 70.6%, 10 years is 49.9%, and 20 years is 16% following complete excision of the chordoma. And progression, I just take half a minute. And progression-free survival is 37.2, 5 years, and 26.6, 10 years survival. So the most important things are significant improvement overall survival observed in younger patients, median overall survival of 18 years in patients younger than 50 years versus 5.54 years in those who are older than 50 years. And Ki-67 index is very important. If the Ki-67 index is less than 0.5%, then the overall survival increases to 18 years, as well as if it is less than, if it is more than 50%, then the overall survival steadily declines. And number of surgeries are also very important. So up to 2 surgery, median progressive survival 5 years is up to 2 surgeries versus 2 years in more than 2 surgeries. So number of surgeries are very important. So we should attempt to have the radical excision in the first attempt itself. Okay, with that I'll conclude. Thank you very much.
Thank you, sir. Next up, may I please call upon Professor Rajneesh Kachra to deliver a talk on microsurgical excision of chordoma. Thank you.
Once again, thank you very much, Professor Ghosh and team for the invitation and presence in this meeting. My topic given was microsurgical excision of clival chordoma, and at the outset, I must apologize, but apologize that my cases, whatever has been done, are long time back, and whatever available approaches, and the follow-up is not that much adequate. So I will show you whatever cases we have done that time with the available technology. So chordoma as such is a very rare bone tumor and originates from the primitive notochord, usually midline extradural, very, very aggressive tumors. As you have seen from Professor Ghosh, they are locally invasive tumor. And the extent of resection is the most important factor for the long-term survival. So the aggressive surgical approach to attempt and radical resection and adjuvant RT is recommended. So it occurs in the midline skull base and it can extend to various regions like paracellular, prepontine, middle fossa, nasopharynx, and postcranial fossa. There are many management challenges, slow growing, but it is very aggressive, infiltrative tumor, invasive, and it is in vicinity to very important neurovascular structures, brainstem, cranial nerves. There is a usually bone involvement, and whatever aggressive surgical approaches, always there are associated surgery-related morbidity, and there is a higher recurrence rate. So the treatment strategy has to be a complete resection whenever possible, and adjuvant radiotherapy for the remnant tumor. Aggressive microsurgical resection of the chordoma can be followed by long-term tumor-free survival. And more aggressive, more conservative approach you have to keep in a recurrent tumor reoperation cases, or particularly patient has received a radiotherapy. This is one article from still also this is from 2011 from Dr. Shekhar, and he has given a prognosis about these tumors. The five-year progression-free survival in complete resection is about 87%, in incomplete about 50%, and overall survival about 95% for the complete resection. So the resection has to be complete. And at that time, he has given that there is no significant difference in 5-year progression-free survival or overall survival between the various type of radiation treatment. This is our own series from India. Dr. Bishra has published about 41 cases of skull-base chordoma from 2001 to 17. And in his series, about 5-year and 10-year survival, about 73 and 49%.
So these are the major prognostic factors: surgical resection, the radiotherapy. So the choice of surgical approach depends on the location of the tumor, surgeon's philosophy, and his familiarity about this particular approach, and patient's clinical status. So I won't go into the various approaches. There are many approaches, and whatever approaches we have done some cases, I will show you. So this is one approach we have liked very much, and it gives a very wide exposure to excise the tumor, this kind of tumor. This is extended frontobasal approach, and it gives, these are the areas you can access. And this is the diagram which I have made myself. Understanding this approach is the frontobasal, you remove this part of the craniotomy and then osteotomy, and you can access right from the you drill the ACF floor, you can access the sphenoid sinus up to the lower clivus and the paranasal sinus up to 3 centimeter wide exposure you can get from this approach. So these are the advantages of this approach, and these are some of the examples we have operated by this approach. And this tumor, huge tumor, extending anteriorly into the paranasal sinuses, and it was excised completely. But a year later, patient had a recurrence of this tumor, and we operated again with the same approach. Another tumor, again, it is extending anteriorly into the paranasal sinuses, and probably today, maybe endoscopic surgeons will operate with the endoscopy, but we have done with this approach. And this is the post-operative CT scan, shows almost complete excision. This is the fat graft which we have kept here in the tumor space. This was one of the case we couldn't remove this tumor completely. And this is one patient initially operated by Dr. B.K. Mishra in 1994. Then again, we don't have a very good pictures. This is and very limited amount of pictures available. And this is recurred in 2001. And then I had operated very extensive clavicle chordoma right from, and there is an intradural extension also. Another simple approach which we have used in some of the cases is for exactly a midline tumors, very simple and direct view it gives. This is one tumor which is just confined in the midline, and but very large tumor. And this is a post-operative CT scan shows a complete excision of the tumor. You can achieve sometime with this approach. But now, of course, it can be done with the endoscopy also. Now, coming to some lateral approaches, this is one tumor, very extensive, a lot of destruction of the bone, and we have approached this with the extended middle fossa approach. And this is post-operative CT scan, shows near total excision. Another case, this case I had operated very recently, last month only, and patient has presented with the minimal headache and 6-nerve palsy. Very small tumor in relation to the clivus and the petrous apex. And a small video I will show you. So this is totally extradural, and this is petrous apex, and this is the glycerol ganglion. We just lifted up and then removed this tumor. There was a lot of extradural bleeding, and sometimes you face with a lot of extradural bleeding in this approach. So post-operative CT MRI also we couldn't do. He hasn't come yet for the further follow-up. So we are just awaiting this post-operative MRI, and then if any residual tumor is there, we'll subject him for some adjuvant kind of treatment. So this is how this approach works well for this kind of clavicle chordoma. Another, this lesion, we have operated long back. I think this was operated in 1997 or 98 with the middle fossa approach extradurally. And this was the residual tumor which remained, and we subjected him for the kind of adjuvant treatment. This patient I had operated in, I think, 2008. But I couldn't remove a very significant part of the tumor, though it was a very small tumor, and this remained a significant residual. And this patient was subjected for the gamma knife, and he tolerated gamma knife very well and remained for so many years disease free. So coming to transpetrosal approach, this is one tumor we had operated by posterior petrosal retrolab approach, and we could excise this tumor. And this was operated, I think, in 1998. And then again, patient has come with a recurrence in the middle fossa, and this tumor was approached by the middle fossa extradural excision of the tumor. This is post-op. After I left, there was no follow-up, but patient survived for at least 5 years. This is one retrosegmoid approach, but in fact, retrosegmoid approach is not used for the chordomas, but it's some kind of a posterior petrosal approach because it is an extradural tumor. So this is one patient who has come with multiple cranial nerve deficits and tumor arising from here. And this is MRI shows a very large tumor. And this is, we have approached through the retrosigmoid, and this is postoperative MRI shows almost near total excision. Patient had a tracheostomy, which we did at the time of surgery itself at the end. And she was on the nasogastric tube, but everything has been removed. She had a very good recovery from this surgery. This is one more patient who had a lower clival chordoma, and this was in 1997. And we operated by the far lateral approach, and this is a post-operative CT scan, and this is a direct access it gives to reach to these tumors. And these are the follow-up MRI. This was done in, I think, 2002. So from 1997 to at least 5 years, she didn't have any recurrence. She also had a lower canal deficit. She remained on a tracheostomy. She remained on the nasogastric tube, but and she compensated. She recovered, and these were all removed. So this is our limited experience. This is according to location extensions. We had 17 tumors. Excepting these 2 tumors, I have excluded cervical. One patient had a cervical chordoma, and one was sacral chordoma. These are the different approaches we have used in these patients. Mostly our approaches were extended frontobasal and the extended middle fossa approach and transpetrosal. So coming to the conclusion, treating skull-based chordomas is a challenge. Radical surgical resection using one or more approach greatly improves the chances of long-term recurrence-free survival. And the adjuvant radiotherapy or SRS or now proton beam therapy is considered for the residual tumor, which helps in controlling these tumors. Thank you very much.
Thank you, sir. Next up, we have the recorded talk from Professor Dwaraknath Srinivas on four lateral approach to foramen magnum meningioma.
Good afternoon. I would like to thank Professor Ghosh for inviting me to speak on bilateral approaches and also apologize for being unable to attend in person because of leave denial due to vacation at our institute. So I'll be speaking on far lateral approach and its various modifications. So the far lateral approach was first developed by many pioneering surgeons from Heroes to Fukushima. And basically, it contains a retrosigmoid and a C1 laminectomy, unroofing the foramen magnum and extending as lateral as the occipital condyle. Now, depending upon the occipital condyle and the unroofing of the vertebral artery, dissection, etc., it has been divided into multiple other approaches, which includes the extreme lateral retrocondylar approach, partial transcondylar approach, transtubercular approaches, and transfacetal approaches, which minor modifications. So the whole idea is that this approach is used for those tumors or aneurysms or vascular lesions in the lower clivus foramen magnum area situated anterior and anterolateral to the brainstem. Of course, we need proper radiological investigations. The position is true lateral because the C1, C2 foramina are close to each other and the vertebral artery is not stretched between the two foraminas. And of course, doing the above potentials. The important steps include identification of the vertebral artery. This is best identified in the vertebral groove of the upper surface of C1. Because the vertebral artery is surrounded by a venous plexus, you would need fibrin glue to stop this troublesome venous bleed. Of course, you need a Doppler to identify the vertebral artery. And you follow the vertebral artery all the way to the dural opening and dissect it. And then, if necessary, it can be mobilized. The craniotomy, of course, you do a small suboccipital craniotomy, remove the C1 arch, etc., and the dural. So, why is the drilling of the occipital condyle important? And that's because the more the occipital condyle is removed, more the chances of instability and more that you require a fusion to maintain the stability. So, what we did was, we had done this quite a few steps, and we thought, is it necessary to remove the entire occipital condyle in all surgeries? And so then we came up with this concept of the tailored far lateral approach, in which we expose the occipital condyle but drill as much as necessary. So, of course, this is the anatomy of the suboccipital triangle, which I'll be showing on this cadaveric study which we did at our institute. This is the skin flap, the trapezius, sternocleidomastoid. Then you dissect it out. You see the splenius capitis, semispinous capitis. And then you come to this structure, which is the superior oblique here, the inferior oblique, and the rectus capitis posterior major, which gives you the suboccipital triangle. And in this suboccipital triangle, you find the vertebral artery. And this is the C2 arch and C1 arch, and this is the vertebral artery. So now this is the anatomy of the suboccipital triangle, which is very important in the process to this, in this approach. So, unlike I mentioned, the vertebral artery exposure is very dependent upon identifying the groove of the C1 arch, because the anatomy changes of the C1 arch changes from a rounded structure to a flat lateral. So this is how you see, you can see that this is the groove of the atlas on the C1. And after you get a complete bony exposure, this is how it should look. The cervical cord is the vertebral artery, this is the occipital condyle, which is partially drilled, and the C1 arch which has been. So basically, it has this four modifications. One is the supracondylar approach, the partial transcondylar approach, the transcondylar approach, and the extreme lateral approach. So you can see in this cadaveric dissection, again, once the entire condyle is removed, you can see that you can go completely anterior to the brainstem. So this is a short video which will show you how we do it. This is a three-dimensional video, so I'm sorry for the double images. So this, you see, this is the most important step, in which you can see that the vertebral venous plexus and the vertebral artery is being lifted off subperiostally from the C1 arch. Then by sharp dissection, you should cut out the fibrous tissue and mobilize, identify the vertebral artery. You can see this is the vertebral artery here. So once the vertebral artery is exposed, you need to mobilize, you need to expose the entire course to identify where it's entering the dura. So here we are exposing that. We're taking out the outer covering, the sheath, and so some of the C1 arches is left behind. That's also being removed. I can see this is the vertebral artery here, and this is entering the dura over there. So you need to go anterior to the lateral to the vertebral artery. So this needs to be sharply dissected. And you can see once you have mobilized the vertebral artery here, what we're going to do is drill the occipital condyle, do an axial drilling, and try removing as much of the occipital condyle as possible, up to 30%. so that you do not destabilize the joint. This is going to be troublesome feeding in this area. So you have to use either 5-fibrin glue or some other fibrin sealants to get hemostasis. So you can see here the occipital condyle is drilled and the vertebral artery is exposed up till its origin. This is how it looks like in the vertebral artery. So if necessary, this vertebral artery can be mobilized. So you can see this 1/3 of the posterior 1/3 of the occipital condyle has been drilled. So this is a VA pica aneurysm, and this is where you need more condylar drilling when compared to the foramen magnum angiomas. This is slightly anteriorly and superiorly placed VA pica aneurysm, pica arching, where the aneurysm lies. So here again, the vertebral artery has been identified extradurally, and now the occipital condyle is being drilled. So you need to do extensive drilling of the occipital condyle, eggshell it, and then remove it. So some bits of the C1 arch, which is remaining, has been removed, and the vertebral artery is being skeletonized so that we can achieve good proximal control in extradurally. In the dura is open, the standard steps, the arachnoid is open, CSF is released. The lower nerves which come into the view are identified. Very important to preserve this. Otherwise, the patient may develop peripheral paresis. And the proximal vertebral artery is identified. So if you can notice over here, you can see this part of the bone is actually impeding the vertebral artery, impeding the proximal vertebral artery. This is impeding this visualization. So you can see only half of the vertebral artery is visualized. So it comes in way of the dissection. So we try doing some steps to see if we can mobilize the vertebral artery. Local nerves are dissected off. A sharp dissection, the aneurysm neck is being exposed. So then we take extradurable control and try delineating the aneurysm. But what I realized was that placing of a clip would be difficult because this bone is coming in way of the visualization of the entire course of the vertebral artery. So now what we do is, this is where the Taylor drilling comes into effect. Because the occipital condyle has already been exposed and kept, we don't have to worry too much about again doing extensive dissection. So all we do is to go back, is reflect the dura and drill out the rest of the occipital condyle as much as necessary. So now you can see that almost the entire vertebral artery width is seen, and this is the neck of the aneurysm. So you get a straight trajectory for placement of the clip. So again, we go out, place the extradural vertebral artery, place a temporary clip. Then come back, dissect the aneurysm further, take a long biometric clips, and place the vertebral clip, and then check the flow of the flow into the distal vertebrae. So we confirm the patency here and apply themselves. So you can get an idea as to how the tailored drilling of the foramen of the occipital condyle is done. Similarly, in foramen magnum angiomas, you get this beautiful view right on the top of the tumor if you go do a lateral approach. And again, the steps which I already described. So I'll just run through the video quickly. So again, you dissect, the steps are the same. You dissect away the nerves from the top of the tumor, principles of meningioma, devascularization, dissection, decompression, and then deliverance. So the tumor is being devascularized. Now the tumor is being dissected off. But what you will notice here is that the vertebral artery is straddling the tumor. So after the lower pole is removed, when you go to the upper pole, you need to actually slightly displace the vertebral artery. You can see the vertebral artery is straddling the tumor here. There's tumor here and there is tumor here. So you have to mobilize the vertebral artery and the key here. And then you do the rest of the dissection. These are the final picture of the tumor being removed. And what you see here, you can see the absolute angle of the approach in such that you can actually see the opposite vertebral artery. So it gives you an idea of how much of a good approach this is, where you can see completely anterior to the next. So these are some of the cases of foramen magnum tumors where we have had to do a paralateral approach. This is a tough case in which you can see bilateral vertebral arteries over here. So you do that. You need to do a bit of more occipital condyle drilling than when it's anterolateral. So these are some of the cases. This is a calcified tumor. There's another tumor, another one, another one. So we analyzed our experience with occipital condyle drilling depending on the tumor, and you could see that we had anywhere between little bit of occipital condyle removal to almost 30 to 40% of occipital condyle removal. And depending on the occipital condyle removal, it gives you an idea of the increased angle of approach. So it makes it more obtuse and allows you to get a closer view anterior to the breast. So this tailored dissection of occipital condyle is how we do it, because it avoids extensive upfront extensive condylar drilling. It has no instability. It gives adequate exposure to the foramen magnum. Tumor itself shows the way. While for VA pica junction aneurysms, more drilling may be required. Transposition of the vertebral artery is rarely required. So I would like to stop here and again thank Professor Ghosh for inviting me, and again apologize for my physical absence. Thank you.
With that, I'd like to call upon Professor Sanjay Behari for the final talk of the day on extreme lateral transcondylar approach with vertebral artery mobilization for foramen magnum and anterior clival lesion.
So good evening. The last talk, of course, so much has been said also already about the anatomy. So I'd like to tell you that, of course, by drilling the condyle, you go anterior to the foramen magnum. So this is the condyle. The hypoglossal runs, canal runs somewhere 2/3 and 1/3. So coming like this is the sigmoid sinus. Coming like this and drilling will get you to the anterior cranial fossa here. And so you see this is one extensive lesion, which is almost going to both sides of the vertebral artery. See the brainstem here. And it's quite difficult to actually approach it from one side. So you can give either a horseshoe incision or you can give a C-shaped incision. And then, of course, this is the suboccipital triangle from which you can see that this is semispinalis capitis, this is superior oblique, inferior oblique, and rectus capitis, posterior major and minor. You leave a small cuff here, and this is the occipital bone. This is the inferior part. And then you see the vertebral artery in its groove here. This is the C1 arch, this is the C2 arch, this is the lateral aspect. So you have to work quite lateral to what you think you are working on. And therefore, a dead lateral approach is most important. The other thing is there should not be any neck rotation. That's a very important point. And then you drill out the vertebral artery from the foramen transverse area of C1 and C2, and then you can mobilize it superior and inferior, and then you can drill the occipital condyle. So this helps you to drill the C1 lateral mass and the occipital condyle. You can shift vertebral artery superiorly or inferiorly and actually take it there. And once you do that, then you have the entire tumor. You see the vertebral artery is here. Look at the amount of anterior aspect you get. This is the cervicomedullary junction here. This is the tumor, and this is where the vertebral artery is. And important thing is when you push it upwards or downwards, you can actually, and you can take a dural cuff all around the vertebral artery. So this part of the vertebral artery is from C2 to C1. This part is above the C1, and this is the intradural part of the vertebral artery. You can actually mobilize the entire thing and take the tumor, and this is the cervicomedullary junction. You get a huge space anterior to the cervicomedullary junction. And this is the post-operative image of the same patient, and you can see that there is a drilling of the artery, and then you can see that the condyle has been drilled, and the patient who was almost quadriplegic with respiratory depression has become quite fine now. So now to show you a video of this another case where you see that there is an extensive tumor which is also encasing this vertebral artery on this side, causing cervicomedullary compression. And this is the contrast image, meningioma, which is more on one side, but is encasing the vertebral arteries here. You can see that they're right within the tumor. And what you have to do is to make sure that this is a horseshoe incision going from up to the midline to the mastoid on the opposite side. And then you get the trapezius and latissimus dorsi. This is the first level of your suboccipital. Then the second level is the semispinalis capitis and the longissimus capitis. This is lateral, this is medial. The third is the splenius capitis and the sternocleidomastoid both are here. So all of them you have to remove. And then you come to the suboccipital triangle. And in the suboccipital triangle, what you get is the rectus capitis posterior, major and minor, and the superior oblique and inferior oblique. And this is where the vertebral artery is on the C1 arch. You can easily palpate the C1 arch here. And this is the C2 spinous process that you see here. So you can actually see this arch, but it's not so important. And then there is the vertebral artery will always be covered by a fascia, and with a very simple dissection, it is just possible to completely mobilize the vertebral artery. And the important thing is that you have to make sure that you are at the C1 lateral mass here. You can actually palpate it with your finger. You can see where the lateral mass ends, and then you can follow the vertebral artery to its groove downwards. And this is just a simple process. It's not very difficult to do that. The C1, the foramen transverse area is deroofed, and the vertebral artery can just be mobilized. And there you can see the C1 nerve root there, which is superiorly. Now, once you mobilize the vertebral artery, then you can actually shift it wherever you want, whether superiorly or inferiorly, and you can actually drill the lateral mass. This is the C1 lateral mass. So you see that you can either drill towards the occipital condyle. This is, I'm just exposing the lateral mass of C1, and then here is the occipital condyle. So you can actually see that once you shift the vertebral artery, you can actually do a lot of work there. And this is the C1 arch being removed now and exposing the dura here. So you can see the dura is being exposed. And then a little bit of suboccipital craniotomy, and also taking a little bit of condyle here. So you see that by just mobilizing the vertebral artery, you can get a good exposure there, and you know where your vertebral artery is. Then the dural opening is done. You see the arachnoid. This is the superior part, this is the inferior part. And you see that this is the spinal accessory nerve. This is the C1 nerve roots. And the other thing is you see the arachnoid, and from the arachnoid, the tumor is exposed, and this is the pica here. So then you just go on decompressing the tumor. Initially, the space looks smaller, but as you decompress the tumor, the space goes on increasing. So you decompress, get it out, and there you see the vertebral artery now, intradural vertebral artery of the same side. And as you go on dissecting, you can actually go on mobilizing the tumor. This is the spinal accessory now. And so you go on mobilizing the tumor. And you've already seen the vertebral artery. You have a proximal control, and you see the vertebral artery there. And the tumor goes on coming in your view. And you've not even seen the brainstem there, but the entire tumor can be removed here. So there you see the pica here, the vertebral artery. You can see the basilar artery dividing into the two vertebral arteries, quite anterior to the brainstem. And then this is the last part of the tumor, which is just attached to the anterior dura, which you can also remove. And you can see that there is a little bit of fibrin glue there, a little Surgicel, and then you meticulously close it using fascia. So you see that this mobilization of the vertebral artery really helps. And now this is a post-operative image, which shows the complete tumor excision, and the patient did very well here. Now I'll show you another case. You see this is an extensive foramen magnum meningioma going to both sides of the midline. You see how much of compression it is, and you can see both the vertebral arteries, and the tumor is right there. And this patient had been operated by the posterior approach here. You can see the depression here, and the surgeon couldn't remove any tumor and then referred the patient to SGPGI. And this is the midline and horseshoe incision. This is the superior nuchal line. And of course, you see the trapezius and latissimus dorsi. This is the first layer. And leaving a cuff of muscles, then a dissection is done. And just dissection. And then we come to the splenius capitis and the sternocleidomastoid, and then the semispinalis capitis and the longissimus capitis. So once you do that, then you have the suboccipital triangle, which I told you about. And in this case, you have the suboccipital triangle, and now the rim of the foramen magnum, here the head is on this side, that is being exposed. And this is the rim of the foramen magnum, which is being exposed. And now going right up to the lateral edge, and just on the superior surface of the is the vertebral artery. You just palpate it and you can easily find it out. You can dissect it, and it is going into the, you can see how much, so this is the intradural part, and it goes like this and goes down like this. And so you can actually completely drill it and remove it. This is the C1 arch being removed. You can see the dura is here. Now, this is the, once you mobilize it upwards, then you can drill a lot of anterior part of it, C1 and C2. And then this is the occipital condyle, which can also be drilled. Of course, there'll be a little bit of paravertebral venous plexus bleeding, but that's okay. And this is the suboccipital bone, which is being removed. So this is the dura. This is the dura. So you can see, you get a large space. And the very important thing is you are actually making the incision quite anterior to the brainstem there. And there you see that this is the vertebral artery here, and this is the vertebral artery is being pushed backwards, the intradural part, and there you see the tumor attached to the brainstem. So this is the vertebral artery, there's a spinal accessory nerve, and just anterior to the brainstem, we're getting the tumor. And then there is a gentle dissection as you go along and go on mobilizing. It's very nice to just mobilize, and the tumor keeps coming in your view. Go on decompressing, and then you can see the opposite vertebral artery and the surface of the brainstem. Everything is going perfectly, and you're very happy about it. So excellent work being done, and you're very, very happy. And so now what I'm doing is decompressing the tumor, and then this is what happened. This was a recurrent tumor, and the vertebral artery got injured. And this is the exact view during surgery. So what we did was went on sucking, and of course we were and you see that there is vertebral artery there. And so now we put two temporary clips because we were working anterior to the brainstem, and we could see the vertebral artery, and we put temporary clips and took it. And then, of course, whenever we are operating on these cases, the side of surgery is determined by two things: which side has the non-dominant vertebral artery, and also which side the tumor is actually going towards. So we put these, one was first after the temporary clips were put, then we put permanent clips anterior to the brainstem. The other contralateral vertebral artery is functioning well. So you see that sometimes when the tumor is infiltrating and it's quite anterior, you get a lot of space anterior to the brainstem by using this thing. The tumor had been taken out, most of it, and the last part you see the rent on the vertebral artery. As a safety, we coagulated this, and then this is post-operative image. You can see the cerebellum, the brainstem, and this is the part from which this is the post-operative CT scan. And you see the clip here. You can see the clip. You can see the clip artifacts here. And this is quite anterior to the brainstem. And this is the sagittal image. You can also see the clip artifacts here on the CT scan. So you can actually work quite anterior. You get a lot of space there. You see the clip, it's quite anterior to the brainstem. The vertebral artery has been controlled and the suboccipital craniotomy has been done. And then the 3D image also shows the clip here. So this is the second case. And of course, we have a third case. I'll just, although I'm running short of time, but just for, it's only a 2-minute video. It's a very extensive tumor anteriorly. And of course, this was only one side and dead lateral and just went suboccipital craniotomy. I'll mount, of course, the muscles. You can always remove the muscles in one bulk so that this does not cause atrophy of the muscle. This is the C1 nerve root. This is the, this is the C2 nerve root, this is the C1 nerve root, this is the C1 arch, and this has been completely exposed here. And this is the head end, this is the foot end. So you see you can see the C1 nerve root, which leads you to the vertebral artery here. And so this is the vertebral artery, and it's always in a groove. It is not very difficult to remove it. You can actually palpate the entire thing on the C1 lateral mass, and it has a very constant course. It goes like this, goes through the lateral mass, foramen transversarium, and then comes medially. Yeah, just one minute more. So it goes like this, and then comes like this. And so what you have to do is to just drill this part of the lateral mass, deroove the vertebral artery. It's always in its facial canal. You just mobilize the vertebral artery. And as you go on mobilizing with suction, then the vertebral artery goes on moving. And the advantage of that is you can actually take it back and forth. So you see that this is the occipital condyle here. This is the C1 lateral mass. The vertebral artery is in your view. You can actually drill about 1/3, go quite anterior to the dura, and actually remove the tumor from there. And with these extensive tumors, it's very important to get as much space as you can. So this is the, you can see the view, and this is the occipital lobe, and a little bit of condylar drilling is being done just to make sure that we have enough space there. Now the dura has been opened. You can see the cerebellum, a small Surgicell. This is the spinal accessory nerve. This is the pica. These are the lower cranial nerves, the hypoglossal and the other cranial nerves. And you can actually get the tumor between these nerves. So you see that this extensive tumor creates space for itself. This is tumor here. And the cerebellum has been retracted a little, and you have the tumors between the spaces here. So a lot of space you get, and you can see the complete anterior dura. You can go on dissecting. And the most important thing is once you dissect, decompress very well, then you get a lot of space there. And as you go on decompressing, then more and more tumor comes in your way. The most important thing is till you have done an arachnoidal dissection, do not coagulate. And after you have done an arachnoid dissection, then you can shrink it and get more and more into your view. And so little by little, more and more tumor comes out. And then you can see the contralateral vertebral artery and the brainstem there. And of course, as Dr. Abida had said, that anterior spinal artery and all of them are the problem. So it's much better to get a lot of view here before you take it out. So this is the last part of the tumor, which has been taken out. And you can see now that once the tumor has out, you can see the complete anterior dura and the contralateral side. And as I angled the microscope, you can see the opposite vertebral artery there. So you can actually get a significant amount of space there. So therefore, to just conclude, this is the post-operative image. And to conclude that it gives you a direct access to anterior cervicomedullary junction tumor interface. You can mobilize and proximal control of vertebral artery. Sometimes you can do a simultaneous occipitocervical stabilization. And it provides a direct visualization of anterior midline and even the contralateral vertebral artery. Thank you very much.
Thank you, sir. And now, can I please request Professor Siddharth Ghosh, Professor Sanjay Bihari, and Professor Rajneesh Kachra to have a brief and concise panel discussion moderated by Professor Ashish Suri.
Thank you. I think it was a very challenging session, and challenging because it's a pre-dinner session, and but still the hall is pretty full. So that speaks high of the Water Dandy team. Congratulations for an excellent scientific program. We had very excellent lectures, a lot of controversies back to back, and Dr. Abida's presentation was excellent. And this I've already talked to her earlier. I think these presentations will continue, and one day, with your age, they will also finish. I think you should make them lifelong. I think it is very important that you should approach the National Board of Examinations and submit it to the library, a voice-based lectures, which will be actually a treasure for the 200 neurosurgeons passing out every year from DNB and MCH programs. And for both the INI entrance and then the PG NEET SS entrance, and for the exit exams, this will be vital. This is vital. And this is something which will never die. This was there 50 years ago when I joined neurosurgery. It will be there when many of the backbenchers become professors. And I think this is something, and because it requires peer review and all, but I think more than that, being NB, being a government organization, you can take endorsements from the societies, Walter Dandy chapter, India chapter, and NSI, the Skull-based society. I think have 5, 6, 7 societies and just submit it to them. I think that's a wonderful treasure. Coming to lectures, I think Dr. Ghosh's lecture on chordomas was very enlightening. It was an excellent video, a very strong message, a very strong message. People always see the primary surgeries. Secondary surgeries, recurrent surgeries for chordomas are very frustrating. These are very unpredictable tumors, very vascular. And at least whatever I have done in the recurrent tumors, I've never been able to achieve a gross total excision. It is very difficult. And I've always damaged the patient. I've always, in these cases, I've damaged some nerve or something or the other. And so the recurrence first surgery is the best surgery, though these are extradural surgery tumors, but still they're very frustrating tumors. They become very fibrous, unpredictable. More surgeries means less survival. Proton therapy till now is the best judgment. And the most important message for the youngsters at the moment till the future therapies are there, put a layer of fat. Whenever you're operating chordomas, put a layer of fat, prepare the abdomen and your thigh. When you even have even if a thing is a chondrosarcoma, still put a fat. It may still be a chordoma. And because this that is also what I learned after the proton center came in, and my patients good I put the fat in an endonasal approach, but most of microsurgical approaches we don't put the fat there. So I think this is something that we must do. But Kachra's Rajneesh Kachra's lecture was wonderful, yeah, and dissection of all the skull-based approaches for the chordomas. Well, because my wife is a neuropathologist, I take a lot of interest in oncology meetings, though it becomes boring at times. I attended the SNOW meeting last year at Vancouver, and chordomas are malignancies. These are very high-end malignancies, and they are to some extent, they're becoming non-surgical. And there's a lot of exome sequencing, a lot of molecular work is happening into that. And maybe another 10, 20 years, a lot of immunotherapy and targeted therapy and tyrosine and other inhibitors and all are going to come in. And I think we are going to see a lot of chemotherapy and targeted therapy into chordomas. Regarding the two controversies in far lateral approach, very beautifully demonstrated, both by Dr. Dwarkanath and Professor Bihari, that one said that you can measure the angle on the CT scan of the tumor and the anterior edge, and you can actually save mobilizing the amount of condyle drilling and mobilizing the vertebral artery. But Bihari nicely demonstrated the mobilization of the vertebral artery, and if it is required, it can actually become a blessing in disguise because you see the anterior surface of the tumor. But yes, it is a controversy. I think both the things are important. The study of the tumor on a preoperative MRI. If the meningioma is more ISO, you can still do away with less drilling and less mobilization of the vertebral artery. But if it's much more hypo and becomes very fibrous and very tough, and you can actually have to cut with your knives and scissors, you need more space. You have to work between the nerves. And like Dr. Goyal said regarding the facial nerve, I think the worst thing you can have is a tracheostomized patient post-operative. And bilateral clear nerve palsy. I have a patient who has bilateral nerve palsy. It is, she is improving, but it is very painful for the patient and the relatives. And second, I think we must not undermine the CT scan presence of the jugular tubercle. This is one area where we must actually, that anatomy is very important. I think we should learn that anatomy as that. Extradural drilling of the jugular tubercle actually helps. In some cases, in 10-20% of cases, you can do away with the vertebral artery mobilization, or you can see an extra space. Any other comments from the panelists and the speakers? And questions from the youngsters? Goel, anything regarding the it helps. Conventional radiotherapy, IMRT,
That's what I'm telling
we
you.
give gamma knife therapy. In
Whether-
AIDS, we have been giving gamma knife therapy.
Gamma,
It helps.
gamma knife is, there is a role for
But
gamma knife.
the world literature
Yeah.
who says the proton therapy 5-year survival is the best in primary or the recurrent cases. That is, but I think the immunotherapies and the targeted therapies will ultimately outrun them.
Another, if you want me to make a comment, I'd like to just talk on chordomas.
Yes, sir.
And what Dr. Siddharth Ghosh showed and also Rajneesh showed, that we attack chordoma. Attack. And Dr. Siddharth showed that he did multiple attempts to attack and remove the tumor as radically as possible, and he removed it, did a beautiful job. As you rightly said, that chordomas are aggressive tumors. Histologically may not be that aggressive, but otherwise behavior is quite unpredictable, to say the least. I have realized over the years that there are two tumors which have completely unpredictable behavior. One is chordoma and one is craniopharyngioma.
And petrocleval brain. The three. I can add one to the list.
Recurrence-wise, you see,
Yeah, recurrence-wise.
craniopharyngiomas and chordomas are both histologically
Benign,
quite
absolutely.
benign.
Absolutely.
But you do craniopharyngiomas, you do a radical resection, when it will recur, nobody knows. In one article of mine, and I wish that you read that beautiful sentence which I wrote, that when you do a chordoma, you can have such a huge exposure, panoramic, you are seeing the sixth nerve, you are seeing this, you are seeing that, you are seeing the artery here, and you celebrate the success of a beautiful. So I wrote in that article that before the celebration of success is not yet over, the tumor has recurred. So that is the extent of unpredictability of chordomas. Many people talk about radicality of resection, like you remove the bone involved by chordoma, you remove 1 centimeter of bone, normal bone around the chordoma. We saw the paper by Laligam Shekhar, I think you
It
showed.
doesn't happen, sir.
You see, these are all, myths and fancies,
Absolutely,
according to
absolutely.
me. What we should do is, also, we should be little bit understanding about the pathology in question. And we should remove radically. We should, one thing is, if you are becoming a conservative surgeon, you are not a real skull baser. You have to be an aggressive skull baser. But aggression does not mean that you go for cure. You cannot go for cure in these tumors. I was removing one chordoma, and then one Canadian doctor was standing behind me. He said, "Are you going for a cure?" I said, "What cure?" I mean, nobody can go for a cure. So we do our job and leave the rest upwards. And also this proton beam and all those things have been shown to have a good control this thing. Let us see how the things evolve over the period.
The only problem is that glioblastomas, the patient will not live, but these patients will not go to anyone else. Once you operate them, they'll always come, they'll only come to you again and again. Right, sir. Thank you very much. Any questions from the youngsters? Thank you. Thank you.
One more sentence, Ashish, if you allow me. When I give lecture on AVM, I say that AVM is the last chapter of neurosurgery, where your technique, your anatomy, your philosophy, your understanding of the patient, your understanding of your own skills matter. So that is the last chapter of neurosurgery. I also say that chordomas and craniopharyngiomas are unfinished chapters of neurosurgery. Just for the
further discussion, I came to know in last year only that is the Chordoma Foundation.
Yes,
There's a
yes,
very, very big Chordoma Foundation, which is run by the researchers are from the top institutes of the world.
I am the member of the foundation for many years.
Right. Thank you so much.
Thank you. And Siddharth, thank you for organizing all this.
With this, we come to the end of an extensive and brilliant day one. Thank you all for attending. We hope to see everyone tomorrow as well. Have a great night.
Tomorrow evening, there is a very important cultural event which showcases Northeast India's traditional dance and music. And there's a lot of effort put onto that. So we would request and invite all of you to make sure that it is time. Because the art